yes, doctor. It's perfect. Your voice is perfect.
Audible now? Okay.
Yes, audible, doctor. Audible.
Visible also? Perfect.
Yes. Just come little bit of front, doctor, so that people can see you properly. Yeah, little front. Yeah, that's all. That's all. That's all.
Okay.
That's all, doctor. That's all. That's all. Perfect.
Yeah, I'm
Perfect,
using the desktop actually. I'm comfortable.
doctor. Okay, okay, no problem, doctor. This is fine, doctor. I'll just show you. I'll just show you the screens once again.
Okay.
So Rishu is there, doctor, who is your host, who is going to
Rishu
introduce
Vidati.
you.
Hello. Hi, Rishu.
Good evening,
Yes,
sir.
yes.
Good evening, Rishu. Okay. Yeah.
So I'll just run through the first screen so that you both are clear. So these are the sponsors whom we have to thank you, which Dr. Rishu will do it, and Dr. Rishu will talk about the session which is coming up now, and then she will introduce the pharma who is sponsoring, and then she will introduce Dr. Gogoi, and from there Dr. Gogoi will start from these sessions completely.
Okay. Okay. So we'll have the questions in between.
Yes,
If
yes,
the
yes.
time permits. Okay.
Yes, yes,
Okay.
yes, yes.
Right. Thank you.
Thank you, Ram.
Thank you. So 5 minutes to go.
Yes, 5 minutes to go, doctor.
I got up. Yes. Yes. No, I got a mail also just now. I got a mail also. Okay. Right. I got up. Yeah. Okay.
फोन करिया मैं काले sequence और patient मैं एम से पहुंच गए कितने डेटा दिखे 13,000 12,000 13,000 into 14 divided by 15 12,630 ठीक है यार तो सस्ता दिखाई दे भी नहीं
Good evening, good afternoon, everybody.
Yes, good afternoon.
Good afternoon.
Good afternoon, sir.
Hi, good afternoon, everybody.
Good afternoon,
I
everybody.
think we will start in the sharp time, sharp 4 p.m.
Doctor, it's already 4 right now. So, should we start or should we wait for 1 or 2 minutes?
Hi, Dr. Jana.
Dr. Gogoi, good afternoon.
Good afternoon, Dr. Jana.
Dr.
Yes, sir.
Jena,
How
please, Dr. Jena, time हो गया, please start.
No, should I? Is it the right time of the myeloma session?
नहीं myeloma नहीं है. Now is the ITP, then followed by the myeloma.
ITP है अभी. Dr. Jana कहाँ से आ गया?
Now the ITP है, followed by the myeloma.
Okay, so the myeloma will start at about 5 o'clock.
Yes.
And
Five.
so that is my. I will be the session coordinator.
You,
ITP is concerned.
Dr. Jena give small introduction and.
Okay. That's fine. So should I start now?
Yes.
Okay. Good afternoon and welcome to this second day of our 5th annual Congress of Eastern Hematology Group Virtual Mall. So yesterday we had a very important and very fruitful session and discussion on hematological malignancies, including lymphoma, and both diagnosis and management is concerned. Then we had a very nice session on sickle cell disease where there are two international speakers. One was Kalpana Gupta and second was Dr. Kutler. And he was one of the important principal investigator for the SUSTAIN study, which has made the approval of a new molecule, crizanlizumab, for the uses of to prevent the vaso-occlusive crisis, and the attendance and participations were very excellent and well appreciated. Now I will, on behalf of Eastern Hematology Group, all the organizing team, I welcome to the second day of this annual Congress, 5th annual Congress. full of, we have now 3 or 4 sessions. One the ITP, multiple myeloma, acute leukemia, and then the last session will be on hemophilia. Very interesting, very practical problems. I am sure the speakers are very excellent. We have 2 international speakers, and this is very fruitful. And I welcome all of you and wish you a very fruitful day of academic interaction. So with these brief introductions, I welcome again and invite you to join in this second day of the annual Congress of Eastern Hematology Group. So over to the organizer now.
Good evening, everyone. Welcome to day 2 of Eastern Hematology Group Conference, sponsored by Novartis, Intas, Janssen, Astra, Bharat Serum, Takeda, and Plasmagen. So the first session for today is immune thrombocytopenia, and session coordinator will be Dr. P.K. Gogoi, sir. This session is sponsored by Intas. So now I would like to welcome Dr. P.K. Gogoi, sir, who is currently Director, East India Hematological Center, and was ex-professor and HOD of Clinical Hematology, Guwahati Medical College. Sir, kindly proceed.
Thank you, Dr. Ishu, for your kind words. And good evening, everybody, and welcome to the second day of the Eastern Hematology Group Congress 2020. So at the outset, I would like to thank the organizers for asking me to coordinate this session on immune thrombocytopenia, ITP. ITP is an autoimmune mediated conditions that results from antibody-mediated destruction of platelets and impaired megakaryocyte platelet productions with a marked heterogeneous pathophysiology, resulting in clinical variety and unpredictable treatment response. Each patient requires an individualized treatment plan that take into consideration into platelet count, bleeding symptoms, health-related quality of life, and medication side effects. Today, in this session, we have got 2 eminent speakers with us, Dr. Pranter and Dr. Rahul, to speak on ITP, and a panel discussion which will be moderated by Dr. Vasav Bakshi with panelists Dr. Sumit, Dr. Sajia, Dr. Jivan, Dr. Ankit, and Dr. Manisha. So on the first talk, our first talk is on the treatment of refractory ITP, which will be delivered by Dr. Pranter Chakraborty, who is a professor and consultant senior hematology of Fortis Hospital, Kolkata, Vivekananda Institute of Medical Sciences. Now, may I request Pranter to deliver his talk, please. Pranter, please.
Yes,
I'm showing.
they will play. This is not live, so they'll play my speech. Thanks, sir, for the kind word. Yeah.
With a very beautiful background.
Yeah. It's a pleasure to speak at the annual conference of the Eastern Hematology Group. And in this new world, we are all virtual. And I've been given the task to explain the management of refractory ITP. Now, the most important question first which comes to your mind and to others is, what is refractory ITP, right? So if you look at the definitions and disease states of ITP, if you look at the consensus and the ASH, you'll see that patients who have failed splenectomy or relapse thereafter and have severe ITP or have a risk of bleeding that requires therapy. So essentially there are 4 aspects. Let me tackle them one by one. First is, that means without splenectomy, I can't call a patient suffering from relapse ITP. But we know there are several challenges in undergoing splenectomy because there's an increasing reluctance to undergo or recommend splenectomy amongst patients and physicians. Moreover, if other treatments have been ineffective based on not the well-documented evidence, but widely believed consensus, people feel that splenectomy will also not work, right? So that becomes a major issue. So refractory term for today's discussion, let's say, and I quote Professor Basel and others, is whose platelet counts do not respond to more than 2 treatments. There is no single medication to which they respond, be it n number, but when you use them singly, it don't work. And their platelets are very low. And most importantly, it's accompanied by bleeding, because you know the dictum always is, do not treat the platelet count, treat the patient. So defining refractory ITP as no response to treatment is entirely subjective, but I can't do anything about it. But what we have to understand is, do patients with refractory ITP behave differently? Well, actually, they feel miserable. You have seen it also. They respond poorly to a variety of treatment. They develop worsening disease and medication-induced toxicities, because the more drugs you use, more toxicities. And most common reason is obviously prolonged steroid usage, the Cushingoid habitus and all sorts of problems. And it has been documented that they have a markedly reduced quality of life. So whether you call them severe, chronic, refractory, or very difficult to treat, they have a higher hemorrhagic and infectious morbidity and mortality. Mind you, it is important. We always counsel our patients that your chance of dying due to bleeding is very low, but not in this population. And they require vigilant care because of their substantial risk for serious hemorrhage, especially as they grow old. And why does this occur? Because there is absence of the tonic growth factor nourishment from the platelets to the endothelium, which make it very important to stop the initial part of bleeding. And the endothelium becomes fragile and it permits more and more hemorrhage, which leads to the complications. Now, once you have understood that they are different from the baseline, and I'll show you some data regarding it, are all patients with refractory ITP the same? Well, who hides behind this refractory ITP? And this is from a February 2020 article. I recommend you to go through it. Actually, 50% of them are not primary ITP. They can be secondary, they can be inherited or acquired bone marrow failure syndromes, they can be MDS, or it may be drug induced. So, whenever you label a patient as refractory ITP, the first thing you need to do is again reconsider your diagnosis. What happens in the real world? So, here is this study, so many people together, they got 37 multiple refractory ITP patients, of which initially they thought that 65% of them are primary, rest were secondary, like definite autoimmune disease or even malignant hematologic disorder or CGD came out. But out of this primary ITP, there was monoclonal gammopathy in 7, and there were isolated biological features of underlying autoimmunity, like a positive Coombs test or ANA. So ultimately, if you see, 50% of those 65% also were not correctly labeled as primary ITP. So there were features of underlying autoimmunity, be it biological or clinical, in almost 60%. So previously I told you 50%. In the real world, we see that 60% of your refractory ITPs are not ITPs, right? And then for sake of completion of this study, I'll show what they did to them. But first I'll show you is, look at the deaths, right? Out of 14, 2 deaths. Out of 8, and then you get another 4 from this group, 3 deaths. Now this you do not see in primary ITP. And if you try to make sense of what they wanted to do, they tried to giving TPORAs, which my friend Dr. Rahul will discuss, and immunosuppressant therapy in combination, or TPORAs and supportive IVIG and corticosteroids in combination. So what we learned from this study is that even the baseline characteristics of multi-refractory ITP differed from a typical ITP. So if we get a biomarker, there is no definite diagnostic marker of ITP as of today. We have to identify these multi-refractory ITPs from the beginning. The outcome was severe and was associated with high morbidity and mortality. So combining immunosuppressive immunosuppression therapy with a TPO receptor agonist may be a relevant option. I'll discuss this when I come back to the treatment. So the most important question is, why is refractory ITP refractory? And there have been thousands of pages written on it. But if I summarize it in one slide, then what do we see? The antigen and the epitopes keep on spreading. So you think that, okay, this particular platelet antigen is the antigen, it might change. And when these new antigens develop, there are antibodies developing to them. And measuring antibodies are never a standard of care. So you're in a soup. On top of that, initially we know that it is primarily antibody driven. But when it persists and becomes refractory to your eyes, it actually becomes a T cell driven disease. There are multiple clones and it's a clonal driven disease. There is a lot of data on it. You can go through it. Then there comes clonal expansions, and that makes the task more difficult. Moreover, you can have long-lived plasma cells in the spleen when the antigen has disappeared, but these plasma cells continually tell the B cells and others, go on, kill them. So the platelets keep on getting killed. Moreover, whatever drugs you use, especially even your TPO receptor agonist, there can be an upregulation of drug efflux pumps. So it gives resistance to the drugs which you are using. Some of them, without you knowing, can evolve into MDS. So that is another issue. And we, fortunately for us, this is, I think, the only fortunate part in our advanced biology, that we have now novel targets and we have novel targeted inhibitors for mTOR, SYK, FC, and Bruton tyrosine kinase. How this play a role is beyond the scope of today's discussion, but I'll show you the data. So ultimately, how do you manage refractory ITP, right? Now, I have purposely given this flow chart. I know it's a busy slide, but look at this. When a patient presents with isolated thrombocytopenia, this is what we do. There are certain optional tests, immunoglobulin levels, because you want to rule out CVID and other diseases. So not supporting for ITP, supporting ITP, more platelets more than 30,000, no observation. First line, you either use steroids or IVIG or anti-D if the spleen is in fact intact. Response, not refractory. So IVIG was not given before, you use it. Response, not refractory. Repeat initial evaluation, and at this point of time, if you have not done a bone marrow earlier, you should again look at it if they fail to respond steroids or IVIG or both. And it might be that it is not ITP. If they respond to TPORA agonists, then it is not refractory. So again, your patient goes on. You see it is compatible with ITP. You go on using other agents, and this is where the agents which I'll discuss today are rituximab, immunosuppressive, fostamatinib, and splenectomy. But if it's not ITP, then obviously they go out of your ITP level. Problem is, if these drugs do not act, and by definition, if splenectomy does not act, then it is refractory ITP. And what do you do there? You do an extended workup, right? So I'll show you the table, but there are certain things, even, genetic testing for Wiskott-Aldrich syndrome. And then you can use combination therapies if you're still convinced that it is ITP, because there's a high chance that 50% of this will not be ITP. Remember this. So you should do a CBC with differential, and you might even diagnose leukemia by doing a bone marrow. If you look at the reticulocytes, you can even get Fanconi. The peripheral blood can tell you whether, there are certain RUNX1 heterozygotes or Wiskott-Aldrich. Why immunoglobulins? Because to rule out CVID and Wiskott-Aldrich. Hepatitis C has to be ruled out. Infections have to be ruled out. And look at the whole genome sequencing versus specific panels. Is it possible? Tell me. But these are the recommendations, because if they come as positive, and I have recently seen that there was a mutation where there were no morphological changes, but it was just like megakaryocytic thrombocytopenia, and the mutation was there, and the patient had to be taken off for transplant. So you can do certain other things, but I'll not go into the details of those for ruling out squashman, diamond, or others. So what is your multi-target approach? You can do something to increase the production. You can keep them for a longer time in the circulation. You can prevent sequestration. You can prevent destruction, right? And that is our aim. And that is what we are trying to do. So if you look at the older studies, I know some of these options are obsolete, but they are worth mentioning because we used all sort of chemotherapies like CVP, CMOP, CEP. Then you used even vincristine to manage these patients. They would have responded, might not have responded. But what we are doing now, post TPO era, is adding anything and everything to TPOs RA agents. So you can add danazole, you can add cyclosporine A, you can even add prednisolone, cyclosporine, rapamycin, and obviously rituximab. And there is a concept of rituximab maintenance coming on, which you think if you want to discuss, I'll discuss later. So basic aim today is adding immunosuppressants, and the new kid on the block who is playing quite well is mycophenolate mofetil. But can you imagine? People are using Atra. People have gone back to cyclophosphamide. So this Atra story is also, quite interesting. I can discuss it later. But the response, 62%, 25%, it's anything between 20 to 60%. But this is the last part of my talk, and I'll talk about the novel agents. Obviously, IVIG is not novel. This will be discussed by Rahul. But imagine, when we started using bortezomib, we had to hold certain doses because of thrombocytopenia, right? And we knew bortezomib actually prevents the release of platelets from megakaryocytes. Now we are using it in ITP. We are using BTK inhibitors like ibrutinib, acalabrutinib, zebrutinib, and rituximab is our old friend. So many doses, so many ways. So I'll just discuss 30 seconds on fostamatinib, which actually is a prodrug. It targets a previously unexplored mechanism inhibiting FCR-triggered SYK-dependent cytosolital rearrangement during phagocytosis. This is novel, right? So if your IVIG is not working, you can add to it, and they have shown certain actions. And if I benchmark fostamatinib with others, obviously whatever data is there, we see that splenectomy can have 80% overall response. But when we're talking of refractory ITP, we are presuming you have done splenectomy, right? And time to response 1 to 24 days. TPO mimetics 2 to 3 weeks. Here it is 43% overall. It takes 2 to 8 weeks, and probably it has to be continued indefinitely. So obviously more and more trials are being conducted in combination, not alone usually. And then why does bortezomib act? Because they might deactivate T and B cells, decrease their migration and adhesion, and they can restrict the antigen presentation, which drives the immunological phenomena. I think in the next few years, you'll hear a lot more about bortezomib. And this is one phase 1-2 study of a BTK inhibitor, where it actually was active in 33% of ITP patients who are refractory to multiple treatments with no alternative therapeutic actions. And obviously playing with the B cells, you'll understand that we might combine this with TPORAs. We might do anything because we are desperate to save lives. So at the end, ladies and gentlemen, let me confess, we are the blind men as far as the refractory ITP elephant is concerned. Some of them develop because of peripheral tolerance. They actually, like most of the childhood ITPs or CMV induced, varicella induced, H. pylori induced, they can resolve spontaneously or with definite agents. There are problems in differentiation in CLL, in immunosuppression therapy, they are fine. But when we are looking at ITP, it might well be antiphospholipid antibody syndrome, it might be SLE, it might be ALPS or even syndrome. So the most important thing you need to do is you have to open your eyes. Do not label a refractory ITP as ITP unless you see the whole story. Do not miss the forest by looking at a single tree. Thank you very much.
Thank you, Professor Planter, for your very nice and elaborate talk on treatment of refractory ITP, which are very nice. I don't think any questions now. So I think we can go to the next talk, which is on role of TPO agonist in thrombocytopenia, which will be delivered by Dr. Rahul Nathani. Rahul is a director and head, Department of Hematology and Bone Marrow Transplant, Max Super Specialty Hospital, Saket, Delhi. He is a major achievements Best Reviewer Award 2017, Best Poster Award, European School of Oncology. He has got more than 100 publications, both in national and international journals. Associate Editor, Indian Journal of Hematology and Blood Transfusion. Now, may I invite Dr. Rahul to give his talk. Dr. Rahul, please.
Thank you, Eastern Hematology Group, for giving me this opportunity. The topic for me today is the role of thrombopoietin receptor agonists in management of immune thrombocytopenia. Over next 12 to 14 minutes, we'll learn about the various clinical aspects of these agents. So as we all know that there are several agents approved for use in immune thrombocytopenia, and the prednisolone, dexamethasone, IVIG, NTD are the usual agents that are used upfront in these patients. And there are several other agents of which India has enough experience of different kinds of agents. Now, if we go by the ASH algorithm, if a patient has received initial treatment and has not responded or is still dependent on agents, and at 3 to 12 months, there are two primary treatment options which are available. One is rituximab and second is the thrombopoietin receptor agonist. Now, the guidelines would suggest, and in clinical practice also, we would want to assess the patient's values and preferences. And depending upon those patients' values and preferences, we use either rituximab or thrombopoietin receptor agonist, or for that matter, any other agent. Now, in clinical practice, what does patient value and preferences actually mean? So this could be the fear and anxiety of the low platelet counts, the acceptance of a low platelet count, tolerance of minor bleeding, so somebody may be panicked with even an epistaxis happening once in a while. The activity level, somebody may be lazy, somebody may be very active where they may actually need a higher platelet count. Acceptance of chronic therapy for their treatment, because ITP could be a lifelong condition for them. Patients may have a desire to avoid corticosteroids. They may want to avoid surgeries, or they may want to go for surgery. They want to just get it all over. Let's do this splenectomy and be done with the thing. Patients may have a desire for pregnancy. Now, once we are analyzing these patients' values and preferences, we have to keep in mind, as always, that the patient assessment for these is more important than the physician's assessment. Now, the two agents which are approved are eltrombopag and romiflostim. I'll talk about the mechanism of action of these agents in brief. Now, romiflostim is a direct agent. It directly binds to the receptor, while eltrombopag binds to the transmembrane domain of this receptor. Now, if we have to compare these two agents, we will see that eltrombopag is a small molecule, while romiflostim is a peptide which is developed by screening the peptide libraries. The binding site we have already discussed. It does not displace endogenous thrombopoietin, while romiflostim could displace TPO. The downstream pathways for eltrombopag after binding is the JAK-STAT, the PI3 kinase, and the ACK pathways. While for romiflostim, the downstream pathways are JAK-STAT, PI3, ACK, and STAT3 pathways. Now, an important difference between these two agents is that romiflostim largely works on mature megakaryocytes, while eltrombopag can work in earlier megakaryocytes and late megakaryocytes both. Also, one mechanism of action, the ion chelating, this is an off-target effect of eltrombopag. This ion chelating action of eltrombopag actually could lead to anti-proliferative effects of leukemia cell line, and it also causes thrombopoietin independent effect on stimulating the stem cell and megakaryocyte precursors in vivo. Now, both these receptor agonists have been described to have immunomodulatory effects also. They can increase regulatory T and B cell effects in these patients, which is largely mediated by the TGF-beta, a major cytokine which is involved in the T regulatory cell development. And it is this cytokine is found in abundance in megakaryocytes and platelets, both. I will further discuss about this at the end of this presentation. Now we'll talk about the efficacy of these agents. I don't think anyone has any doubt about the efficacy of both the agents. There are several studies which have been published. These are the larger published studies on romiplostim, where one would see the effect of 88%, 71 to 90%, 95% response rates in romiplostim. Similarly, in eltrombopag, the treatment durations have varied from 6 weeks to 6 months. And the 80%, the 59% resistant one, 79% and 60% response rate. So we know that these agents are effective. They work in increasing the platelet count and reducing. Now, if I was to summarize these, the recent meta-analysis, which included 1,126 patients from 13 randomized controlled trials, there were 8 adult and 5 pediatric ITP populations. Now, TPO receptor agonists significantly increased platelet responses by 3-fold, and the durable response rates by almost 8 times as compared to the placebo or the standard of care. Now, obviously, patients do discontinue therapy. Now, in the extent trial for eltrombopag, 55% of the 302 patients withdrew. And the reasons for withdrawal were adverse effects in 14%, patient decision 13%, lack of efficacy in 11%, and other reasons. Similarly, in a long-term romiplostim study, 31% of the patients discontinued, and the reasons for adverse effect in 12%. Patient decision was a big contributor here, 27%. Alternative therapies in 12%, and other reasons. Now, one aspect is the improvement in the platelet count, but the other aspect is reduction in the bleeding and concomitant medication. Now, again, if you go by this meta-analysis, we have seen that the thrombopoietin receptor agonists significantly reduce incidences of any or incidences of severe bleeding events. These results also suggest a significant reduction in the need for rescue medications in these patients. And these studies have also suggested that these agents have been able to reduce or stop concomitant medications if they were on. So overall, these receptor agonists are active in increasing the platelet count, they are active in reducing the bleeding event, and they are active in reducing the concomitant medication or the rescue medications required for these patients. How do we dose? How do we start? Now, this is important to know. For eltrombopag, the initial starting dose is 50 milligrams per day. If we do not see any response by 2 weeks, then the dose is increased to 75 milligrams per day. Now, we should remember that for ITP, the maximum licensed dose of eltrombopag is 75 milligrams per day. For romiplostim, the schedule is slightly different. Now, the product insert says you start with 1 mics per kg and then increase the dose by 1 microgram every week, and it will take up to 9 weeks to reach the maximum dose. Practically, what we do is we start with an initial dose of 3 micrograms per kilogram per week, or round it off to the nearest vial, which is 250 micrograms. If there is no response, then we increase it weekly to 5 mics per kg, then 7 mics per kg, then 10 mics per kg. And again, as per the license, 10 micrograms per kilogram per week is the maximum dose for romiplostim. Now, children tend to need higher dosages, and many children in these trials have needed eltrombopag up to the 75 milligrams, and many children have required romiplostim at the higher end of 10 mics per kg of romiplostim. Now, switching of TPO-RA. Now, switching of TPO-RA from one class to another has been surprisingly effective. There was a study of 46 patients where 80% of the patients who did not respond to eltrombopag eventually responded to romiplostim. And 46% of the patients who did not respond to romiplostim, they responded when they were started on eltrombopag. This is important to know because there are situations where somebody may be responding, but maybe having fluctuating platelet counts or maybe having an adverse effects. Then we know that the switching to another agent may help these patients. Safety is an important aspect of any medicine. And yes, there are potential adverse consequences of these agents. Thrombocytosis, we all know. Thrombosis risk is there. There are concerns about the stimulation of leukemia cell growth. Autoantibody formation is generally exclusively to romiplostim because of this peptibody nature. Elevated LFTs are basically concerns of eltrombopag. There's another concern with eltrombopag, which is cataract. Even in children, cataracts have been reported. There can be a rebound worsening of thrombocytopenia. And of course, a major concern had been an increased bone marrow reticulin. So I'll talk about the bone marrow reticulin first. Now there is enough data available that in follow-up, the bone marrow reticulin generally is not bothersome. If I have to talk about the largest studies of these published, the 162 patients, And if we see that at the 1 year of the treatment, 69% of the patient had MF0 and 28% patients had MF1. Very few had MF2 and MF3. Now, when we compare it with the baseline, 85% at the 2 year, 85% patients had MF0, 9% patient had 1 grade increase in myelofibrosis index, 2 patients had 1 grade decrease, and 1 patient remained on MF1. None of the patients had grade 2 or grade 3 increases. Nowadays, practically no center does bone marrow biopsy unless somebody is on a research protocol to look for reticulin. However, if a bone marrow biopsy was performed for whatever reason and reticulin 3 or a collagen fibrosis is discovered, then TPO-RAs need to be discontinued. Also, with MF2, a patient may actually continue TPO-RA, but this is the population where one may want to repeat a biopsy 6 months down the line to see if it has progressed or not. Thromboembolism is an important adverse effect of this medicine, and the annualized incidences of venous thromboembolism are about 0.41 to 0.67 compared to patient controls, which is 0.28 to 0.4. Similarly, annualized incidences for arterial thrombosis are about 0.96 to 1 compared to 0.67 to 0.9 in controls. The data suggests that of all the thromboembolic events, less than 20% resulted in permanent disability, and only 3 deaths could be attributed to this thrombosis. But then, yes, it is an important concern. This is the data on romiplostim and eltrombopag, where they annualized all thromboembolic events per 100 patient years. And for romiplostim, the numbers are 4.1 to 7.5. And for eltrombopag, this number is around 3.4 per 100 patient years. Now, annualized thrombosis rates in the adults are 2 to 3 times higher in patients who are treated with TPO-RA versus ITP patients who are not treated with TPO-RA. And even in this population, it's higher than the non-ITP control population. Now, the basic clinical features can help us decide whether or not to start on these agents. If a patient has previous thromboembolism, has a history of splenectomy, previous antiphospholipid antibodies, concomitant medications like oral contraceptive pills, or other risk factors for thrombosis like obesity, hyperlipidemia, diabetes, then one needs to be cautious about starting these medications. Now, surprisingly, the thromboembolism events are not associated with thrombocytosis. In fact, 30 to 50% cases of these events have happened in patients who had lower than normal platelet count. Also, contrary to the popular belief, the thromboembolic events are not associated with higher doses of thrombopoietin receptor agonists. Most of these events tend to happen in the first year of treatments. Now, once we have achieved a treatment, the further goal is always, can we get a treatment-free remission? Can these patients go off these agents, or can these drugs be tapered? Now, in mechanism of actions, we have talked about that the ITP is basically a misbalance between the TH1 and TH2 subtype. Now, thrombopoietin receptor agonists basically increase platelet count, and these platelets secrete a lot of TGF-beta. This TGF-beta leads to increased T regulatory activity, decreased macrophage activity, and it modifies the differentiation and maturation of the antigen-presenting cells. This does have immune modulation induction, and this can basically shift the balance towards the TH2 subtype instead of the TH1 subtype. And once these happen, patients could go into a longer remission. Now, there are few published data on patients on the able to go off these medications. A study of 302 patients these agents. Now, going by the expert panel recommendation, it is presumed that in clinical practice, approximately 40% of the patients who are on TPO-RAs could undergo tapering. Now, tapering can be performed if 2 criteria are met. One, the patient should have stable platelet count, preferably above 50,000 or 1 lakh. And the response has been maintained for at least 6 months without any rescue medication or any other concomitant treatment or any bleeding events in these patients. So a stable platelet count of 50,000 to 1 lakh and stable for 6 months or more without any other support. Now, how do we taper? So for eltrombopag, it is recommended that we should reduce the dose by 25 milligram every 2 weeks. And once we reach the 25 milligram dose, we have done those 2 weeks and platelet counts are stable, then we do eltrombopag 25 milligram every 4 days before discontinuing it. For romiplostim, it is basically the dose reduction by 1 mics per kg every 2 weeks till we reach the dose of 1 mic. So if somebody was on 3 mics per kg, then we make it 2 mics per kg, then 1 mics per kg. And once we have been on 1 mics per kg every week, then we make it alternate weeks for 2-3 times. And once we have been on alternate weeks, well, then we make it every 3 weeks, and then we consider discontinuing these medication. Now we should remember that tapering of this medicine is not recommended if platelet counts had been less than 30,000 or platelet counts were less than 50,000 associated with bleeding event. If somebody was requiring maximal doses of TPO-RAs to maintain platelet count for a very long duration, these are not the candidates for drug tapering. If there are other comorbidities which could impact the quality of life, or if there are other concomitant therapies being administered, then these are patients who are not candidates for drug tapering or drug-free remission. Now, there have been other uses of TPO receptor agonists. It was approved for hepatitis C patients who were receiving interferon and ribavirin. Now, this is a rarity with the invent of sofosbuvir. Many off-label uses of TPO-RAs have been done in patients of chemotherapy and thrombocytopenia because of chemotherapy. There is a data to suggest that L-Trombopag restores the graft function post-bone marrow transplant in patients who had poor graft function. There's also data to suggest that MYH9 related disorders and Biscott-Eldrick syndrome patients, they do benefit from L-Trombopag. There are two other TPO agonists, avatrombopag and lusotrombopag, which are approved for patients with liver diseases related thrombocytopenia prior to any invasive procedures. These are not available in India as of now. With this, I would want to thank all of you and close this session. Thank you.
Thank you very much, Dr. Rahul, for your very nice talk. I think we can take 1 or 2 questions. So if there is nobody, can I ask one question, Dr. Rahul?
Yes, please.
Can you use this TPO agonist in pregnancy?
So surprisingly, there is no such data available. There are reports of somebody using it in first trimester and nothing bad has happened. But then again, we do not have concrete data available.
Okay. But I think there is some recombinant TPO, which is some data they are using in pregnancy. I'm not
so
sure.
Recombinant thrombopoietin is actually widely used in China, not outside. And they use it during pregnancy also. But then, we do not have data outside of China for this use.
Thank you, Dr. Rahul.
Thank
you. So next in the agenda, we have got panel discussions. Over the last decade, there have been numerous developments and changes in treatment practices for management of ITP. The topic of today's panel discussion is immune thrombocytopenia, what is new in 2020, which will be moderated by Dr. Basab Bakshi. Dr. Basab, he's an assistant professor. Sorry. No, I can't see the slides. Yes, okay, sorry. He's the assistant professor, Department of Medical Oncology, Hematology, all in.
तू co-host तब बना जब ये खत्म हो जाए, पहले मत बना, ये गांडू है साले सब।
अब सुन, मेरे को उनको co-host अगर नहीं बनाऊंगा तो वो बोलने लगे कि I cannot share the screen.
Sorry, some disturbances in. So he has got a lot of publications both in national and international journals. He is a member of Indian Society of Hematology and Blood Transfusion and member of British Society of Hematology, PSAs. So he will be the moderator for these panel discussions along with the panelist, Dr. Sumit Mitra. Can you show me in the screen? Please share the screen. Sumit is the consultant hematologist at NIH Medical College. Yes, next, please. And Sajia Gulshan, consultant hematologist and hemato-oncologist, PLS Hospital, Kolkata. And another panelist is Dr. Jeevan Kumar. He's a senior consultant, Department of Clinical Hematology and BMT, TMC, Kolkata. Next is Dr. Ankit Jitani. He is a consultant in hematology and bone marrow transplant, Apollo CC Cancer Care, Ahmedabad, Gujarat. And next, there is Manisha Jain. He is Associate Consultant, Department of Hemato-Oncology and Bone Marrow Transplant, Artemis Hospital, Gurgaon. Now over to Dr. Basab Bakshi to carry on, please.
Thank you, sir. Thank you, sir. Good afternoon, everybody. First, I would like to express my gratitude to Eastern Hematology Group and special thanks to Tufan sir for giving us this opportunity. This session would be moderated by me. The topic is immune thrombocytopenia, what is new in 2020. Is the screen visible to all?
Yeah.
Okay. So I start with a case of a newly diagnosed ITP. A 24-year-old married woman named Ritika, mother of 2 kids, was referred from IGIMS, Patna. This is a regional cancer center in Patna with complaints of severe thrombocytopenia and bleeding. She was thoroughly evaluated. There was no history of fever. She had purpuric spots, ecchymotic patches, wet purpura, and gum bleeding. There was no organomegaly. She was negative for the viral markers. Her hemoglobin was 10 gram percentage. Total count was 12,000, and platelet was 2,000. Was very 2,000 per cubic millimeter, and peripheral smear was unremarkable except severe thrombocytopenia. Bone marrow aspiration showed only megakaryocytic thrombocytopenia. So my question to Dr. Jeevan Garg is that what are the causes of thrombocytopenia? How will you approach a patient with isolated thrombocytopenia, and what tests will you perform to confirm your diagnosis? Dr. Jeevan?
Yeah, thank you, Dr. Basab. So first of all, I am thankful to Eastern Hematology Group for providing me this opportunity. So regarding the various causes of thrombocytopenia, so we can broadly divide this into benign and malignant cause. And first, I will like to discuss the benign causes. In the benign, it may be infection, it may be acute infection, it may be chronic infection. In the acute, it may be Epstein-Barr virus infection or any other viruses. In the chronic, the most common infection may be due to hepatitis C virus or maybe HIV. Other causes may be nutritional deficiency like folic acid, vitamin B12, and other benign causes may be aplastic anemia or any drug-induced thrombocytopenia. The rare benign disorder may be due to autoimmune disorders like SLE, or it may be due to microangiopathic hemolytic anemia like DIC or CTP, and rarely it may be disease. And another syndrome, which is HPS syndrome, Harris platelet syndrome. This is commonly in the eastern part of the India. So the Harris platelet syndrome, this is a benign syndrome, and platelet count in majority of patients is more than 50,000, and patient is asymptomatic. And the rare disorders which can occur in adults, but in majority of children can present with thrombocytopenia are hereditary disorders like Wiskott-Eldridge syndrome, Bernard-Solder syndrome, or it may be Fanconi anemia. And in case of malignant disorders, so like MDS can present only with isolated thrombocytopenia, and other causes may be acute leukemia or maybe lymphoma, and the CLL may have autoimmune component, and CLL may cause secondary ITP. And Dr. Basab, what are the
thank you so much. Yeah. Now, how will you approach a patient with isolated thrombocytopenia?
Yeah, so before we are approaching to the patient, we have to rule out all these causes. So the majority of these causes can be ruled out with the help of history. So history is very important in case of ITP. It is more important than the investigation. So we have to take the history from how long patient has thrombocytopenia, and we have to take detailed history of bleeding, whether this bleeding looks like platelet bleeding.
Right. History, physical examination will have to be a bit concise, a bit fast.
Yeah. And in the history, 2 points should be asked. One is the drug history, and another is this family history. And in the physical examination, we have to rule out any hepatosplenomegaly or lymphadenopathy to rule out any malignancy. And in the investigation, the CBC and very good peripheral film examination. So these investigation can confirm the diagnosis of ITP. Actually, we cannot confirm. This is the diagnosis of exclusion. And other investigation generally we are not doing. In adults, we can do hepatitis C and hepatitis B and HIV to rule out the secondary ITP.
Has to be done.
Yeah. And bone marrow, generally bone marrow is not required in majority of cases. It is required only if patient has another cytopenia, like he has anemia along with thrombocytopenia, or some abnormal cells are seen in the peripheral examination, or in the examination patient has some hepatosplenomegaly or lymphadenopathy, then bone marrow can be decided.
Right.
Or if patient is not responding to treatment of ITP, then
or
it
even
can
before splenectomy.
before splenectomy or yeah. So if we are thinking of refractory ITP, then it should be done.
Okay. Thank you so much.
Yeah, thank you.
My next question to Dr. Manisha Jain is, how do you classify ITP?
Yes. Sir, ITP, thank you, sir, for the question. ITP is basically described either because of etiology. It is an immune response against platelets and megakaryocytes. So either it is associated with any autoimmune disease, then it is called a secondary ITP. When other autoimmune disease has been ruled out, it is primary or idiopathic ITP. Also, according to phase of the disease, IWG has classified according to the various terminology, like newly diagnosed ITP when the ITP is in the period of less than 3 months from the diagnosis. When the symptoms persist beyond the 3 months up to the 12 months, it is persistent ITP, while more than 12 months is chronic ITP. Refractory ITP is when the splenectomized patient develops symptoms requiring treatment.
Right. Thank you, madam.
Now, severe ITP, yes.
Next question is, what are the initial treatment options in a case of newly diagnosed ITP, and what would be your treatment goal?
So, whenever patient presents with, so is it I'm audible?
Yeah, right. Yes, yes.
So, whenever patient presents with a patient presents with bleeding symptoms, then he or she requires the treatment. The basically treatment depends on the severity of the bleeding. If there is life-threatening bleeding like ICH or mucosal bleeding or large hematoma, patient requires urgent interventions. Then in that case, we go for IVIG. In developing countries where resources are less, we can go for methylprednisolone 30 milligram per kg per day for 3 days, or even anti-D IV is also used. Rest patients, most of the patient responds to this treatment. Otherwise, steroids, depending on the age of the patients, is the treatment of choice. Dexamethasone, pulse therapy, or prednisolone 1 to 2 milligram per kg per day is the treatment of choice. In case of persistent and chronic ITP, we go for second line therapy. That I think will be
Okay. Thank you, madam. So we'll have to we'll think of starting therapy if the platelet count is below 20,000 or the patient is bleeding. The treatment, our treatment goal is that to keep a platelet count more than 20 to 30,000. Right, and so that bleeding prevention of bleeding, or so that bleeding
patient should not bleed. Yes, sir.
Should not bleed, and
platelet count is not the target of the thing, sir.
Right, and the therapy should be minimally. The toxicity should be minimal. Now, what should be the duration of initial corticosteroid therapy for a newly diagnosed patient? He was starting corticosteroid.
Hello? So depending on the age of the patient, right. Pediatric or
adult, I'm talking basically
adult
of
adult or pediatric patients. The adult patient, normally we give the dexamethasone pulse therapy 40 milligram for 4 days in the duration of 14 to 20 days, and 2 to 4 cycles are enough to have 80% response rate. Right. While if we use the prednisolone 1 milligram per kg per day, we usually give the patient up to the 4 weeks. Depending on the duration, and it should not be extended beyond the thing because of the toxicity associated with steroids.
Right, we should taper off by 6 to 8 weeks. Thank you. So now that IVIG 10% is also available. Will you choose IVIG 5 or 10?
So basically in our center, we use 5% only, although 10%
Right.
have shown the similarly efficacy, but the
Yes, yes.
benefit is having the low volume for infusion and lesser infusion time.
Right.
So we can switch
And
to
listen.
10% as per the availability, sir.
Thank you, absolutely correct. How will you manage a patient with a life-threatening bleed? You have already a patient with a life-threatening bleed. How will you manage newly diagnosed patient?
Patient with life-threatening bleed needs urgent intervention, and usually we go first with IVIG, 1 gram per kg per day for 1 to 2 days. And depending on the situation like ICH or something, although platelet transfusion will not be helpful in ITP, but in this situation, we can consider
Yes.
for platelet transfusions. And sometimes we need add-on therapy with TPO agonist also in scenarios with life-threatening bleeding like romiprostim and altrombopac, as we will discuss in follow-up panel sessions. But these are the options we have to give because patient needs
Right.
urgent rise of the platelets to prevent further episodes of the bleeding.
Thank you so much. Now coming back to the case, the patient had onset of symptoms 2 months back, and she was when she was in IGMS, she was started on steroids in IGMS with no response. Then she was transferred to AIMS Patna, where she was administered IVIG 1 gram per kg for 2 days. And there was no rise in platelet even after 72 hours, and she continued to bleed. So this is a situation where IVIG and steroid didn't work, and the patient has profuse bleeding. So my question to Dr. Shajia is, what are the treatment options now? Dr. Shajia?
Yes, sir. Am I audible?
Yes,
Hello?
yes, yes.
Yes. Very good evening to everybody, and thank you organizers for having me. So this patient, she's now she's gone into 2 months, well into the going toward assistant by definition ITP, and she's not responding to steroid and as well as IVIG, and she's actually so in this case we have we can think of TPO receptor agonists at present, and we can also hello. We can also I think we should also review our diagnosis, whether we have missed any, whether there is any immune conditions which we might have missed, whether any inherited causes, or we can review the bone marrow, which has already been done once before, to see whether any other, which is actually a primary ITP or some other thing which has been missed.
Right. Bone marrow was done previously, so we didn't go for bone marrow. And correctly, you have talked about TPO agonists. These are the options. Even rituximab is an option. But in this patient, actually, there was some financial constraints, and we thought of TPO. Giving TPO agonist, but she can't continue for indefinitely because of financial constraints. So we have to think about splenectomy in this case. Though according to the recommendations, splenectomy shouldn't be the preference for the initial 1 or 2 years. Still, in this case, as the patient was not financially capable of TPO agonist therapy, we thought of splenectomy. So splenectomy was planned, and but the platelet was around 8,000, and active bleeding was present. So a plan was made to give a bridging therapy of with a TPO agonist and to go for splenectomy. A referral was given to gastrosurgery, and tablet L-Trombopac 50 milligram was started. Now my question to Dr. Shajia is, what is the mechanism of action of TPO agonists? And what are the advantages of L-Trombopac, though not we have not used or not available here, over L-Trombopac? And what are the adverse effects of TPO agonists? Dr. Rahul has talked about all these in the lecture before, but if you can once again enlighten us.
What is the mechanism of TPO receptor agonists? Yes, they act by binding to the TPO receptors on the surface of megakaryocytes. Your L-Trombopac and Avatrombopac, they act at the transmembrane domain of the receptor, and romiplastin extracellular portion of the domain of the receptor, and then increase the signaling and stimulate the megakaryocytes to increase production of the
via JAK-STAT, and ERK pathways, signal transduction pathways, they increase gene transcription,
production as well as activation, and so they can act.
Thank you. Thank you.
Yes, regarding your advantage of avathrombopag over, should I continue?
Yeah, please. What is the advantage of avathrombopag over L-thrombopag?
Over L-thrombopag, though both of them are acting at the same site and both are oral drugs, your avathrombopag, it has one advantage is it does not have to follow the strict dietary regime of L-thrombopag, a 4-hour delay, a 4-hour around the drug, as well as you're avoiding
no interaction with food.
As well as few side effects like hepatotoxicity and your thrombosis, which is L-thrombopag, is not seen in case of avathrombopag. And avathrombopag usually is recommended for as a peri-procedural use in CLD patients.
Right, and it is 2 to 3 times more potent than L-thrombopag. Yes. Now, another question is, how long will you give a trial of TPO agonist if there is no appreciable response? Or no, the adverse effects, few words about adverse effects. Very briefly.
The adverse effects are different. Usually in case of L-thrombopag, it is mainly your GI side effects, your increased transaminases, your headache, and then your increased risk of DVT. So as for your romiplastin, those slightly lesser. And in case of avathrombopag, you have a similar your headache, hypertension, chances of, and so cataract is also one of the side effects of L-thrombopag.
Right. In trial, around 6% of the patients they develop cataract. Even in the PETI trial, also there was even in the pediatric population also cataract was seen in a few patients. And besides that, bone marrow fibrosis is one important but significant fibrosis is rare. And there is a risk of clonal evolution and malignancy has been talked about, but it's more common in MD. If you use this TPO agonist in MDS patients, it's more common, and it is actually in ITP patients, it is not a concern. And besides that, rebound thrombocytopenia. Around 10% of the around 10% of the patients on TPO agonist, when you withdraw it, the platelet count drops below the baseline pre-treatment level. It goes below the pre-treatment level. So rebound thrombocytopenia is another side effect. And for romiplastin, a risk of antibody development is one side effect. We'll talk about it later. Now, how long will you give a trial of TPO agonist if there is no appreciable response?
We gradually increase the dose, whether in case of L-thrombopag from 25 to gradually increase to 75, romiplastin from up to 10, maximum of 10. And then we continue for another of 4 weeks. And if we see still the maximum response, there is no response, then we can
Right, 4 weeks. So both with a maximum dose, both for L-thrombopag and romiplastin, we give them for 4 weeks up to the maximum dose. For example, for L-thrombopag, it may be 75 milligram. For romiplastin, it may be 10 microgram per kg per week. And then after 4 weeks, if there is no appreciable response, we shouldn't continue. So coming back to the case. After 2 weeks, her platelet count was 50,000. She was vaccinated, and after 4 weeks, the platelet count was 1 lakh per cubic millimeter. She was taken for splenectomy. Now, Dr. Sumit Mitra, my question to Dr. Sumit is Dr. Sumit here?
Yes.
Good evening. My question is, what are the response rates to splenectomy? And what is the common cause of failure of response to splenectomy?
Achha, spleen is a major site where the platelets which are coated with antibodies are broken down. So if we bring down the spleen, then we can hope for a response.
Right.
So the question is, how do we define response? If we say that the platelet count should be normalized, this occurs in about 65 to 70% of the patients. But if we look at a bigger scenario, if we consider a response to be more than 50,000, then near about 85 to 90% patients, they show a response.
Right, 85 to 90%. And the response persists, for example, for 10-year response rate is around 78% patients, they maintain response up to 10 years.
Yes.
Hello? Hello?
Hello.
Dr. Sumit. So, and what is the most common cause of failure of response?
Regarding the causes where thrombocytopenia persists even after splenectomy, common surgical causes presence of accessory spleen.
Right. Thank you.
There are other causes, for example, the duration of ITP before splenectomy was ventured upon. Or, for example, the underlying disease. For example, it's a secondary ITP that SLE or hepatitis C. So, in these cases, the response will be not that extent. So, thrombocytopenia will persist after splenectomy even.
Thank you.
Response to splenectomy beforehand, it's very few variables have been studied. One that is studied greatly is the age of the patient.
Age of the patient, yes. More than 60, they're more likely to.
Less than 50, it's likely to respond. More than 65, nearly nil response.
Right. Can we predict the response to splenectomy beforehand? Barring this age factor, can we predict beforehand?
Yes. Yes, for example, if the patient had been responsive to corticosteroids,
okay,
the chance of splenectomy is greater. The chance of response to splenectomy is greater. Again, we mentioned the underlying diseases. If it's a idiopathic ITP, no secondary.
No, I'm talking about ITP only.
Yes. So if the patient has been responsive to steroids previously, then there is a high chance of response. Or if the platelet count rises within the first week of splenectomy, then we can say the response will be durable.
Now, before splenectomy, I'm asking before splenectomy. So, there is, though this is not available, indium level platelet scan of autologous, indium level autologous platelet scan, and this can be a predictor. Though if the sequestration is maximum sequestration is the spleen is in the spleen and less in the liver and hepatic A, then the chance is that the patient will respond to splenectomy. This is one thing, but this is not widely available. Now coming to thrombocytopenia in pregnancy. Now, okay, now two more questions are there. Elaborate pre-splenectomy vaccination strategy in brief, just in brief. Dr. Sumit.
Yes, splenectomy will is likely to bring upon many infections. We are most concerned with the infection of capsulated organisms, pneumococcus, meningococcus, influenza type B. So you must vaccinate the patient against these. So the strategy we should embark upon is, we should, from the diagnosis, we should inform the patient about the possibility of splenectomy and prepare the patient accordingly. We are getting several months time. We can getting 6 to 12 months time during which we can vaccinate the patients. So the strategy is vaccination for pneumococcus conjugated vaccine.
Just the names.
Yes. Vaccination with the Prevnar. Keep a gap of at least 8 weeks and then give the pneumococcal polysaccharide vaccine. Similarly, for meningococcus,
again, meningococcal and HIV.
And give a gap of about 2 months, at least 2 months, and then give the second dose, the Haemophilus influenza vaccine, and of course, give a yearly influenza vaccine. So I recommend these 4 vaccines to be given.
Absolutely correct. Thank you so much. Now, coming to thrombocytopenia in pregnancy, my question to Dr. Jeevan is that, what are the differential diagnosis of thrombocytopenia in pregnancy, and what is the minimum platelet count which is considered safe for pregnancy and delivery?
Thank you, Dr. Basab. So the most common cause of thrombocytopenia in pregnancy is the gestational thrombocytopenia, which is a benign thrombocytopenia. The other cause, this gestational thrombocytopenia is seen in around 60% patients. Another cause,
just the names.
Other, it may be ITP, and in the third trimester, it may be preeclampsia, HELP syndrome, TTP, HUS, and rarely it may be antiplatelet, antiphospholipid antibody syndrome, or very, very rarely it may be acute fatty liver pregnancy that may cause thrombocytopenia.
Yes. So in the early pregnancy, it is mostly ITP. So in the first trimester, in the first trimester, if we get a platelet count, low platelet count, then it is most likely ITP. But in the late pregnancy, we'll have to so many causes are there, and so we'll have to consider all these. Thank you.
So another is the question is the cutoff of platelet count in the pregnancy. So generally we keep a cutoff around 30,000, or if patient has bleeding, then it may be around 50,000. And for the delivery, if it is normal vaginal delivery, then the cutoff is 30,000. And in case of cesarean, it should be 50,000.
50,000, right? 50,000 is preferable. Yeah. Now, what are the agents that can be used in a pregnancy?
The most commonly agent, if platelet count is less than 30,000 or patient is having bleeding, then we can use steroid or IVIG. So if the time of between the delivery is just 7 days or less than that, then we prefer IVIG. But if this thrombocytopenia is detected during 3rd or 2nd trimester, then prednisolone or methylprednisolone can be considered. The dose should be 1 milligram per kg.
IVIG during bleeding or before delivery?
Before delivery, the target is to increase the platelet count before the delivery.
Right. And what is the preferred dose of prednisone to start with?
That should be 1 milligram per kg.
Actually, in pregnancy, the recommendations are that to start with 20 milligram because of the side effects like hyperglycemia, like hypertension, all these, and again psychosis and all these. The recommendation is to start with 20 milligram and then to decrease the dose to keep the patient with the minimum dose with which she responds. Okay. My question, this is now coming back to the case. After splenectomy, the platelet count increased and the patient was put on thromboprophylaxis and antibiotic prophylaxis. My question to Dr. Manisha is that what would be the advice to her? What would be your advice to her for regarding further pregnancies? If she has already 2 kids and if she wants to get pregnant again and wants to conceive again, then what would be your advice?
So patient is ITP. So if he has a stable platelet count, then there is no need to worry. Although the ITP patient develop thrombocytopenia in the pregnancy and they are associated with complications like ICH in neonates. So we have to be very careful. So a stable platelet count is more important. And also these episodes are more common in the splenectomized patients, the newborns of splenectomized patients. So we have to counsel like that.
Right. So splenectomy, splenectomized ITP patients, their ITP actually deteriorate during pregnancy. And so we should actually, my opinion is that we should counsel not to conceive again, because splenectomized patient, there's chance of severe ITP. And also there is, for the neonate also, there are problems. So better not to conceive again.
Yes, now coming she has completed the family, so it's better she will.
Yes, right. Thank you. Now coming to this is a chronic ITP case with a patient of chronic ITP, a 38-year-old man. A diagnosed case of chronic ITP was started on romiflostim for last 1 year after failure of corticosteroids and rituximab. He was maintaining a platelet count of more than 50,000 on 5 microgram per kg per week. However, for last 2 weeks, it was seen that his platelet count has fallen below 20,000. There were mild bleeding episodes. His dose of romiflostim was increased then to 10 microgram per kg per week, but even 4 weeks after increment in his platelet count was still hovering around 10,000. So my question to Dr. Ankit is, what may be the cause of above phenomena and what are the options now available, and can we switch to an alternative TPO agent?
Excuse me.
Good evening. Thank you for having me. So quickly, as Dr. Rahul have already pointed out, Romiflostim is a peptide, and there is formation of autoantibodies against it, which leads to loss of response gradually.
Right.
The other options available are the other TPO-RA, which is eltrombopag, and already, as has been discussed, the mechanism of action of the both are different. So eltrombopag is another option which we have with us. Along with eltrombopag, options like rituximab in combination with or without dexamethasone is another reasonable option which can be offered to the patient.
And romiflostim, another thing is that romiflostim steroid can be added to a low dose steroid, like 5 to 15 milligram of steroid can be added to romiflostim, and these may be tried. This may lead to again response that may lead to response. So that is another option, adding low dose steroid to romiflostim. Can we switch to alternative TPO agent? Yes, you have told that we can switch, and this study also shows that switching a patient, even if the treatment is not, the patient is not responsive to one TPO agent, he may respond to the other TPO agent. That is possible. When from eltrombopag was changed to romiflostim, around 66% patients responded, and when romiflostim was changed to eltrombopag, around 100%, the response was around 100%.
Excuse me, Dr. Basab. Excuse me.
Yeah.
Yes.
Sir,
Yeah.
5 minutes, sir.
Okay.
5
Okay.
minutes.
Okay.
The patient was switched to eltrombopag 50 milligram OD. Within 1 week, the patient platelet count showed an upward trend, and by 2 weeks, the count was 60,000, and by 4 weeks, the platelet was more than 1 lakh. But after 1 year of this incident, the patient who was still on eltrombopag and maintaining an adequate platelet count told you that his funds are exhausted and insurance company is not paying him further. He asked you whether he can stop eltrombopag. So what would be your advice to him?
So again, as already discussed, we need to gradually taper the dose of eltrombopag and find the minimum dose which helps the patient in maintaining the desired platelet count. So 2 weekly tapering by 25 milligram every 2 weeks is what we would go for. And when we reach a 5 milligram daily dose, then we skip days in between and reach the minimum dose which the patient requires.
Yes, right. Thank you. Now coming to refractory ITP, I don't think this needs further discussion. And Dr. Shazia, my question to you about fostamatinib, what is the mechanism of action of fostamatinib?
Fostamatinib is a newly approved oral drug, which is the spleen tyrosine kinase inhibitor. It acts at the receptor level, inhibiting the spleen tyrosine kinase and preventing downward regulation, and it prevents the further destruction of the antibody-mediated platelet destruction. That's how it helps in refractory cases and those who have failed other lines, multiple lines of therapy.
Like it's a pro-drug actually, and it gets
yes, it's a pro-drug, and it's degraded in the gut into R406.
R406, and actually it's actually binds to the spleen tyrosine kinase and downwards and inhibits the downward signaling, and this that's how the platelet, the antibody-coated platelet, which otherwise would have been phagocytosed, that escapes the phagocytosis. Thank you so much. My last question to Dr. Sumit is, very briefly elaborate the role of immunosuppressive and steroid sparing agents in ITP. Very briefly. Dr. Sumit, are you there?
Okay, very briefly, steroids have many toxicities. So we want to bring down those toxicities. So we use agents along with the steroids in low doses where we can maintain a minimal platelet count, which we can call a response. So such drugs are like dapsone, danazol, cyclosporin, azathioprine, mifetil, which can be used either in solo or in combination with some other drugs. For example, we can use cyclosporin combination of dexa along with rituximab. So by that mechanism, we can keep the dose of steroid too low. For example, a patient may require 5 mg or as the toxicity of steroids. So this is how the steroid sparing agents work.
Right. Dapsone, danazol, absolutely. And danazol, dapsone both have around 50 to 60% response rate. And as discussed previously, mycophenolate mofetil is another promising drug which may be used. So thank you so much. Thank you all the panelists. And I think This was a fruitful discussion. Now over to the coordinator. Sir.
Thank you, Dr. Basab. And thank you all the panelists. So once again, thank you everybody for your nice deliberations and participation in the discussion on ITP. So although there are numerous publications which we have seen now on the diagnosis and treatment of ITP, the knowledge gaps still remain. We have a lot of room for growth in multiple areas to get to where we want to be in managing ITP. So good night, stay safe.
Thank you so much.
Thank you, everyone. So now I would like to hand over to Dr. Prakash Shekhawat for next session.
Thank you all. And this is today's day 2 of this 5th annual conference. And the sessions are going very well and they are very educative also. And this next session is on multiple myeloma. And the sponsor for this session is Jensen and Johnson & Johnson divisions. And I would like to invite the session coordinator, Dr. R.K. Jena sir. Sir is presently professor and HOD in Department of Clinical Hematology, SCB Medical College, Cuttack. Sir needs no introduction, and he has more than 70 publications in journals of national, international repute. So I would quickly hand over the program formalities to Dr. Jena sir to conduct this session and as a session coordinator. So over to you, sir.
So good evening and welcome to this multiple myeloma session. After a very interacting session on ITP, now we'll move to the second session on multiple myeloma. It has 4 parts. The first speaker will be Dr. Dragan Jebramovic. You will be talking on the mutations in myeloma. Second, I will be speaking on newly diagnosing multiple myeloma from Indian perspective. The third speaker will be Saji Kumar. He will be talking on frontline new treatment in multiple myeloma. And at the last, we'll have a panel discussion, and the moderator will be Rahul Bhargava. And we have a very elite panelist to discuss the real few cases scenario. As a first speaker, it gives me immense pleasure to introduce Dr. Dragan Jebramovic. He is a consultant and hematopathologist and currently acting as assistant professor in the Division of Hematopathology, Department of Laboratory Medicine and Pathology, Mayo Clinics, United States. He is a very well-known figure so far myeloma field is concerned. He has many national and international publications. His research really revolves around the diagnostic and hematopathological aspects of myeloma. With these few words, may I invite Dr. Dragan to deliver his speech. And his topic is, does mutation matters in myeloma? Dr. Dragan, please. Yes, sir. Good morning, Dr. Dragan, and welcome.
Jebramovic, and I'm a hematopathologist at the Mayo Clinic in Rochester, Minnesota. The title of my talk today is Does Mutation Matter in Myeloma? I will start my screen sharing now. I like to start my talks, especially to the clinicians, with the question, what do clinicians really want from the lab or pathologists such as me? And the answer is firm diagnosis, prognostic factors that are available from the lab, and hopefully some therapy guidance. We have 2 types of specimens that we mostly deal with in patients with myeloma, that is blood and bone marrow. And although blood has in the last few years become more and more important, and there are many new studies coming up, I will focus in the interest of time most of my talk today on the evaluation of the bone marrow. So this is what we look at the bone marrow. These are the parts of the evaluation that we do in patients with myeloma. First, we need to quantify bone marrow plasma cells. We need to establish plasma cell clonality that is mostly done by flow cytometry these days. we evaluate prognostic factors, and we'll talk mostly about these because this talk is about the mutations in myeloma, and so that is a big part of what we do as pathologists is analyze the bone marrow specimen for different prognostic factors. We need to be sure that we are dealing with myeloma and not some kind of lymphoma with plasmacytic differentiation, such as lymphoplasmacytic lymphoma or clinically Waldenstrom macroglobulinemia. We have methods to detect that, to make that distinction. We have to look for amyloid deposits. And finally, we need to evaluate bone marrow for anything else that might be present either in lymphoid or myeloid compartments. So prognostic factors, and that's most of what we're going to talk about today, in myeloma are mostly these days still is fish abnormalities. That is something that is mainstay of myeloma stratification in pretty much all the classifications that are available. And so that cytogenetic is still something that has to be done on pretty much every newly diagnosed myeloma. Molecular assessments such as gene expression profiling and next generation sequencing mutation assessment, that is slowly trying to gain traction in the clinical practice, but these are still not use in any kind of widespread manner. And then we obviously have immunophenotypic assessment, again, done mostly by flow cytometry, for which can give us other types of prognostic factors such as plasma cell proliferation rate, percentage of bone marrow polyclonal plasma cells, and the post-therapy minimal residual disease. When we talk about genetics of myeloma, the first thing to emphasize is that, as all of you I'm sure are aware, is that genetics is very complex. And it turns out that as technology is advancing, the genetics appears more and more complex. There are two separate, in my mind, separate angles for approaching the genetics of myeloma. One is looking at pathogenesis, and the other one is practical clinical implications of findings. Pathogenesis of myeloma is illustrated here in an obviously simplified way. There are early events in the genome of a myeloma cell, which is really a post-germinal center B cell that differentiates into a plasma cell. And there are two types of major events that happen at this stage, at the early stage, and that is either acquisition of hyperdiploid karyotype, and about half of myelomas, maybe 40%, have the trisomies of odd number chromosomes. Or the other major genetic change that happens at this stage is translocation involving immunoglobulin heavy chain, most commonly a region, and these translocations then activate other oncogenes, and some of the most common ones are presented here. And so these early events, and there is a small percentage of cases that has some overlap between the hyperdiploid and non-hyperdiploid or IgA translocated cases, but for the most part, that is the base of the genetic abnormalities. And at this early stage, also what happens is that there is a cyclin D dysregulation, either by translocation or by other mechanisms. And then as disease progresses, you get many more aberrances in the genome, including NF-kappa B activating mutations, mutations involving RAS, MAC kinase pathway, amplification of a MYC message, either by translocation or more commonly by other methods, by increased transcription. And then obviously P53 inactivation, either by chromosomal aberrations or by point mutations. So as you can see, this is complex, and this is obviously still simplification of how complex the process is. And then you compare that to the our clinical approach is really stratifying myeloma into only two major groups. One is a standard risk myeloma, and then the other one is a high risk. And high risk myeloma is defined by specific genetic abnormalities, translocation of OR14, 1416, 1420, deletion 17p, gain 1q, and then p53 mutation, which is the only one that got into the high risk group. And then there are other clinical and immunophenotyping features, including revised international staging system stage 3. And in the next slide, I'll show you what this encompasses. Then plasma cell S phase, which is high, and it is usually measured by flow cytometry, or gene expression profiling with high risk signature. Particularly in a rare cases, there is a combination of these high risk factors can lead to either double or triple hit myeloma, and these patients really do even poorly than the high risk. These are really difficult to treat patients. Revised international staging system is really based on the presence of high-risk cytogenetics, as shown is a stage 3, but also the measurements of LDH, albumin, and beta-2 microglobulin. And so this is how it was established in 2015 as a consensus from the International Myeloma Working Group. One thing to keep in mind here is that we do recognize that high-risk cytogenetics, these translocations and deletion 17p are bad actors, but there is a question of whether it is enough to have those cytogenetic abnormalities in any percentage, or you need a certain accumulation of these. In other words, are these categorical variables, or are they continuous? And there is at least one publication from last year from a French group that showed that in cases of TP53 deletion, what you need is at least a 55% of cells to have that for it to be clinically significant, or at least to be in this double hit myeloma category. So this tells us that possibly we're looking at some of these cytogenetic events in a more simplified way, and that in future we might have to actually quantify this in a more rigorous way. Gene expression profiling is a very powerful technique, however, not widely used. It can nicely stratify myeloma into standard risk and high risk, and even substratify based on fish categories. It is still important even when applied to the fish stratified patients. Very few institutions, I think University of Arkansas is the one that I know that routinely does it in a clinical practice. The rest of the field pretty much uses gene expression profiling only in a research setting. Point mutations, as you might expect, are again common in myeloma. They're obviously more common in myeloma than in MGUS. This paper showed that unequivocally. You get about 120 single nucleotide variants in myeloma, half of which are exonic and the other half not, and that is significantly more than what you get in MGUS, which is a precursor. Are they important, these point mutations? Well, many groups have looked and tried to establish the importance for clinical practice. This upper figure is from a publication from 2015 from a British group that established a 15 gene panel that was for myeloma. In our group at the Mayo Clinic, we developed our own next generation sequencing panel for mutations, which includes 61 genes plus 7 intron regions. And the genes covered belong to many different pathways, including MAP kinase pathway, NF-kappa B pathway, DNA repair pathway, including TP53 mutations, and plasma cell differentiation pathway, including IRF4. At this point, majority of institutions, including ours, uses next generation sequencing for mutation screen only for refractory disease, trying to identify a potential therapeutic target in patients who have undergone many different rounds of different chemotherapies. What we have and most groups have is a capture-based NGS assay without amplification step, because it is easier and more reliable to validate in a clinical practice. But for this to be to work properly, you need a lot of cells, a minimum 200,000 cells in our hands, and for that we use flow cytometry sorting. Whenever you have a gene expression profiling and NGS potentially in clinical practice, you have some issues, including who interprets the data. Is it going to be clinician, a pathologist, laboratory scientist, bioinformatician, computer algorithm? Then who integrates the interpretation with other prognostic factors into a therapeutic recommendation? And so these things are still not clear. In our institution, we do report NGS finding with some general comments, but it's really clinicians who have to actually decide what they're going to do with that information. And then finally, who pays for the study? NGS utility is still relatively uncertain. And the clinical trial, there are many clinical trials ongoing which are trying to establish the importance of the mutations in these different pathways. And in this slide, I'm showing you from a recent review article that there are many different potential drugs for different mutations or different pathways that are affected by the mutations. And in the right column, you see the clinical trials that are particularly developed using these drugs. As you can see, there is a lot of activity in this field. And I wouldn't be surprised if in the next several years we start using some of these inhibitors of different pathways, even in earlier settings, not just in very late relapses and very multi-refractory myelomas. So, as I mentioned, this is likely in the near future. The question, does mutation matter right now in myeloma? And the answer is at least some of the mutations do seem to matter. TP53 by allelic inactivation, and it's usually one chromosome has deletion of 17p and the other one has the point mutation in TP53 gene. That has been shown to be of a significant importance, defines a very high risk group of double hit myelomas. So that mutation is definitely important. And the other potential mutation that is important right now is mutation MYD88 L265P. This mutation is characteristically seen in Waldenstrom macroglobulinemia. MYD88 is an adapter protein that functions in a signaling pathway from toll-like receptors to activation of NF-kappa B. And if you have a loss of function mutation, such as in this middle panel, what you end up is some type of immunodeficiency, reduction in natural effector memory B cells. And if you have a gain of function mutations, which is L265P, like in Waldenstrom, you end up with constitutively active NF-kappa B pathway, and that is thought to be one of the main reasons for developing Waldenstrom macroglobulinemia. Importantly, most patients with Waldenstrom will have this mutation, not all of them. It can be seen in other types of lymphoma, but it hasn't been described in myeloma. So it is potentially a good diagnostic mutation to look for if there is a right clinical context. The last thing I want to talk about is that mutations can also be seen in non-plasma cell compartment. For example, in looking for pre-myeloid abnormalities, CHIP, which stands for clonal hematopoiesis of indeterminate potential. CHIP mutations have been found in a relatively small percentage of allele, and they accumulate in older people. It turns out that myeloma patients who have CHIP mutations tend to do worse, whether this is just because they tend to be less healthy or older people. It's still not certain. This was a paper published this year from a Spanish group, but something definitely that keeps a new field of research in myeloma, whether we should start at some point tests for CHIP at the diagnosis, and would that change anything in how we do our diagnosis and treatment? Would we change the approach, maybe use immunomodulatory drugs or not do stem cell transplant? All of that is still under investigation. In summary, multiple myeloma is disease with complex genetics. It is still stratified mainly by clinical findings and FISH abnormalities. There are many point mutations as well as other genetic alterations that have been described that can be found obviously in myeloma cells, but also in the background hematopoiesis. Most of them are still part of clinical trials and research endeavors, with possible exceptions of MYD88L265P for diagnostic purposes, distinguishing from Waldenstrom, and a TP53, which is prognostically important. I will stop here, and I thank you for your.
So thank you, Dr. Dragan, for this wonderful speech on the overall mutation and its relevance at present so far prognosis of myeloma is concerned. And since Dr. Dragan is online, I think we can take up 2-3 questions. To initiate, you have told very new terminology to us that double hit myeloma and triplet myeloma. Do you think that the whatever the data are available, that double hit myeloma is or triplet myeloma is worse than the double hit, and double hit is worse than the single hit or the overall high risk myeloma? Any studies in this regard? Dr. Dragan, please.
Can you hear me? So yeah, a triple hit is going to be worse than a double hit, and double hit has been shown unequivocally to be worse than a single high risk factor. I don't know if there are any new studies. Maybe Dr. Kumar would know better about that. Whether in terms of the prognosis, a lot of these data are collected from a routine clinical practice, at least in our group, where we test for these cytogenetic abnormalities on every single patient, and then stratify them, look for their survival afterwards.
Okay,
can I?
Yes, please.
Hi, good evening. This is Dr. Mayur here from Tata Medical Center. I have a couple of questions, Dr. Dragan. Fantastic talk. My first question is, there have been studies where they have done bilateral bone marrows from myeloma patients. And when they have done the mutational profiling, they have seen that although there were common mutations among the two sites, they also found quite a lot of heterogeneity in terms of the mutational profile, say on the left side marrow versus right side marrow in myeloma patients. So because most of these mutations, as you said, could be subclonal. So do you think, as now we are looking at the profiling to find drugs that could target these mutations, do you think this would be an issue when you think of the different drugs to target these mutations?
I honestly don't think that be an issue. Obviously, you're going to have a subclones, and yes, you're going to increase the ability to detect more subclones by doing more than one site. But in my mind, where does it stop? Should you go for every single lesion that you see on a PET scan to say, hey, how about this one? Is there going to be more? So I don't see that changing the practice anytime soon, to be honest. But I could end up being wrong.
Yeah. My second question is because I do a lot of FISH on myeloma patients, and I use the magnetic bead method to isolate the plasma cells for fishing. And I've always been wanting to do copy number analysis and mutation analysis on these patients using these high throughput techniques, but the number of plasma cells has always been a limiting factor. So do you think circulating tumor DNA could be a thing one could explore in order to profile these myeloma patients in future?
Absolutely. I think actually in future, I had a few slides about the peripheral blood, but then I couldn't really, because in the interest of time, go into that. I think both circulating cell-free DNA as well as circulating plasma cells for a single cell analysis is going to be probably the way of the future. The problem is that these techniques are still relatively complex, and for clinical use, you need to standardize. And one thing is to do stuff in the research setting, and then if you didn't pick up enough, that's fine. But in a clinical setting, we have regulatory agencies that would not allow us to have the live test unless we can show that reliably we can identify these mutations in every single patient that has them. And so this is the where the research and the clinical practice start kind of being a little bit far from each other. I see that definitely in future, less and less bone marrows and more peripheral blood analysis, which will also end up having helping us in a more of a follow-up of the patients, more frequent. You can envision somebody coming to the clinic every month to give a bone marrow, to look for mutations, look for MRD, look for all kinds of other things that could be done, immunomodulatory status, the immune defense, the number of different T cell subsets and so forth. So I think that's gonna come. I'm not sure if it's gonna be in the next 5 or 10 years, but I definitely see that coming.
Okay. Last, do I have time for another question, Dr. Jana?
Yes, please okay.
Go. See, for the high hyperdiploidy trisomy, generally we just look for 5, 9, 15 because that are the probes, but there is enough data about gain of 19, which actually ameliorates the high risk associated with gain of 1Q. So, because in India, we go very selective in terms of using our fish probes. And so in order to look for high hyperdiploid or just for the trisomies in myeloma, we just look for the 5, 15 and 9 trisomies. So do you think we should add on the chromosome 19 gain, and it's essential to further refine the stratification?
Honestly, I don't know. Somebody who is in a clinic who treats patients might have a better view of that type of literature than I do. I can just tell you that we have recently stopped doing fish for hyperdiploidy in majority of the patients because we are starting to do it by flow cytometry to look for hyperdiploidy, and because money is always the issue. How a patient gonna cover the cost of all the testing, and so we decided that we can, in the vast majority of patients, our flow cytometry assay is good enough to detect hyperdiploidy, and we don't need to look for it by fish. So only those that we cannot get it by flow, we continue to do fish.
Sure. Thank you so much, because even we use flowploidy for analysis in BCP ALL. In myeloma, we have been a little, because the number of plasma cells. So we've been a little. That's been a difficult point to apply it on the myeloma patients. Thank you so much, Dr. Dragan. Thank you.
Okay, thank you, Dr. Mayur. Any other question? We can take the last question. Okay, thank you. If there is no question, thank you, Dr. Dragan, for this wonderful speech on such an important aspect of this myeloma. So now we'll move to the next talk will be given by myself, the management of newly diagnosed multiple myeloma from Indian perspective. So now over to organizer. Respected chairperson and ladies and gentlemen, in the next few minutes, I will be talking on newly diagnosed multiple myeloma, its Indian scenario. In 2020, there have been few changes which has been already accepted by many agencies, and one of them is there is a lenalidomide, which has been increasingly used in newly diagnosed multiple myeloma patients. Just for example, in transplant eligible patients, the VRD is one of the most commonly used upfront therapy, followed by high-dose melphalan and stem cell therapy, then followed by lenalidomide maintenance. Similarly, in transplant ineligible patients, RD and VRD are two commonly used protocols where the lenalidomide is a part of all the regimens. So if you see that lenalidomide is almost used very preferably, so both in transplant eligible and transplant ineligible newly diagnosed multiple myeloma patients. The second important changes which has been approved, one is CD33 antibodies called daratumumab. It has been increasingly used as a first-line therapy as per and has been approved both by US FDA and EMA in newly diagnosed multiple myeloma patients. As per example, in transplant eligible patients, DARA with VTD by the result of this Cassiopeia study has shown that if you add the DARA with VTD, it really gives a better result over VTD. Similarly, in transplant ineligible newly diagnosed patients, DARA with BMP protocol and DARA with the RD protocol. So both these Maya and LC1 studies have proved that it gives a better progression-free survival and overall survival. So DARA has been approved as an upfront therapy both in a newly diagnosed eligible, transplant eligible and transplant ineligible patients. A third important principle which has been accepted as a upfront therapy or in the management of myeloma is that the aim should be deeper and durable response. The more deeper or the durable response is there, the better will be the prognosis. Now, the aim of the newly diagnosed myeloma therapy is to have it or to create a deeper and durable response. So these are three most important changes which has been approved in the management of the myeloma upfront. Next, if you look at the management of newly diagnosed multiple myeloma patient principles, you have to use the combination of drugs, preferably minimum triplet. You can use it sometimes as quadruple drugs also. And now, as I told earlier, the aim or the goal should be always have a deeper and prolonged remissions. However, we should be very, very careful to have a very good balance and between the anti-myeloma activity versus safety. You have to look for the quality of the life, safety in comparison with the deeper remission. We have to take care of this aspect. So this is very, very delicate balance we have to maintain between myeloma activity and the safety and the quality of the life also. So the transplant ineligible, if you look at the uses of the DARA, both LC1 and the Maya study has proved that this has been beneficial if the DARA will be added to BMP protocol in both in the elderly and in younger patients less than 75. And the Maya study has shown that if it will be added, DARA will be added both through the RD, both in the younger patients and elderly patients. It has been seen that DARA improves the CR and stringent CR and the MRD negative. If you compare, it is 48% versus 26, 41 versus 24, 50 versus 52, and 41 versus 25. Similarly, the MRD negative also, there is a significant improvement in the DARA group in comparison to the NARA group, in comparison to the non-DARA group, as per the 22 versus 6, 24 versus 8, 29 versus 9, and so on. So addition of DARA to either BMP or RD protocols has really significantly improved so far the CR, stringent CR, and MRD negative is concerned. I know there have been protherapy studies which have proved that the more is the stringent CR or more is the MRD negative, better is the result. Thus, transplant ineligible in newly diagnosed patients, DARA with the RD or DARA with the BMP are being considered or as being approved as a new therapeutic options in myeloma patients. So transplant eligible in newly diagnosed multiple myeloma patients, one is that, so this Cassiopeia study has shown that if you add the DARA with the VTD, then followed by high-dose melphalan and stem cell therapy, then consolidation therapy with the same protocol, it has a better response rate and progression-free survival. However, so far, based on this study, DARA with the VTD is accepted one of the approved first-line therapy in transplant eligible in newly diagnosed patients. However, we don't have any answer till date if DARA will be added with the VRD, in which way it can be beneficial. I think we have to wait few more days so far this Griffin study or the Precious study is concerned. So they are comparing with this protocol DARA with VRD versus VRD as induction and consolidation, and its results are outed. So, but the final decision is that this Cassiopeia study has proved that DARA with VTD gives a better result in comparison to the VTD only. Similarly, the role of DARA as maintenance therapy after autologous stem cell transplant in newly diagnosed myeloma patients, I think the Orgia and the dramatic studies are comparing DARA with lenalidomide versus lenalidomide maintenance therapy for 2 years, and its results are outed. So the role of DARA as maintenance therapy has not been proved yet. Having said the beneficial effects of addition of DARA as a upfront therapy, there have been several questions needs to be answered. One is, in transplant ineligible newly diagnosed patients, you know the VRD is one of the most efficient and commonly used protocol. However, it has not been compared. Addition of DARA with RD or addition of DARA with VLP vis-a-vis with VRD protocol has never been compared. So there is no head-to-head comparison with this commonly used protocol in transplant ineligible patients. Similar, whatever the interim report has been shown, the median progression-free survival with these two protocols has been quite similar. And of course, we have to consider the patient characteristics, cost, availability of DARA in deciding whether DARA should be added to our transplant ineligible newly diagnosed patients. So these are the questions to be addressed. So transplant ineligible newly diagnosed patients, though DARA with RD or DARA BMP are the new approved protocols, still then VRD and RD can be considered as options even if the DARA cannot be given to that patient. In continuing that, another question is important to address. One is in the transplant eligible newly diagnosed patients. Though DARA with the VTD versus VRD, there is no head-to-head comparison. As you all know that the VRD is one of the common use protocols, though DVT, so DARA with VTD is approved recently, there is no head-to-head comparison. However, the phase 2 Griffin study comparing DVRD and versus VRD, they have shown that at 22%, at 22-month follow-up, there is no benefit in progression-free survival or overall survival. You have to wait for a long-term follow-up is outed. Then only you can tell whether DARA with VTD versus VRD, which one gives or how far the DARA gives any better result. And another important point needs to be addressed that in high-risk patients, as you know, the KRD is one of the approved protocol. There is no head-to-head comparison by adding the DARA with KRD and what will be the results. It is being outed. So the benefit of DARA in high-risk patients needs to be appreciated by further studies. So thus, transplant eligible newly diagnosed patients, VRD still can be considered as an option without DARA at present. So another important point which needs to be addressed is that there is a first-line DARA has been well approved by the study which I shown that. But if the DARA, same DARA will be used at the relapse, there is no head-to-head trials so far. So for the progression-free survival or the overall survival is concerned. So the benefit of the DARA as a first line, vis-a-vis as a second line on relapse has to be ascertained to really finalize the place of DARA, whether should be give upfront or whether should be given the first relapse. That's another important and critical questions needs to be answered. Similarly, as I told you, high-risk newly-diagnosed multiple myeloma patients, the standard of care is the KRT induction CT, followed by high-dose melphalan transplant, then KRT consolidation, then maintenance CT, then you have to go for either KR or with the lenalidomide that's being tested. So this is the principle of management of high-risk multiple myeloma. But addition of DARA or rituximab to the KRT protocol or to the VRD, it has not been published yet, and we have to wait few more days whether addition of DARA or rituximab to our conventional KRT or VRD protocol in high-risk patients will yield any benefit. That's a critical question. Need to be answered before considering DARA to use in high-risk multiple myeloma patients. So newly diagnosed multiple myeloma patients, Indian scenario, have been said that these are the developments or the principle of management in the international level, but now, so for the Indian scenario is concerned, there is a significant variation in the healthcare facilities and financial position of the patients, as I'm sure you all are aware of the facts. And most of the patients, they depend on the government scheme. And even if the government provides the chemotherapy and other medicines free of cost, there's a lot of logistic challenges so for the accommodation, transplant, and other supportive therapy are concerned. The morbidity gradually increases as the disease progresses, The quality of life is a big important point. It's best in the first remission. It decreases in progression as more and more second line drugs are used. More than one line, and there is a study in Europe, 75% of the patients, they can still go for the use more than one line drugs, means after they relapse, they can still continue to use the second line drugs. Vis-a-vis in India, hardly 1/4 of the patients who relapse, they can go for the more than first line therapy, means second line therapy. This is the scenario, real world scenario, vis-a-vis Europe or the Western countries in our Indian patients. And that is one of the important point. I am sure my colleagues are aware. Stem cell storage should be storage and can be used for a second transplant or in a future if required. So stem cell storage is a big challenge, not only expensive, there needs a lot of technical challenges in most of the centers in India. However, for considering all these points in Indian scenario, the best therapy should be delivered at initial presentation. That's our motto, that's our principle. So far, the newly diagnosed multiple myeloma in Indian scenario is concerned. The standard risk newly diagnosed myeloma patients is concerned, induction CT, so VRP, VTT, VCT was there. Additional new one is the DARA with VTT is considered as one of the approved first line therapy. The stem cell should be collection after initial 4 to 6 chemotherapy induction CT. You should go for the there are two options available. You can go for the upfront high dose melphalan followed by stem cell transplant and consolidation, then maintenance, or you can complete the you can store the stem cell for the future, complete the induction to an extent of 6 to 8 cycles, then go for the maintenance CT. Then you can use the high dose melphalan or the stem cell rescue on relapse. So these are the two options available in the Western world where there is no problem so far the stem cell storage is concerned. But in India, the management of the things are different. The standard risk diagnosis management should be done with induction. Our most commonly protocols are VRT, VTD, VCT, or those upfront cases you can afford. You can go for DARA with VTD. The high dose melphalan followed by autologous stem cell transplant should be given to all patients. I have explained the reason for that. Then followed by consolidated CT and maintenance CT. So these are the principles of newly diagnosed myeloma patients standard risk in our Indian scenario. High risk newly diagnosed myeloma in India, induction CT should be done with VRD or KRT. Then all the patients who receive high dose melphalan followed by stem cell rescue. Consolidation CT should be given here in the high risk patient. Maintenance can be given either with the bortezomib, with lenalidomide, or with lenalidomide, or even with the bortezomib only, depending on the comorbidity and the patient tolerability. So high dose melphalan with autologous stem cell transplants, I believe, should be considered in all the cases in our Indian patients because the cost has been reduced. I was calculating the cost because of the availability of the generic brands and all the governments support now. The cost of a transplant can reduce to 1 lakh rupees. Many governments are providing free to all the patients. The stem cell storage is a big concern in our setup in most of the centers. That's why we should consider the stem cell transplant in the upfront. The second remission eligibility of the further transplant in the future is a challenge because that the age increases gradually. As the age increases, the tolerability to the rescue to the salvage chemotherapy and stem cell mobilization is a big challenge. Comorbidity gradually increases. Affordability, the patients usually gets financially trained, mentally trained, and physically trained out. The drug intolerance and toxicity becomes a big problem, and that's a deterioration in the quality of life too. So all these points makes in our patients really very, very difficult to go opt for the transplant in the second remission. That's why in all Indian patients we should aim to deliver the best therapy, and best therapy used with high dose melphalan followed by the stem cell transplant after the induction CT. So autologous stem cell transplant, our experience in SCB Medical College, Cuttack, Odisha, we started our program in 2014 to 2020. In the 6 years, we did the 82 cases, and there is a 75 was newly diagnosed and 7 were resistant. Stem cell yielding, what is one of the important points that we could achieve 100% stem cell yield in one settings by this large volume leukapheresis, and by our effort, by our meticulous manipulating all the procedures, we could achieve 100% stem cell yield. And another important point that we could transplant in 5 elderly patients more than 65 years old, and our eldest transplanter was 74 years old, and the mortality was within day 14, mortality was 2 patients died, beyond day plus 100 was 5. The relapse progression was in 12 cases, and the myelodysplastic syndrome developed in 3 cases, And of course, we provided this transplant free to all patients. Not only transplant, all the chemotherapy was given to the free to all the patients. So these are the story of our transplant program. The myeloma in our center is concerned. So the message is that the autologous stem cell transplant is possible in eligible in newly diagnosed myeloma patients. Should always look for this possibility. So this is the publication we did in 5 elderly patients, and if you look at the day 100 status of the myeloma, every patient achieved this stringent CR, and most people look at the neutrophil engraftment. The medial neutrophil engraftment was +12, very closely similar with the younger transplant patients. So far the engraftment is concerned, in the elderly patient, it's not a problem. And another important point is that we have never compromised with the dose of the melphalan. All patients receive the same 200 milligram per square meter body surface as the condition regimen. So this is the publication which you did, that in single a large volume recuperations in 55 cases we could achieve our stem cell yield to a target. So to conclude, ladies and gentlemen, newly diagnosed multiple myeloma patient, the best therapy should be given at the initial presentation. The aim should be deeper response, and we should always aim for the operational cure. High dose melphalan followed by autologous stem cell transplant should be looked for in all eligibly newly diagnosed myeloma patients. Elderly myeloma patients still will always look for possibility of these high dose melphalan. Maybe the dose may be modified in some cases, followed by stem cell rescue. This gives you the best and the deepest remission and the best regimen at the initial therapy. And there has been a significant improvement in the management of newly diagnosed myeloma patients in India across many centers of the country. Now the scenario of management, diagnosis, and the affordability patients or the government supply, it has really improved significantly. Though daratumab has a significant impact in the outcome as a newly diagnosed myeloma patient, as upfront therapy should be administered for those who can afford for that. I am sure the benefit of DARA can be given to the patients who can afford for that. With this, thank you very much for your attention, and thank you very much again. So thank you for your attention. I invite question or comment. You can take up 1 or 2 questions or comment on this topic.
Dr. Jaina, this is Dr. Bhargav.
Yeah, Dr. Rahul, welcome, please.
Thank you, sir. In spite of multiple sessions from Mayo Clinic, in spite of thousands of CME every month, every year on myeloma, talking about bone marrow transplant, why do you feel that still in India, only 400 to 500 stem cell transplants are being done? You are doing 82 transplants, you are doing 6, 7, 10, 15 transplants, we are doing 80 transplants a year. Across Indian population, still there is a doubt in the minds of people about bone marrow transplant. So how do you see this as a unifying feature with all these CMEs which are happening and we are learning? How do you see in the novel era, things are going to become clear? One. Second question, Dr. Shaji Kumar is there, because every month Mayo Clinic or European or American guidelines keep on coming and talk about delayed transplants or early transplants or not doing transplants at all. Do you think this will give a right and correct message for the people of India that every single myeloma needs to get a transplant done? What is your comments upon that? One liner, would you say that every single myeloma up to 70 years of age needs a transplant? Should we take this mantra from Eastern Hematology Group as their motto that next in 2021, every single multiple myeloma being diagnosed in Odisha, West Bengal, and Bihar will be transplanted, irrespective of cost? We'll find the cost, we'll get the money. Will that happen? What is your comments and how do you see the future for this?
Okay, thank you, Dr. Rahul. The first part that in spite of all these CMEs and other points, why the incidence of the transplant in myeloma is not increasing, I think that's a very controversial question which I will hesitate to answer, because it is multifactorial. There is a awareness problem both by the doctors and by the patients also. Even we do come across a patient those where we could have gone for transplant, but they have gone to somewhere else outside, etc., etc. They go on treating, and when they relapse resistant, they come back because it is beyond to achieve any second remission because of various reasons, and it's a very, very difficult scenario to go for second remission and to look for transplant. the problems are there is a multifactorial. And coming to the whether of the Eastern Hematology Group message should be to all patients to go for the transplant or not. I have extensively dealt the Indian scenario, though there is something different for standard risk. So far the science is concerned, Mayo Clinic would like to preserve the stem cell and go for the second remission. But in the Indian scenario is concerned, I have explained the reasons why you should deliver the best treatment at the initial setting, because to get the second option, many patients may not get the opportunity to go for second remission and the transplant. Regarding the other scenarios concerned, I think I will pass on to this question to Dr. Saji. Saji, please answer this point.
So, Dr. Jena, what was the second one, the use of transplant routinely?
The Rahul's question was that do you recommend that transplant should be offered to all the eligible patients in myeloma in the international scenario vis-a-vis with Indian scenario, because you are very aware of the Indian scenario. What is your comment in this regard?
No, I think anyone who is eligible to go through a stem cell transplant should be offered.
Saji's voice is very dim.
Your voice is not very low.
Let me give me 1 second. Let me make sure I have the. Can you hear me better now?
It's something better. Something better.
Okay. No, I think in the all patients who are eligible to go through a stem cell transplant should be offered a transplant. And I think I completely agree. I think the default should be to consider an early transplant, and the delayed transplant is again used in a very limited fashion, only in patients who either for some reason don't want to go to or cannot go to the transplant right away. And as you said, even with the IFM 2009 trial, 23% of those patients never got a second transplant at the time of, or got a transplant at the time of the relapse. So you will end up not using those cells and not getting the transplant later on. So I think all of them should be, at least the discussion should be had. Obviously, the limitations would be the cost of the procedure and availability and so forth.
Okay, thank you, Dr. Saji. And I must appreciate the effort of Dr. Rahul also. He's doing a commendable job in all the social media in transferring these knowledge information for every aspect of hematological diseases, including the myeloma and transplant also. I request Dr. Rahul to keep going all this good information, whatever is going or whatever is doing. Any other comment or question from others, please? We can take up one more question or one more comment.
Dr. Jena and Dr. Tufan here.
Yeah, please.
So, what is the out-of-pocket expenses of the patient with multiple myeloma in each transplant?
Okay, but so far Odisha is concerned, it's nothing. It's almost zero out of pocket because everything is being supplied. Maybe it's fooding and others stay outside. That's the requirement. If a max, it can go up to 10,000 rupees. So, but that's the out of pocket expenditure. So far Odisha is concerned. I'm sure that there's a difference in other centers too. Also, you can explain your center out of pocket.
Tufan, for us, sitting in the most corporate hospital in the country, the cost is $8,000, which is amounting to 4.5 to 5 lakh rupees.
Okay.
So it's 200 milligram mel, 200 milligram mel, 10 days of hospitalization, and 4.5 to 5 lakh rupees. And we do almost 1 lakh rupee transplant in BHU, Bikaner, and Indore medical colleges, state medical colleges funded by government. So we have been able to do in, say, $1,500 transplant in these centers. So anywhere between $1,500 to $8,000 or $9,000 is the current price.
What is the major biggest cost?
Antibiotics.
The antibiotics.
Antibiotic. So if we can find out, that's why we have hired an infectious disease specialist, Saji, that if we can reduce the antibiotic cost, believe me, it's going to come by $1,000 more.
Wow.
That's a problem. The biggest problem is our rates of Klebsiellas and transmissions through ESBL and carbonase resistant bacteria, which are already there in the gut. So we have a data of 100 myeloma patients who has got 80% people have carbonase resistant Enterobacteriaceae into their colonization. So in the stool, they're already harboring that. So that's a problem. So if we can overcome that, and that's what we are trying to overcome, if we can overcome that, then it's a smooth sailing.
Okay.
Dr. Jena, please continue.
Okay, so we'll end my talk here. So now I will invite our star speaker, always friend of Indian Society of Hematology, Eastern Hematologist Group, and even Odisha Hematology and other people also. He is more popular in than anybody else. He is more popular. I am sure even every state, every hematologist, oncologist, general physicians know. So he is none other than Saji Kumar. He is now currently, there's no need to introduce, always a pleasure. He's a good friend of mine. He's working as a professor of medicine, Mayo Clinics, and Rochester, Minnesota. He has received many, he's very humble in writing his awards, etc. I know he has received many awards, and most important is he has loved to also, he has very emotionally written that he loved the All India Institute of Medical Science, where he got a lot of training. So he received the Kirpal Kaur Award for Best Resident. He has mentioned as a first. That's his emotional involvement to the aims and India. Also received the American Association of Cancer Research Award in Molecular Biology, Warsaw, and also Young Investigator Award from Eastern Cooperative Group, and Teacher of the Year Hematology Oncology, Mayo Fellow Association, and many associations also. I have seen even us also. He has received many international awards, and he has a lot of publications, hundreds of the publications related to myeloma. He has delivered many new drugs, new concept, new understanding in myeloma. He's a man of myeloma. He's one of the group of the IMF International Myeloma Mafia, we call it, and they can swing every decision of myeloma in their favor. Anyway, with these few words, I invite Dr. Saji Kumar to deliver his lecture. Please, Saji Kumar, please. So over to organizer, please.
Good evening. Today I'm going to talk about the current approach to treatment of newly diagnosed multiple myeloma. This is an area that has seen considerable progress in the past decade with the introduction of several new therapies, as well as development of several new combinations. These are my disclosures. Let's start off by talking about the newly diagnosed multiple myeloma patients who are eligible to undergo an autologous peripheral blood stem cell transplant. Now, the current initial therapy of newly diagnosed multiple myeloma is the combination of bortezomib, lenalidomide, and dexamethasone. This is based on the phase 3 trial SWOG S0777 that compared bortezomib, lenalidomide, dexamethasone to lenalidomide, dexamethasone. Patients were randomized to get lenalidomide, dexamethasone or bortezomib in addition to lenalidomide, dexamethasone for 8 cycles of induction, followed by lenalidomide maintenance. This trial showed that the addition of bortezomib led to deeper responses and a higher response rate that translated into a better progression-free survival, and most importantly, an improvement in the overall survival. The addition of bortezomib was associated with a higher rate of peripheral neuropathy, but otherwise was well tolerated. Over the years, we have identified that giving the bortezomib subcutaneously once weekly can be associated with significantly less peripheral neuropathy than was observed in this particular clinical trial. Now, there are other triplets that have been studied in the setting of newly diagnosed myeloma, and these include bortezomib thalidomide dexamethasone as well as bortezomib cyclophosphamide dexamethasone. Both these triplet regimens have been shown to induce significant responses in newly diagnosed myeloma prior to proceeding to an autologous peripheral blood stem cell transplant. Now, there's only one trial that has compared VTD to VCD, and that is a randomized trial done in France for 4 cycles prior to an autologous stem cell transplant, and showed that VTD was associated with a deeper response, but at a higher rate of peripheral neuropathy, and cyclophosphamide containing combination was associated with a higher rate of hematological toxicity. Now, the long-term outcomes with the VTD injection therapy has been published by the Italian group, and it seems like a reasonable regimen to consider if there is no access to lenalidomide in the upfront therapy. Now, there have been ongoing efforts trying to improve upon this triplet regimen of bortezomib, lenalidomide, and dexamethasone. The EVEN-11 trial randomized patients with newly diagnosed myeloma who were either transplant ineligible or were planning to defer the stem cell transplant to a later phase at the time of first relapse. These patients were randomized to bortezomib, lenalidomide, dexamethasone or carfilzomib, lenalidomide, dexamethasone given for 9 months. And these patients were randomized a second time to either receive lenalidomide maintenance indefinitely till progression or until 24 months. Now, this trial showed that even though the carfilzomib containing regimen was associated with a higher rate of VGPR, the progression-free survival was exactly identical for the KRD and the VRD regimens. And this result held true even when we censored the patients who went off to alternate therapy. And even in the older patient population, the subgroup of patients who were over 70 years of age, again, we found that there was no significant improvement to adding carfilzomib to lenalidomide dexamethasone compared to bortezomib and lenalidomide dexamethasone. Now, this trial clearly showed that for an initial therapy of multiple myeloma, replacing the bortezomib with carfilzomib did not seem to make any difference. And these results are consistent with what we have seen in the non-transplant eligible patient population setting, where bortezomib in the VMP regimen was replaced by carfilzomib, and the Clarion trial did not show any improvement for carfilzomib compared to bortezomib. Now, in contrast, when you add carfilzomib or replace bortezomib with carfilzomib, we do see a higher rate of cardiac, pulmonary, and renal toxicity compared with bortezomib, where the toxicity was predominantly peripheral neuropathy. It is likely that this increased risk of cardiac, pulmonary, and renal toxicity is what led to a comparable PFS for these two regimens, despite the carfilzomib containing regimen having a overall deeper response rate. Now, there has been increasing attention towards improving the initial therapy of multiple myeloma by adding a third drug to the combination, a third class of drug to the combination. Now, as we all know, daratumumab is a monoclonal antibody targeting CD38 that's present on myeloma cells, and multiple studies have shown that daratumumab has significant activity in this disease. The Cassiopeia trial was designed and run in Europe, where daratumumab was added to the combination of bortezomib, thalidomide, and dexamethasone to see if we can improve the outcomes. Newly diagnosed transplant-eligible patients were randomized to the quadruplet or triplet for 4 cycles induction, a single autologous stem cell transplant, followed by 2 more cycles of the same regimen for consolidation, followed by a second randomization that compared daratumumab maintenance versus no maintenance. And this trial showed that adding daratumumab to VTD resulted in a higher overall response rate, but most importantly, a deeper response rate, including a very good partial response, higher rate of complete response, and most importantly, a higher rate of minimal residual disease negativity, almost a 3-fold higher MRD negativity compared to the triplet regimen. And when you look at the various disease-related characteristics and its impact on the depth of response, you can see that the patients across the study, irrespective of the underlying characteristics, appear to have had a deeper response to the quadruplet, with the exception of the high-risk patients where the benefit did not seem to be much. Now, with the current follow-up, Cassiopeia trial already demonstrates that there is an improved progression-free survival with the addition of daratumumab to VTD. And in fact, the improvement is seen across the different subgroups of patients, including the patients who have had a deep response. Now, the VTD is not a very commonly used regimen in the US and other parts of the world. VRD is the standard of care in many places where these drugs are accessible. So the Griffin trial looked at the question of adding daratumumab to the combination of VRD in newly diagnosed myeloma as induction therapy prior to stem cell transplant. So fairly similar design, newly diagnosed transplant eligible patients were randomized to getting daratumumab VRD or VRD. They had a single autologous stem cell transplant. Then they received consolidation therapy with the same regimens for 2 more cycles. And then these patients went on to have maintenance therapy with either daratumumab lenalidomide in the DARA VRD arm or lenalidomide alone in the VRD arm. Now, when you look at the response rate, you can see that over time, as patients went through the different phases of the therapy, there was a deepening of response with, at the end of 12 months, nearly 80% of patients getting the quadruplet were in a complete response or better, compared to a 60% of the patients in the VRD arm. And when you look at the minimal residual disease negativity, you again can appreciate that there was almost a 3-fold increase in the depth of response or MRD negativity with the 4-drug combination compared to the 3-drug combination. However, even with the longer follow-up, and this is data that was presented at the recent ASH meeting, we can see that the progression-free survival differences have not yet shown up in the quadruplet versus triplet. I suspect that we are going to see some differences with longer follow-up. In contrast, again, the overall survival appears to be identical between these two approaches at the current follow-up. Now, once you do the injection therapy, whether you do it with any of the triplets we talked about or one of the quadruplets, the big question is, do we really need an autologous stem cell transplant with these highly effective regimens like VRD? The IFM 2009 trial randomized patients to a upfront transplant versus a delayed stem cell transplant approach. So patients received bortezomib, lenalidomide, dexamethasone injection therapy for 3 cycles. Then they received either an autologous stem cell transplant or 3 more cycles of the same injection therapy. And then all patients received an additional 2 cycles of consolidation with bortezomib, dexamethasone, and then went on to receive 1 year of lenalidomide maintenance. Now we have longer term follow-up data that was present at ASH this year. Now almost 8-year follow-up at this point in time. You can see that the median PFS was significantly improved with the addition of autologous stem cell transplant in the upfront setting, almost a 4-year PFS rate. And you can see here in this particular trial, a majority of the patients received pomalidomide-based treatments at the second line, and 201 patients in the non-transplant arm received transplant at the time of the first relapse. That is nearly 77% of these patients. Now, when you look at the progression-free survival too, which is often considered a surrogate for the overall survival, as well as the 8-year overall survival, you can see that they were pretty much identical between the early transplant arm versus no transplant. And this is important data suggesting that the autologous stem cell transplant still plays an important role in the early management of multiple myeloma. However, if a patient were to wish to delay their autologous stem cell transplant to the time of first relapse, that's quite reasonable considering the comparable overall survival. Now, there was also updated data from the Forte trial that was presented, which randomized patients with newly diagnosed myeloma to getting a carfilzomib cyclophosphamide induction therapy followed by transplant, or KRD followed by transplant, or KRD without a transplant by replacing the transplant with 4 additional cycles of KRD. What we have seen is that even though the KRD-based induction therapies had a deeper response, a comparable MRD negativity rate, which was higher than KCD, the durable minimal residual disease negativity was seen in the context of autologous stem cell transplant. And this translated to a much better progression-free survival for KRD followed by transplant compared to just using KRD alone, which in turn was better than KCD, suggesting again that a proteasome inhibitor plus IMiD combination remains the standard of care induction therapy, and patients who are eligible to get an autologous stem cell transplant should be considered for an early transplant. Now, the Forte trial also randomized patients at the end of induction therapy to getting either a carfilzomib plus lenalidomide maintenance or lenalidomide maintenance alone. And this trial again showed that receiving a carfilzomib len maintenance significantly improved the progression-free survival compared to a single drug maintenance. Again, this is something that we would expect with the use of 2 drug versus 1 drug, and we don't have a lot of details as to which subgroup of patients actually benefited in terms of what they received for induction therapy. But it is important to point out that the high-risk patients appear to have done almost as well as the standard risk patients in terms of their benefit when you used a dual maintenance compared to a single maintenance, a finding that's comparable to what we have seen with bortezomib len maintenance. Now, finally, with the overall survival at this point in time looks fairly comparable for the carfilzomib lenalidomide-based induction therapy and the carfilzomib len maintenance treatment. Maybe a slightly inferior overall survival for the KCD-based induction therapy, and this is statistically not significant at this point in time. Now, the next big question is, what should we do after an autologous stem cell transplant? Should we do a tandem transplant, non-transplant consolidation, or should we do maintenance therapy? The BMT-CTN trial randomized patients to getting either directly len maintenance after a single transplant or VRD consolidation for 4 cycles prior to len maintenance, or a tandem auto transplant followed by len maintenance. They did not show any difference between these two approaches, suggesting that a VRD-based injection therapy, single transplant, and lens maintenance is sufficient for the majority of patients. The EMN02 trial, in contrast, looked at the concept of VRD consolidation versus no consolidation, as well as a transplant versus VMP consolidation as initial strategy. There was updated data from ASH this year showing that autologous stem cell transplant is better than VMP, again highlighting the importance of transplant, and also that VRD consolidation, if you did not get VRD as part of injection therapy, also appears to improve outcomes. But most importantly, we have data from prior reports showing that patients with high-risk cytogenetics actually do benefit from getting a tandem autologous stem cell transplant, a concept that we are increasingly adopting in the setting of this subgroup of patients. Now, one thing that is clear from the majority of the trials is that patients who undergo a single autologous stem cell transplant clearly benefits from using a lenalidomide maintenance, as this meta-analysis showed, with a significant improvement in the overall survival with the addition of len maintenance used until disease progression. When you look at the subgroups of patients, it is clear that patients with high-risk disease does not appear to benefit from using a len maintenance. And for these patients, the available data would suggest that one should use a combination of bortezomib or a proteasome inhibitor with lenalidomide as maintenance treatment. Now, based on the available data, this is our recommendation for management of transplant-eligible patients. Patients with standard risk disease should get VRD induction, have stem cell collection, and preferably go to an autologous stem cell transplant followed by len maintenance. But if they want to delay autologous stem cell transplant until progression, we can give additional 4 cycles of VRD followed by len maintenance. In contrast, patients with high-risk disease should be considered for a tandem autologous stem cell transplant after a 3-drug or a 4-drug induction therapy, and then use a proteasome inhibitor immunomodulatory drug-based combination maintenance. What about transplant ineligible patient population? Now, obviously, these older patients are at risk for complications because of a variety of different underlying comorbidities at this age, as well as a variety of societal issues. Now, one of the combinations that have been studied in this patient population is the RVD Lite that uses the RVD, but it is reduced intensity with a 5-week cycle instead of 3-week cycle, and 15 milligrams of len versus 25 milligrams, and 20 milligrams of dexamethasone versus 40 milligrams of dexamethasone. And these trials have shown that the RVD Lite regimen produces outcomes quite similar to what you would find with full dose RVD in the younger patient population. Now, there was an update at ASH this year looking at the MAIA study, which randomized patients with newly diagnosed transplant ineligible myeloma to receiving Dara Lendex versus Lendex. And the trial showed with longer 4-year follow-up that the PFS was significantly better with Dara Lendex compared to Lendex. And importantly, the second PFS, or the PFS2, was also significantly better with Dara Lendex, suggesting that eventually we will see an overall survival improvement with the triplet compared to the doublet. Now, the Alcyone study, in contrast, looked at adding daratumumab to the VMP regimen that had been a standard of care for treatment of myeloma for quite some time. And this trial, patients after the 9 cycles of the injection continued on Dara maintenance in the Dara VMP, whereas they stopped treatment in the VMP arm. This trial showed that addition of daratumumab in an indefinite fashion to VMP improved the depth of response, overall response rate, and also the progression-free survival. But most importantly, addition of daratumumab to VMP also improved the overall survival in patients with newly diagnosed myeloma. Now, at ASH, there was data presented with the ixazomib lenalidomide dexamethasone. This is an oral proteasome inhibitor, and in combination with lenalidomide dexamethasone, it led to deeper response and also an improved progression-free survival. And it is important to notice that the IRD PFS is quite comparable to the PFS we have seen with bortezomib Lendex in a similar patient population. However, this trial did not meet the pre-specified threshold of improvement in terms of the significance, but nevertheless provides important data. So currently, our approach to treatment of non-transplant eligible patient population with newly diagnosed myeloma in the standard risk setting is to use either VRD or daratumumab Lendex, while patients with high-risk disease, we would like to use a combination of bortezomib lenalidomide dexamethasone with, again, a maintenance that includes both these drugs until disease progression. So to conclude, I want to highlight that the therapeutic advances and the introduction of new therapies have significantly improved the outcomes in myeloma. The treatment of myeloma requires a long-term strategy that delivers the best treatment package for treatment of newly diagnosed myeloma. And the optimal combinations and sequencing is the key. And increasingly, we should be using a risk-stratified approach. And the future will be in developing more individualized treatment approaches for these patients. With that, I would like to thank you for your attention.
So thank you, Dr. Saji, for this wonderful talk on the recent update and the approach for management of newly diagnosed multiple myeloma, both in transplant eligible and transplant ineligible. As usual, you are always lucid and very clear in your understanding and giving the message. With these few words, I may invite some of the comments or questions from my colleagues.
To set the balls rolling, Saji, just to let us know the audiences, what is the role of deeper responses before transplant? Because there's a huge debate. If in India we do a survey, people are still using VCD, VTD, and VRD. And many of the studies coming from Vancouver talked about having no utility of a deeper responses before transplant. And the moment you achieve a VGPR, just go ahead and do a transplant. So what do you feel about it? Is it necessary to achieve some kind of a stringent CR and a MRD negativity before doing a transplant so you can go deeper into that? Or what is your thought process?
I don't think you need to. I think the key thing is you have to think about the whole entire thing as one package of treatment, right? So your best response is going to be after maybe, somewhere through your maintenance. So the only trial that has directly asked that question is the UK trial, which looked at randomizing patients to additional therapy if they only got a PR versus going directly to transplant. As you would expect, if you changed your regimen before transplant or gave additional cycles and go to a deeper response, you will have a better PFS, but your overall survival is exactly the same, suggesting that you don't really change the long-term outcomes. What we are really doing is, yes, more therapy, deeper response, more PFS. But at some point, you're not going to get much more advantage using the same types of drugs that you already have in the mix. So I don't think there's a need to target a specific depth of response for every patient before transplant. As long as they are having the disease is responding and you're able to collect the stem cells, you can give the transplant. And then in the high-risk patients, I think maybe additional therapy after the transplant, if they don't get to a CR, I think is reasonable.
Dr. Saji, Dr. T.K. Dulai here. So in terms of this post-transplant, do you consider any form of the consolidation in your practice right now?
Typically not. We would do a single transplant and go to LEN maintenance for standard risk patients. In high-risk patients, if they are not already MRD negative or in a CR by the end of the first transplant, then we might either do additional cycles of a consolidation or more likely a tandem transplant and then go to a dual maintenance.
I think that was the question also asked by Dr. Malini. I think Dr. Malini has got the answer, the same question Dr. Topan has asked. Because Haji, can I ask one?
Thank you, sir.
Because since DARA has been approved as a first-line therapy with the DARA VTD and DARA VRD, does the DARA have any influence in the stem cell mobilization on the engraftment during the transplant? Or what's the...
So there's some effect. So if you look at the Cassiopeia data, there is a decrease, about a 20% decrease in the total number of CD34 cells collected. And there is also some increase in the plerixafor use. We have seen some patients with slightly delayed engraftment, but overall, it doesn't affect your ability to do a stem cell transplant, and eventual engraftment is just fine.
Any other question or comment? Okay, but now that the concept has come, operational cure like CML, chronic myeloid leukemia, now the operational cure for myeloma. So what is your vision in this concept and how you will go ahead for that operational cure?
Right, so I think it all depends on what age your patient is to when you're talking about operational cure, right? So the task is similar if your patient is 80 years old, and if you can, keep them going till 90 and they die of something, it's different. But if you have a 45-year-old patient in front of you, they don't have any treatments that you can say is reliably going to keep this myeloma under control for the next, 45 years or next 20 years for right now. So, but I think it's all the way you want to look at it is the new therapies are building blocks, right? So if you look at the data with the induction therapy, single transplant, then maintenance, you're looking at about 5 years of disease control on an average. And I suspect if you include DARA in that regimen or using a DARA-based combination as your second-line therapy, we are probably looking at adding another 3 to 4 years to that. And so I think with each new class of therapy that you get, we probably keep adding another 2 to 3 years to that disease control on an average. So for the 50-year-old patient, either we have something that is reliably curable, or you want to have enough numbers of treatment regimens that you can keep continuing it, keep the disease under control for the next 30 plus years.
Okay, I have a personal question because I was really wondering to find its answer. There are many studies which support that deeper is the remission or more durable is the remission, better is the progression-free survival. Why in standard risks or in high risks also, having given post-transplant consolidation also does not make any difference in progression-free survival or overall survival? How to explain in standard risk at least?
So if you look at the data that you have looked at post-transplant consolidation, the best data is probably looking at the EMNO2 trial, which randomized patients to 2 cycles of VRD versus none. And that the study that had shown an improved PFS. And the reason they showed an improved PFS is because that's the first time that the patients saw lenalidomide. They were on a VCD induction and they got a VRD consolidation. In contrast, when you look at the stamina trial where they used the same VRD before and after, there was no improvement with the consolidation. So the question is, you are not going to get any more deeper response by using the same drug for consolidation. But if you change the drugs, then you're going to get a deeper response. And deeper the response, more the PFS, that's more mathematical. So I think for standard risk patients and high risk patients, it's going to be different. For high risk patients, for the same response, your PFS is going to be shorter because your cells are more proliferative because of the high risk nature, and the clone is going to grow back up even from that MRD negative state much faster than would happen in the standard risk patients.
Okay. Any other question you can take as a last question or comment? So, okay, since there's no question or comment, Eastern Hematology Group appreciate the effort, the inconvenience both Dr. Saji and Dr. Dragan has taken. I know the register is very severe chill. It's too early. It's 5 a.m. or 6 a.m. must be. And so there must be snow surrounding with a lot of income difficulties. You look fresh. That shows your interest and your commitment to serve us. Eastern Hematology Group extend sincere thanks and appreciate for your cooperation and delivering our guest lecture and making this annual congress really meaningful. And I am sure many people have enjoyed your inputs and your discussion and your look and your approach how to manage both myeloma, both you and Dr. Dragan. Thank you very much. Wish you a good luck and very thank you very much again.
Thank you. We had a great meeting.
Okay, with this now we'll move to our next session. It is a panel discussion on the real world treatment in myeloma. The moderator is Rahul Bhargav. He is a very vocal and very known. He's a good friend of mine. Presently he's in the Fortis hematology. He's a senior consultant in hematology and in charge of the bone marrow transplant. He's a very popular and very well-known hematologist, and across the country he moves and patronizes the role of hematology transplant in India in many centers. So you will have the panelists like Shilpa Bhatia. Shilpa is presently in the Apollo Hospital, Kolkata, in Kolkata as a consultant hematology. Then you have Vijita Datta also. Vijita Datta is she's in the department of pathology, Mankata, in Kolkata. Then third is Manish Osta also, and Mayur Parihar. So Manish is now in the Department of Clinical Hematology and Bone Marrow Transplant, Tata Medical Center, Kolkata. And Mayur Parihar is again, he is a well-known cytogeneticist from TMC, Kolkata. And with this, I request Dr. Rahul Bhargav to take over and his time duration. And also, I will request to finish this panel discussion in 25 minutes. So, Dr. Rahul, is over to Dr. Rahul, please.
Thank you.
Thank you. Sharing your presentation.
Thank you, Doctor. I can do that actually speaking now.
Okay, Doctor.
Okay, so that's a beauty of a technology. Thanks, Tufan. I've been in Dubai And that's how technology actually helps you to reconnect with your friends and fulfill your prior commitment. So I hope you can see my slides. It's a one case which we are going to discuss, and how the module is that please keep on telling your own practices as well as your own data. I hope my voice is clear and you can see the slide. Is that so with all the panelists?
Yes.
Yes, Rahul, continue.
Perfect. Yes. So the real world is slightly different from what we see on the trial basis. So let's see. A 53-year-old female presented with usual back pain and high creatinine in September 2018. M-band was 3.4. In IFE was IgG lambda. Fish shows gain of 1Q. So nothing, it's a pain, simple myeloma, which needs to be treated. So question first, what will be your first line therapy? Over to Shilpa Bhatia, Ajit Nag can chip in. So not in particular order, people can actually start speaking and keep on telling their own ideas about it. Because I've written it 1Q, and I'll come back to Mayur Payar about asking how does a 1Q looks like. So what will be your first line therapy? Shilpa Bhatia, first to you.
Yeah, so the first thing is you established that this is a very high-risk myeloma having the 1Q amplification. She is relatively young with renal impairment. I would go for VRD. I would give her the options of VRD, and I would certainly give her the option of adding daratumumab. If she can afford, we'll go for DVRD. If not, we go for VRD.
So Dr. Ajit Nag, is it once a week Velcade or twice a week or subcutaneous versus IV? I beg your pardon?
I would do twice a week and IV initially till the renal function get better.
Anybody for KRD or anybody for VCD of the panelists? Dr. Chakravarti, Dr. Manish, Dr. Bijit Datta. Are they there? Dr. Arijit, are you there?
I think Dr. Arijit is not there. Rest is there.
Okay, Dr. Datta, you and Dr. Chakravarti. Anybody for KRD? As we have seen, the data from KRD plus auto transplant looks very promising with randomized being into KR post maintenance. So 1Q will ask, Dr. Mayur, can you tell me, as Dr. Shilpa Bhatia has said that it's a high risk disease, can you tell us and enumerate that 1Q as either 3 or 4 copies, and does it make any difference in your practice? And once you report a fish, do you really write the amplification 3 copy numbers or 4 copy numbers?
Okay. Yeah, so just to start, 1Q is a secondary abnormality, and yes, it is associated with high risk. Now, there have been papers which have shown that plus 1Q, that is 3 copies. And when you have 4 and more copies of 1Q, these patients do, the outcome is bad compared to those patients which have 3 copies of 1Q. But compared to those patients which do not have 1Q at all, gain of 1Q, 3 copies do worse. So yes, in our practice, we do write 3 copies or 4 copies in our fish analysis, but it does not kind of, I think, clinically change, the interpretation of the results. But we document whether it is 3 copies or 4 copies, because there have been papers which have shown that, patients, when they have 4 or more copies, they do badly. And the possible biology behind it, because generally it is understood that 1Q gain is due to what is called as a jumping translocation, wherein it's an unbalanced translocation. And as the tumor progresses in patients with 1Q, you could have more jumping of 1Q, and then you could have more copies of 1Q that are there, probably showing that this is associated with a further progression of the disease and associated with high risk. And
so, Dr. Mayur, just to cut you short, you're saying 3Q is not high risk, but 4Q is high risk. 3Q,
no. 3 copies is also high risk. 3 copies is also high risk. 4 copies is more high risk than 3 copies.
Perfect. So in your fish reports, any person who's seeing it, please see, as and when you say gain of 1Q, please ask your lab people to write about 3 copy numbers and 4 copy numbers, because the change of maintenance therapy could be on the blocks in terms of using more of proteasome inhibitors rather than using lenalidomide. So Dr. Mayubia's second question is, so we assume this patient might have a 17p deletion. On fish, can you tell us about a biallelic nature? And does it confer poor prognosis if it is present in say only 20% of cells which has been analyzed on fish?
Okay. So now you had 17p deletion. Now if there's a, when you talk about biallelic 17p involvement, you're talking about 2 copies of the 17p being affected. Commonly what happens is one copy is deleted and the other copy is mutated. In order to call it biallelic, you would have to do a mutational analysis. And if you see a mutation, then you know that both the copies are involved. Yes, you very rarely you could have both copies of TP53 being deleted. Like they have now, there's a lot of data and they've shown it, like Papa Manuel has shown in MDS, wherein she's shown that the biallelic, they've also looked at silencing of the other allele. So when you talk about biallelic, it is not just deletion and mutation. You could have deletion of one copy, and you could always have an epigenetic silencing of the other copy. So that is biallelic. So just on fish, no. In order to call it biallelic, you will have to do a mutation analysis also. So you have one copy deleted and the other copy showing a mutation. Then you call it that there is a biallelic involvement of the 17p or the TP53 gene. Yeah.
So, and what is the amount of number of cells we should have to say it's a poor prognostic marker?
Okay, so to start with, I want to say that one has to fish on enriched plasma cell. Now that is a practice which is not very commonly done because of the costs involved, but I think you shouldn't fish myeloma if you're not enriching plasma cells by either magnetic bead method or the other bead. Now, the IFM actually showed 60% is porous, but the Dutch, the Germans have shown even 10% is porous. Dana Faber has a paper which says 10 to 20, more than 60, that there are different outcomes. But for us, anything more than 10%, we say TP53 positive, and it's taken as high risk.
Perfect. So Dr. Mayur has said it very well. Shilpa, this patient goes on to have a high risk in case because there are 2 copy numbers extra, which means there's 4 copy numbers of amplification of 1Q. And we know now to say it high risk 17p, anything more than 10% is high risk for all of us. So this patient went on to get VRD twice a week, and that to IV. Patient achieved a 50% reduction in M-band after 8 injections and continues to get 16 injections of bortezomib along with Lent 20 milligram and DEXA, achieves a VGPR. So what will be the next step in this case? Dr. Shilpa, Dr. Datta? Dr. Shilpa, are you there?
Yeah, sorry, I was on mute. Yeah. So what I do in the real practice is I want to see at least two M-band levels to showing that the disease had reached a plateau and we're not going to get any deeper response. So if she's achieved a VGPR, by which I mean to sort of say you're confirmed that this is the best response she could get. And at this stage, given her age, she should be suggested an autologous stem cell transplant.
Anybody different than this?
No,
Any
sir,
other panelists would like to differ?
I also agree with Shilpa ma'am, sir.
Dr. Shilpa, can you tell me, would you like to not get a delayed response? The IFM trial has just got published and they said the difference was not huge between early transplant and the late transplant. 77% people who are on VRD could still go on to get a second transplant done. Do you think in India, is there any utility of a late transplant?
See, most of our patients, we usually want to get the best and the deepest response in the first chance, because as the disease keeps progressing, the chance of them getting into remission and deeper remission becomes lesser and lesser. So if I would push them for the transplant in the very first remission. And as I said, we want, you've got your best response with your VRD, you've got a VGPR. So even if you give 2 more cycles, you may not land up getting any better response. So it's better that once you've reached a plateau is to go on for the BMT, and then you see whether post BMT, when you do your day 100 assessment, you see whether they've gone into CR. Even the transplant could take her into a better remission. So then you decide whether you want to consolidate or go for maintenance, especially because this is a very high risk case of myeloma.
So Dr. Mayur, at this level of time, say if the patient would have achieved a CR or a stringent CR, would you like to do an MRD in this patient before transplant, knowing whether the patient is MRD negative? And what is your policy at your center? 1. And second, how can there be a sometime discrepancy that there's a small M-band which is positive, say 0.5 gram per deciliter, but still MRD is negative? How do you explain these kind of a phenomena?
Oh, okay. So, at our center, we are doing MRD on myelomas regularly now, but I'm not sure whether that is being taken into consideration to change treatment decision. So I wouldn't be the right guy to answer on that. But yes, we do see discrepancy in terms of MRD and M-band, because you could have low levels of myeloma cells which are actually secreting the proteins, and that is why you could get a low level M-band. And still we have in fact even seen MRD negative, and when we use when we have enriched plasma cells on fish, we've got the small clones, especially of the when we are using sensitive probes like the dual fusion probes, because there the denominator is different. So yes, it is possible and can be seen.
Perfect. So good. So contrary to the popular demand, patient didn't opt for transplant. Patient was in VGPR, was not willing. At what level, if the patient is not willing, say people say we don't want a transplant, okay? At what level would you like to change to maintenance? When you would like to start the maintenance? That's a pertinent question. Dr. Shilpa, would you wait for another 2 cycles to achieve a CR? Would you like to wait and change from VRD to VPD or something like that to achieve more deeper response before you put the patient on LEN maintenance? Do you do that? Or just a sacrosanct, as 16 injections, give 16, give 24 injections, just put the patient on maintenance? What has been the best response? And anybody of the audiences can also chip in, because this is a very, very pertinent question, because I have seen 70% of time, whatever the response, because the guidelines have written 16 injections or they're open-ended, people go on to give 16 injections over and put the patient on maintenance. And there are sure lame ducks to get relapse. So Dr. Shilpa, what will be your point of view onto this?
So I go up to 24. I go up to 24 doses of bortezomib. She's already on lenalidomide, which is theoretically and practically better than thalidomide. So I don't think changing from lenalidomide, I would make sure that she's on the full dose of lenalidomide if she's able to tolerate the dose, provided her kidneys have got better with the bortezomib. So I want to optimize and make sure she's getting the best doses. And if she's reached a plateau after a maximum of 24 doses, then I would change her to maintenance, len maintenance. But I would go up to 24. I wouldn't stop at 16.
So Dr. Shilpa is saying 24. I would say let's achieve the best response possible and then put the patient on maintenance. At least it will give you a better response. Anybody else? Dr. Tufan, Dr. Jaina, your thought process into this?
Okay, but Dr. Jaina here, since you have invited, so my approach will be that suppose you are achieve the best one, I will agree with Dr. Shilpa that I will go minimum up to 24, at least 6 to 8 cycles, 6 cycles, and I will optimize the dose. That's a good point she has told. And then followed by maintenance, because in this setting, the consolidation have not shown any benefit to the same kind of the protocol. If I would like, suppose I am not achieving this stringency here, I may opt for 2 or 4 consolidation city of different higher molecules. Suppose he has not, I have not given my cartridge. I may look for the KRD as a consolidation, maybe 2 to 4 cycles, then followed by lane maintenance.
So Dr. Jaina, absolutely right. The guideline says try to achieve the best response, and the best could be in a clinical setting, could be difficult to know when the plateau will come. The plateau will only come when we know 2 M bands apart, which is stable, which is not progressing or not coming down. Then only we can say it is as a stable thing. So it's an open-ended thing. And that's where the clinical practices come into play, and the experiences that you need to document a plateau that you're not getting with the same medication. And if the patient is high risk, try to change it to another therapy area where you can reduce the burden as much as possible. So this patient not opted for BMT, continued the lenalidomide, and she developed paraplegia in the month of April 2020. So progression-free survival was almost 1 year, 4 months. 16 months practically, she developed paraplegia, and MRI showed extensive soft tissue components. M-band was 2 grams at that time. Question is, how frequently you monitor such patients with M-band and serum-free light chains? Dr. Shilpa.
I do it every 3 months. And if
Perfect.
I see there is an increase, then I would go on, 2 months as well. If I see the trend is
every
getting
3
higher.
months. So do we have any other panelists, Dr. Bhatt, Dr. Datta, or any other panelists who want to chip in?
I also do it every 3 months.
So do we do bone marrows for MRD, or should we be doing every 6 months to 1 year? Do we do bone marrows in multiple myelomas for seeing in MRD at this present moment of time with the MRD data
No.
getting mature?
No,
Dr.
sir.
Mayur, what is your strategy at your center? How often do you do bone marrows in myeloma to see the MRD level? Dr. Mayur? Dr.
Oh,
Shilpa?
sorry, I was muted. I was
Perfect.
muted.
So do you do bone marrow at your center?
So,
how often do you do bone marrows to look for the MRD?
So, we have just, initially, we've just begun doing MRDs for myeloma. And to be honest, it's a big cost issue for the patients, so we don't do it in all patients. But those patients who can afford, I think we do MRD on bone marrows. To be honest, I'm not very sure about the timeline.
Perfect. So we are doing, at least for after post bone marrow transplants, we are doing 6 months to 1 year, depending on the baseline cytogenetics. If it is a standard risk, we do once a year. If there's a high risk, and we are trying to collect the data every 6 months to see how people are doing at this present moment of time. And we have seen the MRDs subsequently rising in a patients who are high risk, and we have been able to hit them who are younger, say 45, 50 years of age. What contrary to the Western data, if your patient is young, please try to act on the rising titers of MRD so that you can give them a better progression-free survival. Once they relapse, the younger patient, it becomes very, very difficult to take on to the next CR. So this patient relapsed multiple myeloma. What will be the next line of therapy in a 55-year-old who's paraplegic and on catheter? DKRD, KRD, VRD, KBD, DPD, DKPD, or will you change LEN and add? Will you ever change LEN and add DARA, or would you just continue doing LEN with DARA, or you like to bring in pomalidomide early?
So I want to take this, but before that, I want to ask, you said you need to act on the MRD. And so many times we are not even acting on biochemical progression until there's an actual clinical relapse. So how can you justify?
Very good point.
Yeah.
I would say in our setting, whenever it's a cytogenetics and you see the patient's progression, if the patient is fast progressing, if the rapidity is fast, please act upon the biochemical parameters as well. We have seen and burned our fingers post-transplant 4 or 5 years patient who tends to relapse very quickly in these subsets who we didn't act upon the biochemical relapses. So I would say, please act upon the biochemical relapses as soon as possible.
Okay.
Perfect. So what will be your next line of therapy in this 55-year-old paraplegic?
So she is relapsed. We know that at the upfront, she is high risk disease. You want to expose her to newer drugs that we haven't exposed her before to. Either you would go for, I don't know, do you have KPD, carfilzomib, pomalidomide, dexamethasone? At this stage, again, you will persuade her if she can add on daratumumab. It's going to be a really good plan because, otherwise she's already paraplegic. We don't know how much of time she's got for recovery, but yes, you need to add newer drugs that she hasn't seen before.
Newer drugs which tends to act very fast.
Very quickly.
Dr. Rahul, I have a comment on this issue.
Yeah.
Because patient has a high risk, I think previously you should continue the bortezomib in spite of the lenalidomide, one issue. And another thing is that in terms of the paraplegia, I think the VTDPS regimen is one of the good regimen you can use it. Because
which one?
VTDPS.
Okay, DTPS. Okay, yeah. Perfect. Agreed. So, Dr. Tufan, very good. So, I'm talking about the newer agents. I'll come back to that point as well. But point well taken. Why we should have added lenalidomide plus bortezomib was because this was an amplification of 1Q, and we know the 1Q amplification tends to work very well with proteasome inhibitors rather than the IMiDs. Point well taken. So, this patient was given a generic carfilzomib, and pomalidomide and dexamethasone shows progression after 2 cycles. What will be your choice now? Would you like to add DARA to this? Because patient is very, very skeptical. The moment you say 1,60,000 rupees a week, they all get skeptical. And how long? Because the question is, when will this end? Where will this end? People need consult therapy, which is like finite, not infinite. So what will be your choice now?
I think we have very little choice. We have to add daratumumab now.
Perfect.
Because...
So DKPD, I mean, would you like to add DARA to KPD? Or would you like to go away of DARA plus PAD? Or would you like to go away of DARA plus DTPase?
That depends on how is she sort of still able to take chemotherapy after all this, and what's a general condition. I think before we add DTPase, we have to be sure that a general condition allows that.
Yes. Tufan, the biggest problem was in DTPase, patient is bedridden, and if you give a AML-like consolidation therapy, patient tends to land up into ICU more often than not. So what we did, patient landed up with us, came to us in September 2020, 70% plasma cells, Foley's catheter. There was no ideas was coming through. We gave 2 cycles of DARA KPD, which was all original. DARA plus KPD, Kyprolis, pomalidomide, and dexamethasone. And after 2 cycles, if it was 2 months, patient was in CR. Plasma cells were less than 5%. And this is not the first patient. This is the 3rd patient who has responded to this regime after 3 or 4 lines of therapy, DARA KPD. This regime seems to do a very, very fast acting reduction in the plasma cells. And still patient for anyone for the BMT, would you subject this patient for BMT?
If she still has any stem cell reserve left after all the 2 years of therapy, yes, if you can manage to get any stem cells out, because she's had a chance where she's into a deep remission, and the only way to consolidate would be BMT.
Perfect. So she underwent an auto.
Rahul, what about the performance status of this patient?
So patient was taken up, patient was bedridden because she was paraplegic, she could not walk. She was given KP DARA plus Kyprolis. She went into ICU because of the diastolic dysfunction, because of the Kyprolis. She went and go on to tolerate the things well. She underwent an auto transplant in end of October, needed 2 times for collection, had a stormy course, and last week follow-up, which was in first week of December, shows she has started doing an assisted walking. So my views, so early versus late BMT's views and practices. The biggest problem probably is in a late BMT is the cost, because we cannot store the stem cells, and it adds 50 to 60,000 rupees to already stretched out patients in multiple myeloma. That's why we are not doing a late transplants. Role of MRD in myeloma, Dr. Shilpa, what is your view in terms in the future which you see role of MRD in myeloma?
This is, of course, like in any other hematological malignancy, MRD has an important role. It's about getting access to getting a good MRD report and in time, and what cost is going to bear on the patient. Yes, of course, if you're talking about operational cure, Dr. Jaina also mentioned, we have to ultimately achieve an MRD so that we can improve the PFS and overall survival as much as possible. Myeloma is one of the conditions where we've got so many drugs now available, and most of them are affordable in our country. You did raise a point about the generic carfilzomib not working. That is a major concern. I've seen it even with the ibrutinib, that the generic ones don't really work very well. So, if we are trying to use these drugs and, but if we can achieve MRD, so in your case, I don't know whether the daratumumab worked or was it the original Kyprolis that has helped patient achieve the deep MR, we don't know that. But yes, in terms of role of MRD, certainly we would like to have it, and we would try to get all the patients MRD negative if possible.
So, Dr. Shilpa, this is the 3rd patient. After 3 lines of refractoriness, we have added DARA plus Kyprolis, and we have seen some data that the synergy comes in even after patients are refractory to one of the agents. If the patient is refractory to DARA, patient is refractory to POMA, if you add both, the synergistic action comes to play, and the pomalidomide helps in bringing out, ameliorating the resistance for daratumumab as such. And what about the D regimes? Now, daratumumab has been approved by Government of India in a newly diagnosed multiple myelomas. What do you think about D regimes? Not the Daud regime, because I'm sitting in Dubai, but yes, Dara-based regimes.
For the affordable ones, I would definitely like to offer it to them, but I wouldn't sort of, go on and tell the people who can't afford that, you need to take this drug. So I would definitely not sort of make people feel guilty about not taking daratumumab upfront. If they can afford it, well and good, take it. If you can't afford it, BRD has done a very good job for decades, and I hope it will continue to do.
So with this, we come to an end, and my take on to that is induction is VRD. And if the patient can afford, as Dr. Shilpa has already spoken about, DVRD in high-risk group, BMT early as much as possible, maintenance Velcade plus lenalidomide, depending on the cytogenetics, or len alone. In relapse, our go-to regime now is in patients who still has a transplant as an option, DKRD or DKPD, people who tends to come to us from various outside centers who have not received a transplant. To achieve a CR2, this is one of the best regimes which we are finding right now. And if the patient is young, please plan for allo because we don't have an access for CAR T cell. We have got 2 patients transplanted 2 years back. They're still doing well without GVHD. Though we have lost one more patient, a third patient, 6 months back, which we have done because of the GVHD. So 3 out of 3 patients, 2 are still alive and 1 we have lost after 8 months. So I would say, think about allo. Is not out of the books at all in an Indian setting. With this, I'd like to thank everybody for patient hearing. Thanks to FAN for giving an opportunity. Thanks, Dr. Jaina, for telling us and motivating us to do something for our own country, which is unique and which gives a solution to our cash crunch patients. Thank you.
Thank you. Thank you, Dr. Rahul. Thank you, everybody.
And thank you all the panelists, Dr. Shilpa, Dr. Mayur, doing a wonderful job at your local centers. Thank you.
Thank you.
So thanks, Dr. Rahul, for finishing this wonderful panel discussion and finishing even before time, as if he is trying to catch the international flight to Delhi. That it appeared to me. Anyway, thank you very much. It was a really very interesting session on multiple myeloma, starting from Dr. Dragon, who alluded at the mutation and its relevance in the overall prognosis and the therapeutic management of myeloma and the possible outcome in the future. Then I spoke on the newly diagnosed multiple myeloma from Indian perspective and practical problems vis-a-vis with international scenario. And Saji Kumar spoke a very excellent talk on the approach to the newly diagnosed multiple myeloma and both transplant eligible and transplant ineligible and the future roadmap by it. And then there was a wonderful panel discussion by moderating by Dr. Rahul Bhargav and with a lot of excellent panelists. They spoke on a real case scenario and how they manage in the very difficult disease. From even a third relapse, they could achieve the remission transplant. They could make him to work also. I'm sure a lot of messages, this panel discussion, everything has been given. With this, I thanks again on behalf of Eastern Emergency Group, all of you, all the faculties, all the panelists, and all the members who have really made this myeloma session very interesting. Thanks our sponsor, Johnson, for sponsoring this myeloma session. With this, it's over to organizer, please now.
Thank you, sir. Thank you all the esteemed speaker and the panelists. And it was beautiful. And we got the lesson that innovator is innovator. Generally, drugs may fail. So now with this, I would like to thank the sponsor and I invite my co-host, Dr. Malini, to take this program further. So over to you, Dr. Malini.
Thank you. And after this wonderful academic feast on multiple myeloma, we move on to the next session on acute leukemia and MDS. The session is sponsored by Plasmagen Biosciences. And as a session coordinator, I would like to invite Dr. Sharmila Chandra ma'am. And she is the president, Eastern Hematology Group, and she's a senior consultant hematology at Narayana Super Speciality Hospital, Havra. Over to you, ma'am.
Thank you very much and good evening to everybody. After the very lively myeloma session, we changed track and come to a very content-rich session, and that's on acute leukemia and MDS. And we have 4 speakers and the time is 1 hour. And I'll point out to my speakers that please look at your watch sometimes while speaking. And we will start with acute myeloid leukemia. And nothing much had changed in the treatment of acute myeloid leukemia since the time when I was a student. And 50 years, practically nothing much was changing in the field of AML. But now, in the last decade, we have had a lot of new inputs. And the most important input is in the diagnostic of AML. And we have Dr. Devdas Bose, who is a consultant hematologist from our own IHTM in Kolkata, and I will invite him to talk on the first lecture, Is NGS Necessary in the Diagnosis at the time of diagnosis of AML?
Thank you. Hello.
Yes.
Hello.
Hello, thank you, ma'am. I'm Dr. Devdas. Am I audible? Hello.
Yes, doctor, you're audible. You're audible.
Okay. Okay. So, good evening. Thank you all. So, my topic is does engage is essential in acute leukemia. So, regarding diagnosis of acute leukemia, particularly in AML, okay, in ELN and European Leukemic Net and NCCN has recommended mutation testing of 9 genes. These 9 genes for diagnosis of acute leukemia, particularly in AML, and gene rearrangement, PML, DARA, SEPA, and CBA, RANIX1, and BCR-ABL. So these gene mutation and rearrangement should be done for diagnosis of acute leukemia. And for prognostication, particularly in normal karyotype AML, cytogenetic study cannot.
Dr. Devdas, please share your slide.
Okay. Okay. Hello.
Yes, doctor.
Okay.
You can zoom it.
Okay. And other mutation, particularly predictable mutation. This predictable mutation may be
Doctor,
targeted.
zoom your slide. Zoom your slide.
Okay. Sorry. So, utility of NGS in diagnosis of AML. NGS can be used to diagnose the AML in view of in according to ALN or NCCN guideline. But because this conventional molecular procedure, particularly flow cytometry or RT-PCR, mainly RT-PCR, may be laborious to diagnose for mutation and these all fusion gene rearrangement. It will laborious, time consuming, and insufficient to detect minor clone also. And but these NGS can allow the parallel study of many genes simultaneously in one assay with very high sensitivity, around 90%. Whereas 40 to 50% of AML patient can be analyzed with quantitative PCR because fusion gene seen only fusion only 40 to 50%, and mutation also some other percentage of patient. And but multi-parameter flow cytometry can be used for 90% of patient in diagnosis, but prognostication, regarding prognostication, is multi-parameter flow cytometry is having very limited sensitivity. So I'll discuss some studies regarding diagnosis of AML. So Jufa et al. What published a study in OncoTarget in 2015. They showed some patient diagnosed by RT-PCR with capillary electrophoresis in FLT3 ITD, and this patient got midostaurin, but some of the patient relapsed, and they studied this relapsed patient and showed the subpopulation of patients shows the patients of FLT3 ITD, but diagnostic sample does not show any FLT3 mutation at the time. So they concluded that NGS is far better for studying FLT3 than the RT-PCR followed by capillary electrophoresis. Though ratified trial based on the RT-PCR and capillary electrophoresis, but this study clear-cut shows the utility of NGS in FLT3 ITD mutation. Okay. And to predict the response of hypomethylating agent in MDS and some cases of acute leukemia, acute myeloid leukemia in elderly AML, many studies shows different conflicting results, but only one study shows the presence of only DEL20Q was associated with improved survival. It is, and other studies are shows the conflicting results. So, but this DEL20Q can be diagnosed in cytogenetics only. So, predicting response of hypomethylating agent in case of AML or MTS, NGS is not useful, though there is many conflicting studies are there. To predict outcome after allogenic transplantation, NGS may be useful because mutation in P53, WT1, and FLT3 are associated with increased risk of relapse after allo-HCT, and this patient underwent NGS at diagnostics and as well as relapse sample, or these 6 patients so found to have clonal evolution at the time of relapse, but these 6 patients as cannot be diagnosed beforehand by RT-PCR because this clonal evolution, we have clonal evolution cannot be diagnosed in RT-PCR because RT-PCR diagnosed based on the known targetable mutation, whereas the NGS shows the wide number, very much more number of targetable mutation which can be applied, both can be diagnostic sample as well as your post-transplant sample. So NGS can predict outcome in allogenic transplantation in AML. So it can be, NGS can be used to treatment strategy, because to diagnose your mutation in FLT3, this BCL2, BCL2 for using venetoclax or IDH1 and 2. So because these 30% of patients shows FLT3, IDH and another 30% or 1 and 2, or your BCL2, some and regarding one study shows the presence of IDH mutation in associated with BCL2, so this gives a better prognosis. Okay, and also the JAK2 mutation for use of ruxolitinib. So all these genes can be studied in one specific assay by NGS. But if we do the all these gene study of all these genes, we need much more number of RT-PCR testing. So that will take time. But if you do the NGS, it will clearly can be done in one simple assay. And regarding fusion gene transcript, qPCR widely employed in fusion-based MRD detection. Because NGS-based targeted RNA sequencing achieved a comparable limit of detection with high multiplexing capacity. There is lots of data is there. So for fusion transcript, if fusion transcript is much higher number, then easy to detect. But if it is lower number, it is difficult to discriminate from the artifactual changes regarding your procedure of NGS procedure, or any passenger, or from the passenger mutation. But associated with, if we have the facility of interface fees, then we can exclude the false positive results in case of higher read counts. I will discuss some studies based on the NGS. These changes et al. They detected the reciprocal translocation in 58 ml cases with fusion transcript of this RX1, PGPFA, RARA, NPM1 based on the cytokines and FIS. And they simultaneously did the NGS by RNA sequencing, and out of this patient, 59% patient shows the presence of fusion transcript. So NGS can be parallelly used in case of fusion transcripts as well as mutation also. And the studies by Freeman et al. Okay, these most common method of MRD detection is multiparameter flow cytometry, which can be applied in 70 to 80% cases with limited sensitivity. And quantitative PCR also shows the good sensitivity around 10 to the power minus 6 or 2 10 to the power minus 4 to 10 to the power minus 6, applicable only in 40% of cases. But these both multiparameter flow cytometry and quantitative PCR MRD negative subgroup of patient ultimately relapse because of clonal evolution, because of fraction of pathological clone remains undetected, or there may be some new clone following treatment. So this can give rise to the relapse. Okay, so what they found, they simultaneously did the NGS and doublet digital PCR for assessment of MRD. They concluded that NGS and digital PCR digital PCR is comparable to better than qPCR and multiparameter flow cytometry, and there is and NGS is better than digital PCR for precision and accuracy. Another study by Spanish group in published in Hematologica, Onicha et al. What they showed, they have excluded the three mutation DNMT, asexual and TATE2 because of these three mutation associated with clonal hematopoiesis of indeterminate potential. So it can paradoxically signifies the presence of AML mutation. So they excluded these three mutation, and these three mutation NPM, IDH1 and FLT3 mutation they have studied, and they established the limit of quantification by tenfold dilution of the mixed mutated and controlled sample, and they found the digital PCR is LOD of the digital PCR is lower than the digital PCR is lower than the NGS. The digital PCR can detect up to 10 to the power -3, but NGS can detect up to 10 to the power -4. So LOQ is the for NGS has the much lower limit of quantification. That meaning the NGS can detect very much more number of cells, or around 1,10,000, one cell in 10,000, whereas digital PCR can detect one mutated cell in 1,000 cell. Okay. So digital PCR is not so efficacious than NGS. So in other words, NGS is better than digital PCR. Okay, and what they found, the MRD by MFC shows the hazard ratio of 2.10. This is comparable to quantity PCR, but MRD shows much more number of mutation, where hazard ratio is 4.22. So regarding prognostication, NGS is better than the both multiparameter flow cytometry and quantitative PCR. Another study done by this Jogden Lavrin et al. Published in NEJM 2018, they included 482 patients of 18 to 65 newly diagnosed AML. At least they have detected at least one mutation each, in 89% of patients. Mutation persisted. This mutation persisted 51% in complete remission with good number of variable frequency is 0.02 to 47%. After exclusion of this cheap mutation, DAT, that is your DNMT, asexual and TATE2, they showed the higher relapse rate. Hello? Hello? Hello, they showed the higher relapse rate and the lower relapse free survival in case of your using NGS. Okay. Another studies by Ito et al. They performed the whole genome or whole exome sequencing in 71% with 13 years follow-up. This they have used paired diagnostics and remission sample from 50 patients, including 32 with intermediate risk AML, and they did after in 30 they take samples after they took samples after 30 days after induction therapy. What they found, the 41% patients shows the leukemia-related mutation at least in at least 5% of bone marrow cells at remission, and they show reduced event-free survival and overall survival versus the 26 who cleared all mutation. So if we do here what they showed, these NGS detection of this mutation having the showed the reduced event-free survival and overall survival, where the if all the mutations is cleared after induction, then there is event-free survival and overall survival is much better than the persistence of the mutation. So there is definite utility of NGS in prognostication of these patients. Another study done by in our country, Dr. Nikhil Patkar, they also shows they have used third generation sequencing with error correction, and they showed that MRD can be detected. They did not compare your multiparameter flow cytometry or quantitative PCR with your NGS, but they have concluded that molecular MRD can be detected by using error corrected next generation sequencing. Now there is advantage of NGS. Hello, advantage of NGS in MRD assessment in AML. No single genetic abnormality is pathognomonic in all cases of MRD. So this is the limitation of multiparameter flow cytometry and quantitative PCR. This sensitivity comparable to quantitative PCR is 10 to the power -5, and the ability to detect variants and multiple genes using a single assay, and this multiplexing of this patient sample shows the increased throughput. Now, regarding myeloid gene panel, what type of gene panel should we use? There is currently there is the consensus regarding the use of number of type of genes included in myeloid gene panel. Commercially available gene panel are 5 types. Illumina is a company. The brand has 2 myeloid panel, 2 sites and amplicate, and human myeloid neoplasm by Chiasec. This is very commonly used. Leukovantage and Quest Diagnostics, and Seor6 by Oxford Gene Technology, and Archer variant plate score myeloid panel. These five panel can be used, but most commonly your Illumina and Chiasec is used. These are the number of genes. And type of sequencing needed by NGS is always targeted sequence type, because we all know the what type of mutations or what type of genetic rearrangement is associated with AML. So targeted sequence is your method of choice, and it usually decrease the number of cost also, amount of cost also. Whereas the whole exome or whole genome sequencing maybe use it fund permits, because they can identify other unknown mutation also, and including targetable or less frequently occurred mutation, but this will increase the cost also. NGS in ALL, current methods of ALL, regarding diagnosis of ALL, your NGS use of NGS is limited. Some of the studies available regarding your measurable residual disease in ALL, because flow cytometry has a sensitivity of 0.01%. It is widely accepted and widely available in ALL MRD, and ASO-PCR also based on the immunoglobulin and T cell receptor gene has a sensitivity of your 0.001%. But there is some limitation of flow cytometry and polymerization qPCR regarding the ALL MRD assessment. Flow cytometry requires a high level of expertise. And there is many number of antibodies required, and it does not have, and this MRD does not have a early there is a consensus regarding the use of antibody in flow cytometry based MRD in BLL, even in TML also, and this ASO-PCR requires the development of generation of the patient-specific primer. Regarding your MRD detection by allele-specific oligonucleotide PCR, This requires the development of the patient-specific PCR. After taking the diagnostic sample, you have to have a diagnostic sample, and then you have to analyze the immunoglobulin or your T cell receptor gene, and then you have to develop your own primer, this patient-specific primer, which is laborious and time-consuming. So, and it will take at least 4 to 6 weeks times to generate a patient-specific primer. So, ASO-PCR is very much sensitive for MRD detection in ALL, in BLL, but it is a B or TLL, but it is time-consuming and it is laborious. So, flow cytometry is much more accepted. But they cannot predict, both of them cannot predict the evolution of leukemic subclone during treatment. This will discuss with example of one study. Patient who achieve the MRD status by standard criteria, that is patient achieved the MRD cutoff of 0.0%, but having a very low level of persistent leukemia, it is less than 0.01%, maybe 0.001 or percent, but they have a higher risk of relapse than those who with no detectable MRD. Once this study done by Farham et al., what they showed, the relapse rate of MRD negative in MRD negative ALL is around 15 to 25% in beta risk group. NGS detected MRD in comparable with flow cytometry in 28 sample positive for flow, and 35 out of 36 shown to be positive by PCR. So NGS is comparable with flow cytometry and quantitative PCR for detecting MRD. In addition to that, NGS detected MRD in 10 and 3 additional samples, that sample were negative for flow cytometry and quantitative PCR respectively. So this results suggests this NGS is more sensitive than PCR and flow cytometry for detecting MRD. Another study is done by this Pulsipar et al. What they showed, this very high risk treatment, a very high risk AML, ALL, and they are eligible for allo-HCT. And in the detection of MRD done by NGS, this NGS negative MRD defined a lower risk population, and the relapse rate, but relapse rate, if we based on the if we take the MRD diagnosed by either your flow cytometry or quantitative PCR, then this MRD negative patient ultimately relapse around 15 to 25%. Because some clonal evolution occurs or some unknown mutation cannot be diagnosed by flow cytometry or your quantitative PCR. But
excuse me, Dr. Bose,
yes,
we have only 1 more minute for you. There's a big time constraint.
Okay, ma'am. I'll complete. Okay, within 1 minute. Okay, and what they they showed these NGS up by your immunoglobulin chain or TCR rearrangement, this better prediction of your post allo-HCT transplant than the flow cytometry or your quantitative PCR. But before interpreting the NGS has definitely some your drawback. Before interpreting the NGS result, you have to exclude the driver mutation from the passenger mutation. So because some technical your aspect should be taken before interpreting the MRD by NGS. Okay, and you have to exclude the chip related mutation, DNMT3, TATE2, or ASXL1, and this chip related mutation is common in usually elderly age group, and quantitative this can be easily diagnosed by your increased number of variable VAF compared to diagnostic sample. And germline mutation, regarding discrimination of germline mutation, we have to take thorough family history and genetic testing, and mutation testing, taking sample from the skin, fibroblast, and saliva, and again the high and stable VAP from your diagnostic sample, and your also in your post therapeutic sample gives the clue of the germline mutation. Okay. So some technical challenges remains, but you have to be cautious regarding your acceptance of NGS data. These data, your maybe huge, maybe huge. All of the data cannot be, may not be used for clinical usage. So summary should be NGS can be of use for mutation, both for mutation study and gene rearrangement in diagnosis of AML, and if fund permits for prognostication and predictable mutation also. But use of NGS in ALL is limited, as cytogenetics and flow cytometry can diagnose ALL and stratify. The risk stratification can be done well in ALL. So flow is also widely used for detection of MRD in ALL.
Thank you, Dr. Bose.
Thank you.
We'll have the questions later on after the next speaker talks. And we already have Dr. Kishore waiting for us.
Okay,
Can we? Admin, can you please?
Stop sharing?
Yes.
So we have heard that AML is a heterogeneous disease, and now we come to the next important topic in the field of AML, and that is the recent additions to the induction regimen in AML. And we have a very important speaker, Dr. Kishore, and he is a hemato-oncologist and BMT physician in Mayot International Hospital in Chennai, and you can see all his achievements on the screen. And please, can you focus your slides and
Yes,
start your lecture, please?
Thank you very much, ma'am. That was indeed very happy to be a part of the lecture where you are chairing the session. Thank you, the entire team, and especially Professor Tufan for giving me this opportunity. We are really kind of constrained with time, so I'll try to restrict myself as much as possible within 15 minutes. So as a classical thing, yes, ma'am was just starting the lecture saying that for the past 30 to 40 years, nothing has changed. There are two diseases where nothing much happened. One is aplastic anemia and the other one is AML. So people have tried a lot of things, 7+3, they have made numerical calculations of 7+3 into multiple things, added newer chemotherapies, but actually speaking, at the end of the day, nothing much was happening. If you really go into the CR database, the real life data, a patient with AML living after 5 years diagnosed today is hardly 20 to 30%. That is the hardcore reality of AML. But still, we are kind of keeping hopes, and the topic was quite interesting for me, that I'm able to see that a lot of newer things are happening. I think maybe down the years, AML is going to be like myeloma, what we heard some time back. Dr. Bose very clearly said that NGS, yes, it has got a role, but sometimes what happens is one part of AML is all the theoretical clonal evolution, because now the myeloid mutations itself are becoming a global kind of a mutation profile where we get a lot of data, and sometimes it just confuses not only us but also the patients. They keep on asking us, what are we going to do with that DNMT or ASXL or whatsoever. So yes, NGS, yes or no, if it is possible, patient is okay, yes, we can get on with an NGS, but to act on the NGS at this point in time, I think we are kind of yet to reach out there, I suppose. But the problem with AML is quite different when it comes to the clinical side, because a lot of things, especially with the high rates of refractory gram-negative sepsis in our country, the induction regimens, the types we are going to choose, everything depends upon the clinical presentation and the comorbid condition the patient has got. So to be more frank, if I want to just do it as a BC and a AD, I will say that before the entry of generic hypermethylating agents in our country, this is what I used to do. Say as a DM student in an examination, if I'm asked what I want to do, a young fit individual, 7+3 induction was kind of quite standard, and when it was a old, frail and unfit individual, many times it was quite like book your tickets to Kasi or Rameswaram. That's nothing much to be done. A load of Sarasi, hydroxyurea or palliation, these are the things people used to do. But I think 2013 or 12, that range, when decitabine started coming into our Indian market, especially the generic decitabine started coming, that I will personally feel is a big game changer in this particular field, because slowly, initially we were starting to use in MDS, slowly we started using it in the older patients coming with AML. And I think with our own data, 5-year follow-up data of azacitidine and decitabine, definitely this has at least improved the quality of life in those patients where it is kind of acting. So if you really ask me, one major change that happened over the last 5 to 6 years is addition of these hypomethylating agents in those patients who are kind of unfit. If you really look at this picture, I have never mentioned any ages, because it's a real confusion. Sometimes in our country, if I say above 65 use these conditions and less than 65 go for a 7+3, it is never going to be a case. There are certain situations where clinically we have found that the patients are not well fit for a 7+3, even in their 40s and 50s, where we have used these hypermethylating agents as a part of the initial induction to stabilize the patient, get him out of sepsis, and then consolidate with some kind of a chemotherapy or a transplant. Because the aim is, I want a kind of MRD, in the sense, not a very stringent flow MRD, at least a morphological MRD. I have to achieve it. Either way I achieve, that is all fine with me. Either it is 7+3 or hypermethylating agent, that is all fine. But looking at just hearing to Dr. Bose, there are a lot of things that are happening now. We have got a whole lot of mutational analysis that is coming up. So now we have got certain things getting added on in a meaningful way to the induction regimens of acute myeloid leukemia. So I'll go in a case-based discussion. So there are only 4 cases. I think I will finish off in another 8 minutes or so. A young male who has been diagnosed ECOG performance status is great. A very box standard AML, how a patient presents to us. The classical thing is the flow cytometry was showing a homogeneous bright positivity with CD33 in this patient, and cytogenetics was involved, kind of revealing an inversion 16, which theoretically has got a better prognosis. As such, the NGS panel was kind of non-contributory, nothing much was there. So this patient was put into a standard, or indeed a good risk category, and they wanted to do a 7+3. So what else can be done at this point in time? The newer drug which kind of went away and then came back with a modified dose is this GO, which is gemtuzumab osagamycin, which is an antibody drug conjugate. Now people are finding that, especially in patients who are kind of falling into the favorable karyotype, who are having a good bright expression. I think this is an era of kind of targeted immunotherapy, I should say, where it has been proven that we can use this drug, anti-CD33 antibody drug conjugate gemtuzumab osagamycin, in patients who are kind of otherwise fit. It has been, I'm not going to the details of the data, but it has been proven by the studies, especially the study, the alpha study, because AML 19 was a study where they used it in older patients as a single agent, but alpha study was the one which they added this GO with chemotherapy, and they found that the significant p-value, there was a difference in the event-free survival of these patients. And theoretically in the Western data, it says that the cytopenias or the other side effects are not that common. But is it really possible in our Indian settings? At least it is, I think it is available on a compassionate use basis, but we are a bit worried about adding anything to 7+3 because the additional cytopenia that can cause. But I think looking at the data, what they say, nothing wrong in trying. But VOD is one concern, where if the patient is going to be going for a transplant, VOD can be a concern with this. So that is one change that has happened in box standard AMLs for favorable karyotypes. GO adds some sensible life to the patient with 7+3. Now coming to this patient, is again a kind of a young individual, a fit individual. The issue is here is he has got a FLT3 positive status. Allelic ratio is not that standardized in our country, I should say. Just presence or absence is what we look into many times. So with NGS or whatever panels with the mutation, if FLT3 is positive, one sensible addition which can be done to the induction regimen, which we can do at present in our country, is to add this mitostatin. Yes, mitostatin, we know it's just a tablet. It's a ratified trial which proved that addition of this specific FLT3 inhibitor made some sense. But actually in our country, we have been using, even before the event of mitostatin, we have been using sorafenib, but it had its own toxicities and things. But relatively being a very original product that is available at this point in time, we have our own data of 6 patients where we have used mitostatin. But instead of using mitostatin, we still feel that FLT3s are going to be bad. So naturally, we are going to kind of consolidate as early as possible the patient achieves the CR1 with an allograft. It has been proven that using a mitostatin in this induction regimen, achieve a CR1, get on with the transplant, that gives a relatively better overall survival compared to not using a mitostatin. So other drugs, gilteritinib is another FLT3 inhibitor which has got FDA approval as a single agent therapy in relapsed refractory cases with FLT3 positive status. So these are the two drugs which are kind of getting their role in the induction therapy, the newer induction therapy in AML. Now coming to this third case, again, kind of an old man, 70 years. He has got MDS, prior MDS, around a normal cytogenetics. His ECOG performance status unusually is quite good, and he has got 80% cellularity with 24% blast, intermediate cytogenetics, no FLT3 or IDH. So what to do? If you really ask me what I would have done for this patient is start an azacitidine and dasatinib. But looking at the data now, some always you have at the back of the mind, okay, so 61, 62, 55 to 60 something, that range who have got a good performance status, we sometimes feel that are we missing that tinge of some daunomycin and cytarabine. So for this only the newer agent that has come up, which can be theoretically used, though we don't have an access to it right now, is a CPX351, which is actually, it's like it's a ready-made mixture, I should say, of the same daunomycin and cytarabine at a proper molar concentration, and also it is in a liposomal formulation so that it goes and gets attached to the blast in a very proper way. So this is proved that again in patients who are kind of treatment related or secondary AMLs who are kind of fit, but I don't know how far it's going to be true in non-Indian conditions, but there is a theoretical possibility of using this CPX351 in those patients in place of hypermethylating agents. Now this is another very old man who has got both FLT3 and IDH wild types are there. Box standard AML, kind of mostly a secondary AML performance status is not that good. 2-3 years before till we were having this hold of this venetoclax, our thing has been to use hypermethylating agent, either azacitidine or dasatinib, depending upon the center's experience. But off late, one thing that is added up to this HMA therapy is venetoclax, because we are getting venetoclax from different sources. So this is a study which the VIAL study which proved that addition of this, I don't know, somehow all of certain venetoclax is being used in every hematologic malignancy you can think of. It proved that it can achieve a deeper, not only a deeper and very earlier response. I don't know, because to be more frank, in the VIAL study, if you see, even at the start of the second cycle itself, there are half the patients who are going into CR. But practically in our country, using 400 milligram addition is not that practical. We start with 100, many times just continue with 100. But what we have seen is in the initial 3-4 cycles, if the patient is able to get out of the cytopenia and sepsis, they do really well with this addition of venetoclax with posaconazole at a lower doses. So last but not the least, it's IDH mutations which are now available in the NGS platforms. If it is there, theoretically, one addition what we can do is just add with the 7+3 the ivosidenib, which is an IDH1 inhibitor, or enacidinib, which is an IDH2 inhibitor. This we don't have any personal experience, but it's just in looking at the data, it looks quite interesting to add this type of inhibitors. That's what I wanted to say. To be more frank, the AML thing is kind of expanding. They're using nearly every drug that is possible. These are the different investigational agents that are in ongoing trials. And one thing which is kind of maturing is nivolumab again. Nivolumab in Hodgkin, nivolumab from solid organs. It is finding its way into leukemias also. And the newer BITE antibodies are also there as an investigation agents for AML. You'll be very surprised to see that there are around 20 drugs right now available in clinical trials for that matter, at least not FDA approved. And there are theoretically 1,000 possible combinations which can be done in AML. So I think in the next 10 years, a decade later, I think AML will become even a chemo-free, total chemo-free regimen of AML, or even a world treatment-based regimen of AML is something not very far away. So this is what the research is targeting at this mutational agents. But unfortunately, cytotoxic in our country, especially 7+3, has still got to play its role at least for the next decade till all these agent data are going to mature. So thank you very much for the opportunity. I think I hand over the mic to Professor Sharmila. Ma'am, I think you're on mute.
Dr. Kishore, please stop sharing.
Oh, yeah.
Thank you for giving us an overview of the more personalized view of AML treatment in the future. And I think we will have all the questions at the end and finish off with the talks right in the beginning. Thank you very much. And we have the third speakers, who is Professor Tufan Kanti Dolai, our very dynamic scientific secretary. And you can see his achievements on the screen. And he is going to talk to us about the treatment of low-grade MDS. Yes, Professor Dolai.
Thank you, ma'am, and good evening to everybody for the kind introduction. So I will be speaking on the treatment of the lower risk myelodysplastic syndrome. Like the AML, the lower risk myelodysplastic syndrome, the area is also become expanding. So I will be speaking on the recent classification in the brief, the treatment of the anemia, thrombocytopenia, neutropenia, and the other refractory cytopenia, the targeted therapy, and what we do in our clinical practice. Basically, the MDS is the chronal disorder, has a cytopenia, has a dysplasia, has an ineffective hematopoiesis, and there is a lot of recurrent genetic abnormality, and down the line patient develops the acute myeloid leukemia and become dying. So basically the MDS is developed due to the lot of the problem. The exact myth pathogenesis is not known due to the immune attack, the environmental exposure, the aging, ultimately the epigenetic changes, the somatic genetic changes, ultimately the MDS initiating cell, there is a cytopenia, and in the other hand, they progress to the AML. So from the pre-malignant condition to the more malignant condition of the myelodysplastic syndrome, because it is a chronal hemopoietic disorders. So in this disorder, it start from the non-clonal disorder from the chip, the arch, and the icus, and also from the cicus, and ultimately developing to the AML and the secondary myelodysplastic syndrome. Basically, from the pre-malignant to the malignant condition, depending upon the development of the disease, we got a different mutational abnormality and the genetic abnormality in patient with myelodysplastic syndrome. So basically, it start with the cicus, that is called the icus, it is called the cytopenia, then followed by the chip, the somatic mutation. In the cicus, there is cytopenia and the somatic mutation. In the MDS, all the four is there. Patient has a cytopenia, has a somatic mutation, has a dysplasia, and also cytogenetic abnormality is there. But currently, we are treating the low risk MDS, the high risk MDS, and also the secondary, the AML, and also the AML. And depending upon this, the risk of abnormality from the non-clonal to the clonal, there is a lot of abnormality is there. I am not highlighting it, but in terms of this, the low risk MDS, the more common cytogenetic abnormality is the trisomy 8 and the deletion 20q, and the molecular abnormality is the TET2 and the SF3B is the more important molecular abnormality we encounter in our low risk MDS patients. We are familiar with the 2016 WHO classification of the myelodysplastic syndrome. But yes, in clinics, we divide the patient based on the risk stratification on the IPSS, IPSSR, and the WPSS, and we divide the patient in the low risk and the high risk. Depending upon that, we'll choose our therapy in the low risk MDS, because the two type of the disease is totally different. In the low risk MDS, the survival is somewhat better. In terms of the high risk MDS, the 10-year survival only 10 to 20%. So the two is the different, not only to the survival, but also their pathogenesis is totally different. In terms of the low risk, the apoptosis and the differentiation is the male important pathogenesis. In terms of the high risk, the proliferation and the percentage of the blast is the more important in terms of this myelodysplastic syndrome. So in the low risk MDS, if the patient has a symptomatic, then only we treat it and supportive care when it is required. In terms of the treatment of this, the symptomatic anemia, whether it is from the deletion 5q or without the deletion 5q syndrome is there. If the patient has a deletion 5q syndrome, we usually use the lenalidomide. And if the patient has a non-deletion 5q syndrome, then we are using the lot of drug, particularly the ESA, the darbepoetin, the lenalidomide, and more recently the luspatercept. In terms of the use the romiplastim, eltrombopag from the platelet transfusion, the symptomatic neutropenia, hypomethylating agent, supportive care, treatment of the infection, and also the multiple cytopenia, the refractory, we use the hypomethylating agents, sometimes the transplant and the targeted therapy. MDS patients develop anemia due to the ineffective hematopoiesis. There is abnormal iron utilization, and sometimes there is the SF3B mutation. A lot of the other genetic abnormality becomes land up with anemic symptom. In terms of the deletion 5q, we treat if the patient has a symptomatic, means transfusion dependent, and the drug of choice is the lenalidomide. Our toxicity and activity has been proven by the MDS-001 trial, and based on this MDS-003 trial, the lenalidomide have been approved by the FDA in 2005. Basically, the lenalidomide is acting by upregulating the gene involving the erythropoiesis, and also it improving the hematopoiesis. It is an immunomodulatory effect and also had an angiogenesis effect. Based on this, the MDS-003 trial, in the 10 mg of the lenalidomide, if you give it, the erythropoietin, the erythroid response is around 65%. And if you consider the cytogenetic response is around the 83% of the del Q5Q syndrome. This is another trial, the similar result, around 70% of the patient, they become transfusion independent if we use lenalidomide in case of the 5q deletion syndrome. But what about the non-Q5 deletion syndrome? The ESA, particularly the erythropoietin, the darbepoetin, plus minus GCSF, there is a lenalidomide, the luspatercept also is there, and obviously the iron overload is become problematic. In terms of the EPO, is basically the erythropoietin attached to the EPO receptor causes JAK states pathway stimulation, and ultimately it stimulates the erythropoiesis. Not only the stem cell but also the erythroblast and the other all the stages of the erythropoietic development. They stimulates and ultimately they become improving the anemia. Before prescribing the ESA, you should score it whether your patient is responded or not, depending upon the EPO and depending upon your transfusion. If your transfusion requirement 2 or the more and the erythropoietin is more than 500, your patient is not likely to be responded with the ESA. So what about the EPO and the non-EPO, the randomized trial? Basically the 40,000 weekly vis-a-vis the 80,000 and vis-a-vis the placebo, the data has been clearly shown us that around 30% of the patients become benefited if we use the erythropoietin vis-a-vis the placebo, and the medium time to the first transfusion and also time to the first transfusion after the 4 weeks becomes improving if we use the EPO. But you should remember the hypertension and the seizure and the thromboembolic episode in terms of this EPO. What about the EPO plus GCSF, the randomized trial, the systemic review is there. If we use the EPO to the GCSF, there is a modest improvement of this rate, particularly around 70% of the patients have responded, particularly in case of the anemia. What about the darbepoetin? Due to the carbohydrate moiety, they have the half-life is more. In terms of the 9 microgram per kg per week plus GCSF, there is a 2.5 milligram per week, twice weekly. If we consider the response rate, around the 50% of the patient, they have major response rate. Yes, you have a problem with the hypertension and the renal insufficiency, you will keep it in the mind. Apart from the low dose decitabine, low dose the darbepoetin, there is a high dose darbepoetin data is there. The 300 microgram weekly vis-a-vis the 500 microgram every 3 weekly. Here the erythroid response is 70% vis-a-vis the 14%. So it conclusion that the erythropoietin, the 60,000 weekly and darbepoetin 300 weekly is the base doses we can use to treat the patients with anemia, particularly for the ESA stimulating agent. What about the lenalidomide in case of the low risk MDS? That is particularly in case of non-Q deletion. The response is around 25% vis-a-vis the 2% with the placebo. So we can use the lenalidomide also, depending upon your EPO level. If your EPO level is less than 100, 40% of the patient become responded to the lenalidomide vis-a-vis the prior using agents. If the prior ESA is used, your 30% patient is still responded to the lenalidomide. So EPO level and the prior ESA is not a cutoff for initiating the treatment with the lenalidomide. What about the new drug called the luspatercept? It has become recently approved by the FDA, the April 2020, for particularly the transfusion-dependent ring sideroblast MDS patients. It is basically a TGA beta superfamily, has enhanced the late stage of the erythropoiesis, and the luspatercept have been given 1 mg quickly subcutaneously 3 weekly vis-a-vis the placebo, and the data has been shown that in the 2 months and the 3 months, around the 30%, 30 to 40% of the patient, they have a erythropoietic response vis-a-vis the 10% with the placebo that have been statistically significant in terms of this response. So the luspatercept is one of the drugs that can improve the erythropoiesis also. By giving the repeated transfusion, there is iron overload that causes generation of the reactive oxygen species. There is hematopoietic insufficiency, DNA damage, there is anti-signal apoptosis. Ultimately, the survival of the patient of the MDS becomes going down. So if you use the deferracirux vis-a-vis the placebo, your survival is improving around the 38% vis-a-vis the 43%, 60% vis-a-vis the 30% with the placebo in terms of the survival. So if you use the deferracirux, the survival of the MDS patient becomes improving. There is a different guidelines recommendation for initiating the chelation therapy in the NCCN, more than 1,000. In case of the American, more than 2,500, you can use the particularly the deferracirux group of the drug. In terms of the managing the thrombocytopenia, apart from the platelet transfusion, the romiplastim and the eltrombopag has a role in neutropenia, the hypomethylating agent, and the vaccination. We can use it in terms of the treating the thrombocytopenia. Why it is so important? Because there is around 13% of the patient may die due to the hemorrhage, and there is increasing bleeding risk because our macrocytes become dysfunction. So there is intrinsic functional defect of the dysplastic macrocyte, and sometimes the MDS become elderly. They have a lot of the concurrent medication, particularly the aspirin, the platelet inhibitor, and the ibuprofen, leading to the hemorrhagic risk. So we have to treat the patient with the platelet transfusion and the TPO receptor agonist. There is a two data is there, particularly in case of the eltrombopag and the romiplastic in this aspect. of the treatment with thrombocytopenia in case of low risk MDS. In terms of the L-thrombophac, we have to use the 50 mg and gradually escalate to 300 mg also vis-a-vis the placebo. And in terms of the treatment response, in terms of this the bleeding risk, in terms of the platelet increment is there, but there is an increasing blast percentage also in there in case of the trial. Similarly, in case of the romiplastim also, the platelet response is around 36% vis-a-vis 3.6% of the placebo, and the bleeding events and the platelet transfusion has become significantly reduced in case of the romiplastim vis-a-vis the placebo. But concern about the excess blast, particularly the AML transformation, though the long-term follow-up data is not demonstrated in terms of the AML progression of the death. There is another trial of the romiplastim. The same thing is there in terms of this improvement of the bleeding risk and the platelet requirement in case of the myelodysplastic syndrome. So in conclusion of this TPO receptor agonist, that it improved the thrombocytopenia, it decreased the bleeding risk, and also in 10% of the cases there is increasing circulating blast. You have a caution, so the close monitoring has become recommended, and don't use the TPO receptor agonist if you have a more blast, particularly the more than 5% of the cases. But sometimes patient become refractory anemia, patient is sometimes refractory thrombocytopenia, refractory neutropenia. Sometimes the patient has a multiple cytopenia is there. What is your option? If the patient has a hypoplastic MDS, then we have to use the ATG plus cyclosporine. Otherwise, we have to use hypomethylating agent, the transplant, and also the targeted therapy. In terms of the hypocellular MDS, if the patient is young, patient blast is less than 5%, has a HLDR positivity, we can use the horse ATG plus cyclosporine. Your 30% of the patient is going to respond. In terms of the rabbit ATG, also around 33% patient is going to respond. There is another trial that rabbit ATG becomes inferior than the horse ATG in terms of this the response rate. If it is some not in the hypocellular MDS, then in that group of the patient we have to use the hypomethylating agent. Normally, we use the hypomethylating agent in the high risk MDS, but yes, there is a data in the low risk MDS also. The dose is the 20 mg per meter square. Usually, we can use daily for the 3 days or weekly for the 3, or you can use the azacitidine, the 75 mg per meter square weekly for the daily for the 3. There's a lot of the data is there. And also the weekly and the daily dosage data is also available, and more recently the oral azacitidine data is also available. Basically, the hypomethylating agents is basically the causing the DNMT sequestration rather than does not influence the de novo DNA synthesis in patient with myelodysplastic syndrome. In terms of the low dose azacitidine vis-a-vis the decitabine has been given 20 mg per meter square of IV over 1 hour for the 3 days, and azacitidine has been given the 75 mg per meter square IV over 1 hour or subcutaneously for the 3 days every 4 weeks till progression. If we consider the response rate here is 70% patient become responded, and it become 50% patient become responded after the 2 cycles, and cytogenetic response rate is around 60% vis-a-vis the 20% of the patient with myelodysplastic syndrome. There is a randomized control trial is there. The same thing has been depicting that there is increasing overall response rate if you use the low dose decitabine and azacitidine also. There is a oral azacitidine data is available. In terms of this cohort, they have given the subcutaneous dose 7 days vis-a-vis the oral dose is there, and the response is around 70% in case of the subcutaneous vis-a-vis around the 40% of the patient become responded if we use the oral azacitidine. There is another trial that is called the phase 3 study of the oral azacitidine. Here the patient have been given the oral azacitidine 300 mg daily for the 21 days plus base supportive care. The cycle has been repeated every 28 days vis-a-vis the placebo, and the overall response is around 40%. Hematological response is around 28%, and the RBC transfusion dependent is around 47% of the patient. Is there any role of the transplant in the role of in the low risk MDS? Yes, if the patient has a FAT, if the patient has a low risk, along with the post genetic risk factor, if the patient has a profound cytopenia, the life-threatening cytopenia, there is a high transfusion requirement is there. If there is a high risk molecular abnormality, yes, we go ahead with the transplant. They become international panel recommendation that if the patient has a FAT, there is a poor risk feature, available donor, go ahead with the stem cell transplant technique. More recently, in the AS Education Book 2020, they have been giving the Monte Carlo analysis in terms of deciding the therapy in case of the low and the intermediate risk of the MDS, particularly looking the quality of the life in MDS vis-a-vis the quality of the life of the transplant. If your quality of the life with MDS is better, don't do the transplant. If your quality of the life with transplant is better, so go ahead with the transplant. So we have to manipulate it, we have to adjust it depending upon your the quality of the life. And more recently, a lot of the targeted therapy has been evolving, particularly the roxadustat, the imlistat, and the evocinate, all into the phase 3 trial. I think very recently the oral, the roxadustat, and the evocinate becomes approving for patient with the low risk MDS. So at the end, what will be our treatment strategy in patient with low risk MDS? If the patient is asymptomatic, don't treat. You monitor the CBC every 1 to 3 months until the symptom or the disease progressions. If the patient has a symptom, then you treat the patients. If the patient has isolated anemia, particularly the hemoglobin is less than 10, the transfusion dependency is there. If the patient has a deletion 5q, go ahead with the lenalidomide. If the patient has a less than 500 of the EPO, then we can start the EPO, means the ESA plus minus the GCSF is there. If it is non-responded, then go ahead with the lenalidomide. If the patient has the isolated thrombocytopenia, particularly the less than 20,000 platelet with the bleeding, then supportive treatment, then we can either use the eltrombopag and thromoplastin. If it is progression, go ahead with the hypomethylating agent. If the patient has isolated neutropenia, apart from the GCSF, which becomes not recommended recently, you give the vaccination and you treat the infection. And also, if the recurrent infection, you give prophylaxis with the antiviral and the antibacterial agent. If the patient has a multinuclear cytopenia, refractory cytopenia, then go ahead with the hypomethylating agent, particularly the low dose hypomethylating agent. And if the patient fit the indication of the transplant, you go ahead with the stem cell transplant also. Hypoplastic MDS, go ahead with the ATG plus cyclosporin. If none of the treatment is becomes effective, go ahead with the targeted therapy, the roxadustat, there is the imlistat, the data has been evolving. With this, thank you very much for the patient hearing, and we become happy to answer the few questions at the end of session. Over to the Surmila ma'am.
Thank you very much, Tufan, for this bird's eye view, a very quick bird's eye view of the treatment of low-grade MDS. I think we'll put the questions at the end and start with the fourth session right away. And I will invite Dr. Shonali Mahapatra. She is from Apollo Bhubaneswar and can you focus? Yes, Associate Professor in AIIMS Bhubaneswar. And she will talk on the treatment of relapsed ALL in children. Can you start, Shonali?
Yes, ma'am.
Yes, please give the PPT mode.
My screen visible, ma'am?
Yes, your screen is visible.
Okay. So thank you, ma'am, for your introduction. So I'll talk regarding, good evening, everybody. I'll talk regarding treatment of relapse ALL in children. So over the past few decades, the survival of ALL in children has progressed a lot, so that more than 80% of children are eventually survival in children with ALL are more than 80%, but still then 15 to 20% of children with ALL, they relapse. And why it's important that the relapse ALL in children is the fifth most common malignancy, and it equals to nearly newly diagnosed cases of RMS or Wilms tumor annually. Though the relapse happens more commonly in the first years of starting of treatment, but it can occur in later years also, like up to 10 years from the diagnosis. And the current cure rate with all these therapies available is around 50% only. Then regarding the sites of ALL relapse, so whether it is a medullary relapse or extramedullary relapse. And extramedullary relapse, it may be CNS or CNS commonest, or testes and others like skin, eyes, these are less common. And in bone marrow, when more than 5% blast is there, then we record as a medullary relapse. And you combine if it is medullary as well as one extramedullary site is involved. Then when we call that isolated extramedullary relapse. So isolated extramedullary relapse when more than equal to
5 cells per cubic of leukemic blast are present in a cytocentrifuge preparation, or there are overt signs of CNS disease like in CT or MRI there is a mass or other features of CNS disease. Then isolated testicular relapse, the leukemic infiltrations in the test is demonstrated by biopsy. So what are the percentage of relapse by site? So this is isolated marrow relapse is the commonest. It is more than 50% cases happen with isolated marrow relapse, followed by isolated extramedullary, that is seen as the commonest, around 21%, followed by the combined, that is medullary as well as, contributes to around only 5.3, around 5% of the cases, and the rest are rare. Then what is the pathobiology of relapse? The pathobiology of relapse is like some clonal cell population are non-eliminated, or there are pre-existing drug resistance clone that got selected, or de novo second leukemia from a common pre-malignant clone which happens more commonly with late relapses, or usually present as minor subpopulations at diagnosis, so expands during treatment that happens with relapse clones, or other recurring genetic aberrations like mutations and deletions of tumor suppressor gene, the TP53, deletions in the NR3C1, or deleterious mutations of other genes. Then features that primary diagnosis. You all know that what are the primary diagnoses which are responsible for increased risk of relapse primarily at the time of diagnosis for childhood ALL. We know that age, if it is less than 1 year or more than 1 year, and hyperleukocytosis, and if poor prednisolone responders, or MRD positive markers like whether if Philadelphia positivity or MLL translocations or hypodiploidy, or intrachromosomal amplifications of chromosome 21. So these are the features if present at the primary diagnosis, then there are chances of increased chance of relapse. But these are per se are not taken into consideration when we re-stratify the relapse. Then the stratification of relapse, depending upon the length of the first CR1. So different groups like BFM or COG and St. Jude, they classify differently. So if it is from diagnosis within less than 18 months, if relapse is occurring, then it is very early as per BFM, early if it is between 18 to 30 months, and late if it is more than 30 months. Similarly, COG, if very early if it is less than 18 months from diagnosis, and late if it is more than 3 years from the diagnosis. And St. Jude, it is early if less than 6 months from completion of frontline therapy, and late if it is more than equal to 6 months from completion of frontline therapy. So basically, when the re-stratification is taken into consideration of relapse, then three things mainly taken into consideration: the timing of relapse, whether it is very early or late, then the site of relapse, whether it is medullary or extramedullary or combined, and the phenotype type of the leukemia, that is B or T. So more often these T leukemias are high risk, comes under high risk stratification, and B under depending upon whether it is isolated. If it is late isolated extramedullary, then more often comes at a standard risk. But again, if it is early or very early medullary, then it comes under high risk. So basically, isolated extramedullary late, they do good, of course, of B variety, and T variety do bad even if they are late. So re-stratification schemes for first relapse of different categories like COG, BFM, this group, or CCLG group UK. These are the groups which are active in pediatric ALL cases. So basically, a low risk category are late, as per COG, late marrow relapse or late isolated extramedullary relapse. High risk are early or very early B marrow relapse or T relapse. Similarly, late isolated extramedullary are always of low risk, and similar the same thing, high risk are always very early or early, and even very early extramedullary relapses are also high risk, and T varieties are high risk. So what are the prognostic factors in during relapse? So more common, most important thing is timing of the relapse, whether very early or late, then the site of disease recurrence, whether medullary or extramedullary, and immunophenotype, whether B variety or T variety. And after we start reinduction, the response to treatment, whether it is MRD positive or MRD negative. So these four things are taken into consideration in the prognostic factors when relapse stratification is done. Then the treatment approaches of relapse. So treatment approaches of relapse, new chemotherapy drugs can be tried, or novel combinations of chemotherapy drugs and combination of other new agents to other known active agents, or monoclonal antibodies directed against the leukemia cells, or drugs that stimulate the body's immune system to attack the leukemia cells, or chimeric antigen receptor or CAR T cell therapy. Then different groups are trying devising relapse protocols. So these are some of the protocols which have completed the trials, and their response rate is like UK ALL R3 protocol and ALL RAISE BFM 2 protocol are more commonly used, and they have their progression-free survival is around 60%. And this COG-AALL 1331, which also included this blinatumomab, which is a monoclonal antibody, and they find it the overall survival of around 80%. So this blinatumomab arm has survival advantage over the chemotherapy arm. Then when you look around the R3 study protocol, which are commonly used in ALL relapse protocols. So first chemotherapy is given for 4 weeks. Then post-induction MRD is assessed. So post-induction MRD, if it is less than 10 to the power -4, then patient continues with the chemotherapy arm. But if MRD is positive, then again after consolidation, MRD is done, and accordingly patient goes into transplantation. So the newer study which has just been completed taking into consideration this blinatumomab. So blinatumomab is given for 28 days, then 7 days off, and in between dexamethasone is given 1 cycle. So during this study was stopped actually in September 2019 because they found that the patients with blinatumomab arm done a very good has survival advantage over the chemotherapy arm. So all the chemotherapy arm children were crossed over to the blinatumomab arm. So what is blinatumomab? It is actually CD3, CD19 bispecific T cell engager with demonstrated efficacy against BALL in children and adults, and it mediates formation of a synapse between the CD3 plus T cells and CD19 plus target cells, and it upregulates the cell adhesion molecules with production of cytolytic proteins and release of inflammatory cytokines. So it then it redirected lysis of the CD19 positive target cell, and it is FDA approved in 2014. But its cost is exorbitant, so I don't know in a low and middle income country like us how many can afford this drug. So treatment based on risk stratification. So treatment based on risk stratification by different groups like BFM group or COG group. So most of the time, if it is first remission, late relapse, and if it is late relapse, extramedullary relapse, then treatment continued with chemotherapy and radiotherapy. But if it is very early, or early, then patients are given treatment as transplant option. The same with COG. So basically, if it is late relapse, then medullary or extramedullary can go with chemotherapy and local radiotherapy. But medullary early, very early, then transplant is an option. Then when you take off this extramedullary relapses, then CNS relapse. What are the principles of treatment? The principles of treatment is systemic chemotherapy and radiotherapy need to be given weekly intrathecal until 2 consecutive CSF is clear. No further intrathecal following cranial radiotherapy. And triple intrathecal is considered superior to only methotrexate intrathecal in patients with overt CNS leukemia. In non-transplant setting, 24-gray cranial irradiation has to be given starting from week 14, and in other cases, 18-gray can be tried in non-transplant transplant setting. But if the patient has received the prior radiotherapy, then it can be changed to 15-gray. Then testicular relapse. So testicular relapse also 24-gray in 12 belly fractions can be given to bilateral testis. Again, it starts at week 14. Then there was controversy regarding orchidectomy versus radiation. There's some found that orchidectomy has best survival advantage, but both are equal. And prophylactic RT to the non-involved testis can be given 15-gray. And because of local RT, infertility will be there, needing hormone replacement therapy. So if we go for this algorithm for children with relapsed ALL management, then if it is BLL, whether it is isolated marrow or combined relapse, whether it is early or late, then we have to give a 4-drug chemo induction. With 4-drug chemo induction, post-induction, we have to assess the MRD. If the MRD is less than 0.1%, then we can continue with the chemo arm. But if it is MRD is positive, can go for this molecular antibody, that is blinatumomab. MRD is negative, then we can go for transplant. But if it is again positive, then we can pursue other alternative strategies like other monoclonal antibodies or CAR T-cell therapy, like other things. And if it is isolated CNS relapse, then again, whether it is early, late, then we can give 4-drug induction. If MRD is a negative, then chemo and local radiotherapy has to be continued. But if it is MRD positive, then reinduction cycle 2, cycle 3, and again MRD has to be assessed. And if it is MRD is negative, then patient can go for transplant. But MRD is positive, then other alternative strategies can be explored. And in case of TLL, again, induction chemo regimen has to be given, and ongoing reinduction chemo cycles. And if it is MRD is again negative, then transplant, but TM is positive, then again other some therapeutic trials need to be given. So other drugs like dasatinib and nilotinib are tried in imatinib resistance PS positive ALL, also in ABL class gene fusion. And if JAK2 fusion is detected, then ruxolitinib can be tried. Then other drugs like clofarabine, nelarabine are tried. Clofarabine in relapsed refractory ALL in children who received at least 2 prior regimens of chemotherapy, then clofarabine can be tried. And it has synergistic effect with cyclophosphamide and etoposide. And nelarabine, it has encouraging results in pediatric TLL, especially in patients those who have a slow early response, and roil in relapsed TLL. Then other protocols are being tried like ALL, where clofarabine, cyclophosphamide, etoposide, and dexamethasone are being tried with PEG asparaginase. So these are some completed trials where other agents are used, like mTOR inhibitors like everolimus. Then this bispecific antibody we have already talked about, blinatumomab, which has a much survival advantage, and other things like CAR T-cell therapy. So these are completed trials, and results are being published. And there's some ongoing trials also are going on with monoclonal antibody, like anti-CD20 conjugated monoclonal antibody, that is inotuzumab ozogamicin. It has also promising result. And in relapsed TLL, this daratumumab is also being tried, which is anti-CD38 monoclonal antibody. Then in transplant, conditioning regimen, if you are going for a transplant, then conditioning regimen that includes whole body irradiation achieves results superior to chemo alone. And delaying transplantation until MRD is positive, it is beneficial. Then whenever we are going for transplant, consensus is match sibling donor, but when HLA identical match sibling donor is not available, then one can go for match unrelated donor, or can try with 1 to 2 unrelated umbilical cord blood, or T-cell depleted haplo transplant. So these transplants also can be explored. Then regarding CAR T-cell therapy, this Tisargen cleave cell is the only US FDA approved CAR T product for pediatric ALL. And in the Eliana trial, there were 75 relapsed refractory ALL patients between the age group of 3 to 21 years included. And they found that 2-year relapse-free survival rate is around 62%. But much more data are needed to define the long-term efficacy. So to conclude, Main treatment options for relapse ALL are cytotoxic chemo and allogenic transplant. Highly active immunotherapies for BLL, small molecule inhibitors of pathways altered in relapse B and TLL, and improved transplant technologies are being developed. This stratification has been further refined at initial diagnosis, and some of these therapies are now also being investigated in the frontline setting. And survival, we hope that survival will continue to improve in children and adolescents with relapse and refractory ALL, as a growing number of molecularly and immunologically targeted therapies are being developed. Thank you.
Thank you, Shonali. This is a very complicated topic with many drugs coming up and many trials going on. And you've done a very good job completing it. And now, do we have time for questions? Do we have time?
Yes, ma'am. 1 to 2 questions we can take.
1 to 2 questions.
If anybody.
And there's one question from Bashop Bakchi to Dr. Bose. Do we need NGS for TP53, rungs 1 and ASXL1?
Yes.
Dr. Bose, please.
Yes. Hello. Am I audible? Hello.
Yes, you are.
Yeah. Yes. We have to do all of these three, including other also, because for prognostication, all of these mutations are essential. So mode of the detection, you can do either RT-PCR or NGS, because NGS is much more will be cheaper than the RT-PCR. So you have to do all of this.
Okay, because we are short of time, we have to give little space to everybody. Any other questions, please? Please come up. Then from Dr. Bose to, you have to study all these three, including other mutations also by PCR, or you've already answered these questions? Now, I have a question for Shonali. In your first slide where you mentioned way forward in relapsed ALL, you did not mention HSCT. Why is that? For completion's sake, that should be there, isn't it? You mentioned CAR-T as the last option, but no HSCT.
Okay, ma'am. Transplant is always there. Maybe it was missed.
But in that slide, that was not mentioned, although all other options were mentioned. Any question for Dr. Kishore?
Okay, Dr. Baba. Didi, can I have a comment, please? Dr.
Please,
Jana,
please.
Look, so my comment is in relation to the Dr. Sonali's topic, that relapse ALL. You know, I am sure those who have used the iCycle protocol earlier, which we used in our department, we have used roughly 115 cases of pediatric ALL iCycle protocol. The basic backbone of the iCycle protocol, though it's a BFM 95 based protocol, but there was a risk stratification, and depending on that, we classify low risk, intermediate risk, and high risk. High risk is very difficult to administer in our setup, so we always divide between low risk and intermediate risk. So what we have found, though we have categorized risk stratification as low and intermediate risk, and as you know, for low risk, we don't give any high dose, you give a caposis type of methotrexate, means increasing dose of methotrexate, which is not a very high dose methotrexate. And what we have found that the incidence of relapse rate has really gone up. Out of 120 cases, roughly, even around 30% have relapsed, both early and late relapse. So we have abandoned the using iCycle protocol based on the risk stratifications. Maybe there may be reasons are many, because our molecular study in risk stratifications may be suboptimal, may not be that reliable. There may be other issues with the drugs which are used in a government setup, you know. So these are the few issues. But we have abandoned the use of risk stratification. Rather, we have switched over to the BFM 95 protocol. We would always recommend to go for at least 3 gram methotrexate to prevent the relapse of ALL. That's the way forward. I can invite the comment from Dr. Sonali or from anybody else. Have they used and what is their experience in using the iCycle protocol? And yes, please.
Sir, one thing is that this iCycle protocol is based on like very good this cytogenetics as well as MRD. So if we don't have in-house robust MRD, it will be very difficult to follow that because it is MRD based protocol. And most of the time, like we are just outsourcing the MRD, we don't have in-house. So because 30% cases this MRD is positive, like I was talking with those who are in that iCycle protocol in that study group. So they are finding like 30% are MRD positive. So that maybe, sir, is making the difference.
True, true.
Sonali,
That's
one here, Dr. Jina. So as you rightly pointed out, in the iCycle protocol, not only in the your center, a lot of other centers facing the same problem in terms of the relapse. So CMC Vellore has a lot of relapse there. We are using, we had a short-term follow-up data. But yes, as Sonali is rightly pointed out, the iCycle is the trial protocol. It is the not published and approval protocol. So I think there is some question mark for regular use of the iCycle protocol in day-to-day clinical practice because it is basically the genetic and the MRD based protocol. So where the facility is not available, I think we switch to the BFM protocol.
And I will again here I will add in continuation with what Dr. Tufan has told. Even I have interacted with the centers of the CMC Vellore, Tata Memorial, and both TMC Kolkata also. Those people who are involved in these MRD estimation, same thing because the MRD estimations it's not standardized. There are many gaps between the reality and the what is happening or what is the findings are accompanying. So it's really very, very premature and too early to depend on in our setup. Considering all the parameters, infrastructures, and technology available to switch over to the MRD-based protocol, particularly iCycle, and I agree that many centers, they have, once you see a very high incidence relapse, they have abandoned the iCycle protocol, they have switched over, which we have done it all. That's my observation, which I wanted to share.
BFM 95 is MRD based, and it gives very good results.
But here the minimum methotrexate dose is 3 grams at least. You can 3 and 5. Unlike the iCycle protocol where the methotrexate dose has been really reduced to a great extent in low risk. It's only 100 milligram, 200 milligram, that's all. It's a capacity way of increasing dose of the one methotrexate. That makes the difference. Anyway, that's my, over to the Didi again, please.
And again, sir, what MRD we are doing, it is flow-based MRD. Again, that is also making the difference. Flow-based MRD.
It has to be a multi-channel flow.
Yeah.
More than 8. And that's
and
true.
Again, sir, giving this 3 gram methotrexate is easier than administering that Capigi with vincristine and increasing dose of methotrexate with Septran. So that becomes more toxic than this 3 gram methotrexate administration.
That's why I'm referring that. That's my point, because we find no difficulty in administering the 3 gram, and why you will compromise these capacities of methotrexate dose along with vincristine, because that's very, very important. And when you are reducing or you are almost omitting the cranial irradiation, so we must have an effective dose or drug which should penetrate the central nervous system. So naturally, other than methotrexate, we don't use the RAC in a high dose which can penetrate the CNS system. So the high dose methotrexate is vital in preventing the relapse. In our setting, particular when the MRD estimation is a big problem in many centers of the country. That's my point only.
Ma'am, please conclude.
Yes, please.
Okay, it has been a very interesting session. And as I said, it's very content rich. So the time was very limited and we had to cut people short. Sorry for that. But anyway, thank you all the speakers and thank you all those who have participated in this. And I thank the organizers for inviting me to conduct this session. Thank you.
Thank
you, ma'am. And thank you all the speakers. So for the next session, I would like to invite my co-host, Dr. Avriti, to take over.
So good evening all. Now we are coming towards the end of this academic feast with our last session on hemophilia. The session is sponsored by Takeda, and this session would be coordinated by our session coordinator, Dr. Shantanu Basu, who is a consultant hematologist at Peerless Hospital, Kolkata, and is a famous name in the field of hemophilia. So I welcome, sir.
Good evening, everybody. Can you hear me? I hope you can hear me.
Yes.
Right. Good evening, everybody. So we have done a lot for hemophilia with prophylaxis, and we thought we have finished doing things and the hemophiliacs would be very happy. But on the way, we have found that not everything is hunky-dory, and inhibitors are one of those problems. So today we have a whole session on importance of inhibitor management in hemophilia. We have a whole lot of speakers who are erudite and experienced in this, and I'm sure you'll be having a good time. But again, time is short, but so is life, so let's make the best of it. For the speakers, may I remind them that before everybody falls asleep in front of their computers, I would like to end the session before that. Right, so with that introduction, may I now request our first speaker, Dr. Tulika Sheth from she's a professor of hematology in AIIMS New Delhi, and you see all her achievements in the slide. I wouldn't read through them. Dr. Sheth, would you please take over and tell us about your importance of inhibitor management in hemophilia, Dr. Sheth, please.
I think my talk is recorded, so are they going to?
Oh, it doesn't matter. Let's have the recorded talk. Yeah. Please stay there if there are any questions.
Thank you.
Dr. Sheth, right. Sure. Thanks.
The host for giving me the invitation to speak on the importance of inhibitor management in hemophilia. This is a very important topic, and there are several lectures about inhibitors and their management after this. So I'm just going to be setting the stage. Okay, so I'll be covering what are inhibitors, why they occur, how do we diagnose, how do inhibitors affect management, how does the development of inhibitors affect mortality and morbidity, quality of life issues, and the financial implications of inhibitors. So inhibitors in patients of inherited hemophilia are the most serious complication, and this is due to development of alloantibodies, also called as inhibitors, to factor 8 or factor 9. So what exactly are these inhibitors? They are alloantibodies, polyclonal high affinity IgG antibodies, and they are directed against factor 8, which is the most common entity that develops inhibitors, or factor 9. And the development is actually a very complex event, which we are still now incompletely understanding, but gradually we're understanding some of the steps that are there, and it's a immune system event in which APCCs, B cells, and T helper cells are involved. And the end result is that they destroy both the endogenous or exogenous factor 8 and factor 9. As I said, inhibitors are much more common in hemophilia A patients, in which the incidence is up to 30%, and in hemophilia B patients, it's much more a rare event, and it is more common in severe hemophilia compared to mild or moderate hemophilia. The antibodies are against the active domains, and that is where the problem is, because it then inhibits any exogenous factor that is given to these patients. The types of inhibitors are low titer and high titer. Now, some patients with low titer can, when given factor 8, become high responders and develop a high titer. And there are some patients who are low titer and even on repeat exposure remain low titer, and these are the low responders. Sometimes the low titer inhibitors may be transient, and these patients will have a loss of the inhibitors over a short period of time, usually less than 6 months. The high titer and high responder inhibitors are usually not transient, and this is unfortunately the more common group that we see, and they can often have anamnestic responses. So this is a graph to show a patient who is a high titer and high responder, when he gets a provocation, then the titer becomes even higher. And this patient has a high titer all the time. And then there are the low responder type that can be there. And a lot of patients can have transient inhibitors. And this is again just to show you the high titer, high responder, low responder, two groups that are there. And it's important to identify, because treatment, which will be discussed by the next speaker, will be dependent on which group the patient is. Now, when are patients at risk for inhibitors? So the first 50 doses of factor given when you start prophylaxis, that is a dangerous time, and inhibitors may develop. The reason for this is that even though prophylaxis is protective, the protective part of the prophylaxis doesn't kick in till after about 20 or so exposures. And again, in older patients, we can see a high risk of inhibitors. So why exactly do they occur? They often occur at times of inflammation or when high doses of factor are given. So surgery and illnesses and any inflammation can increase the risk of developing an inhibitor. Some mutations, especially the large deletions, can increase the risk of developing an inhibitor. There are families with positive family history of inhibitor, and certain ethnic groups like African Americans can have a higher risk of inhibitors. And then there are some immunological polymorphisms that can predispose to inhibitors. As I said earlier, regular prophylaxis can, in the long term, decrease the risk of inhibitors. So when to suspect? Whenever a bleed is not properly controlled with the usual dose of factor, if the normal treatment seems less effective, if there are unusual bleeding episodes, and of course, during the first 50 exposure days of getting factor, patients should be monitored frequently, every 5th dose until 20 exposures, and then every 10th dose after that. And this is what is recommended in the World Federation of Hemophilia guidelines as well. And the same is there from the WFH 2020. So the other are whenever you're planning to switch any concentrate, and of course, if there's a family history of inhibitors, then you would screen these patients a little bit more. And before any kind of surgery or invasive procedure, always check for inhibitors. Sometimes we do a screening test, which might be if you don't have an inhibitor assay available at your center. This, of course, is not always going to be useful, but can give you an idea if the patient should be referred to a higher center for a Bethesda assay. And the diagnostic test would be a Bethesda assay. Some of the labs may be doing a Nijmegen modified Bethesda assay, but this is a basic test to tell if you have inhibitors and to know what the titer of the inhibitor is. And this is how we do this. And the Bethesda assay, the 1 unit of Bethesda unit inhibits 50% of factor that is available. So how do inhibitors affect the management? So the development of inhibitors, as I said, is a serious problem because now the patient becomes resistant to factor therapy, and this is going to pose a major problem for surgery or even for management of a bleeding episode, because now your factors are going to fail. We already live in a society and country where many of our patients have very limited access to healthcare, and hemophilia patients face a life of pain, disability, and unfortunately, even early death. The quality of life study, even in Western countries, shows that often the quality of life in patients is very poor, with diminished mobility, pain, and other activities. The majority of cost of treatment is spent on the anti-hemophilic drugs. And as you all know, that factor 8 and 9 are very expensive, but the bypassing agents are even more expensive. So what happens when the inhibitors develop? Even in Western countries, there have been a lot of studies done to look at this. And obviously, when you have an inhibitor, especially if it's a high titer inhibitor, you're going to have to go on to bypassing agents like APCC and recombinant factor 7A. And some of these patients may require immune tolerance induction therapy, which is going to be discussed later, which is a very, very costly procedure. And even if it's a low titer inhibitor, you will need very high doses of factor 8 to manage these patients. And of course, if they're needing surgery, or if they're having a lot of bleeding, they may need prophylaxis with bypassing agents. The newer agents like emicizumab and some of the other agents can also be used. And this is now leading us to a dilemma about whether to even do ITI or whether to just manage these patients with these new and standard bypassing agents. So at the moment, it's not very clear what to do. What this diagram shows is that patients in different age groups are more likely to get ITI or not. So the younger patients are more likely to get immune tolerance induction, which is shown by these checks. And as patients get older, they're probably just going to be managed with bypassing agents, either one bypassing agent or a combination of bypassing agents. So the lifelong care of any patients with hemophilia and inhibitors is going to be very expensive. And what happens is that the quality of life decreases a lot with these patients because they develop more serious bleeds. It's more difficult to control the bleeds. They're likely to get end-stage joint damage, which leads to severe morbidity and even mortality. So patients are missing school. They are not able to work. They're at the hospital more, and they have much more pain. The cost escalation is also significant. Most Western studies say that the cost of treatment goes up by 4%, but that is because patients are on very high dose prophylaxis. In India, since most patients are on low dose prophylaxis, when they have to be transferred to bypassing agents, the cost of therapy goes up even more. And this is from some Western studies where once patients develop inhibitors, the cost is 3 times more, to up to $1 million a year. And even in Asia and in European countries, the cost escalates. And in fact, one treatment of bleeding, one episode can be from 25,000 to 35,000 per bleed. So that's a lot of money that is spent even in the West. And of course, if these patients need surgery, again, you're going to need a much more expense for covering the bypassing agents for surgery. Now, there's always a lot of limitations when we talk about the cost and the health economics. But I think what's most important is to understand that the quality of life really goes down. So you're spending much more, but the actual outcome is going to be much, much less. So even though there's criticism of health economic studies, there is some value to it, and we need to focus on how to prevent or how to treat these patients with inhibitors in order to avoid the decrease in quality of life. Currently, the only way we can eradicate an inhibitor is by immune tolerance induction therapy. As I said, the cost of ITI is actually a lot, but it is more cost effective than lifelong bypassing agents. And in the West, an immune tolerance induction can be up to $1 million. So it's important to understand inhibitor development so that we can avoid and mitigate the risks. It's important to know the family history of patients who have inhibitors so that we can understand the high-risk genetics and counsel families. It's important to monitor these patients so that we can diagnose them early and change the treatment as is necessary. And if present, we can then manage the bleeding and consider immune tolerance induction in appropriate patients. Thank you, and I'm happy to take any questions.
Thank you, Dr. Seth. It's a wonderful presentation, very comprehensive and very short. Thank you once again. We will take the questions at the end, unless your dinner is being prolonged very much.
No, I'm happy to wait.
Right. Thank you. Thank you, Dr. Seth. So our next speaker is Dr. Maitri Bhattacharya, Director of Institute of Hematology and Transfusion Medicine, a very well-known name, very experienced in treating hemophilias. Now she has the topic of treat or eradicate the inhibitors, a perspective on ITI therapy. As Dr. Seth has pointed out, that do we treat with ITI or do we go for the bypassing agents? Dr. Bhattacharya, please take over.
Thank you, Dr. Basu, for your kind introduction. I think this ITI part is the most neglected part of hemophilia. So I'd like to thank Dr. Tufan for choosing this subject. So let's start with the story of this boy. This is an 18-year-old boy, had a road traffic accident and developed, you can see this type of ecchymosis. And this patient was admitted to see whether there is any fracture or anything else because of our RTI, road traffic accident, and there was nothing. We started giving factor, but this lesion progresses. It developed a necrotic lesion. Patient was having fever. There was pallor. Started IV antibiotic, blood transfusion. And when we checked why it was progressing, we saw that the inhibitor titer was high. This was 48. So bypassing agents were given. And you can see the patient developed nerve palsies also after some time. You can see the defect. So requires a surgery. Surgery was done. It was uneventful. It was under cover of EPCC and the patient recovered. On follow-up, we saw even the inhibitor titer was present. It was 32. So what we can do now, put the patient on prophylaxis with any of these three agents. This is not possible for financial reason because factor 7A, NOVO7, it's not possible, EPCC not possible, emicizumab not possible, neither by the government to provide this, nor by the patient to afford this. So what next? So only option at present is to eradicate the inhibitor from this patient, and that is immune tolerance induction or ITI. So this inhibitor development is the most serious treatment-related complications in hemophilia. We know the bypassing agents are the treatment option, but even the patient sometimes bleed even on these non-factor treatments or bypassing agent. And if the patient is on emicizumab prophylaxis, and if you give this bypassing agent, there is a chance of development of thrombosis or even TMA. And of course, in a country like India, finance is always an issue. So eradication must be our goal in hemophilia patient with inhibitors. How to eradicate? ITI is the only proven strategy that has been found to be effective over time. So what is ITI? So we administer factor VIII regularly over months or even over years to tolerize the immune system. And this restores the normal factor VIII pharmacokinetic. This process is successful in approximately 70% of patients. I'll not go into this slide. Dr. Tulika already discussed how antibody develops in a patient. This we need to know, because if we need to know how immune tolerance acts, then we need to know how antibody develops. So how we can prevent these development of antibody? First of all, when we are giving high factor VIII level in immune tolerance induction, it inhibits the memory B cell, and so that it cannot differentiate into plasma cell and cannot produce antibodies. And this continuous exposure to factor VIII in a non-inflammatory media, in that case, there is upregulation of effector Treg cell, and there is downregulation of effector T cell, so that antibody formation is less. And also there is development of anti-idiotypic antibodies, which blocks the already present antibodies. So this is how it acts. If you give factor VIII, antigen presenting cell, it presents to the T cell, but with this mechanism, there is upregulation of the Treg cell, you can see, and there is downregulation of the effector cell. So this antibody formation is not there. There is apoptosis of the B cell, so it cannot mature into plasma cell and give rise to antibodies. And the last mechanism is anti-idiotypic antibodies. This blocks the already present antibodies. So what are the risk factors so that ITI will be successful or not? So age of start is more effective in childhood. It's less effective in adult patient. This was there that if the highest peak is less than 200, then it will be more effective. And when you are starting the therapy, then if the titer is less than 10, it was said that it's less effective. It's more effective, but it's not, this theory doesn't stand now. It has been found that it's effective even at high titer. And time to titer decline to less than 10 is very important once we have started the ITI. If it's less than 24 months, then it's likely to be effective. So what about other factors? So the time interval, development of the antibodies and starting ITI. If it's less than 4, previously it said that it was effective, but there is no significant difference. It was found in other studies. So factor dose, previously it was said that if it's high dose and high frequency, then it's more effective than low dose and frequency. But it was later on found that it's not that. Efficacy wise, both are same, but the bleeding manifestation will be more in case of low dose and low frequency. And in that case also, it will take longer time to eradicate the inhibitors than if we use a high dose and high frequency. And it was previously believed that this plasma derived factor, which contains von Willebrand factor, it will be more successful with this. This also has not been sustained. Ethnicity, there is no difference, and factor VIII genotype also has been found to be to have no difference. So these factors are not important when we are considering ITI. So there are many protocols. As I told, there may be high dose, high frequency, there may be low dose, low frequency. A few of the protocols has already been discarded, like Malmo protocol, because it contains cyclophosphamide and patient needs admission, and there are toxicities of cyclophosphamide, so it's no more in use. Other protocols are in use. This is a high dose protocol and this is a low dose protocol, but nowadays we don't use APCC along with factor VIII. It's only in cases of bleeding we use this bypassing agents. So the WHO guideline for the management of hemophilia, WFH guideline, which was published this year, August 2020, it said that the optimal regimen remains to be defined. We don't know which one is optimal, but it said the same thing, that the efficacy wise, both the high dose and low dose are same. And if it's low dose, it will take more time, and during this period, the incidence of bleeding will be more. And for this reason, low dose trial has been stopped, and now clinicians prefer a high dose and a high frequency regimen. For the time being, we can say that the most effective regimen is the high dose, high frequency regimen. So that is more near about 150 to 200 units per kg. It may be even daily. So how we are going to know whether the patient is responding or not? So there are three categories. One is success, if the Bethesda titers becomes negative, or if it's less than 0.6, if the normal fine pharmacokinetic is there, and factor recovery is more than 66%, and half-life of factor is more than 6 hours, no anamnestic response, we call it a successful ITI. There may be a partial response also, so the inhibitor comes down to less than 5, factor VIII recovery less than 66, half-life less than 6 hours. So though inhibitor has come down, these two factors are not up to the mark, but there will not, should not be any increase of inhibitor level when the patient is on demand therapy for 6 months, or if the patient is on prophylaxis for 12 months. Unsuccessful when the neither can be achieved even after 33 months. So the minimum duration of ITI should be 9 months and maximum should be 33 months. After that, we'll have to discuss if there is no response. So this is how we should monitor once the patient is on ITI. We can quantitate the inhibitor, evaluate the pharmacokinetics of factor VIII, and most important is patient's clinical phenotype. If it's successful, then it's fine. We can put the patient on prophylaxis. If it's not, then in case of bleeding, we can go for bypassing agent. In case of prophylaxis, of course, either emicizumab or a bypassing agent. And to eradicate the inhibitor, what we can do further is that we can change the regimen on which the patient was on. We can change a low dose to high dose. We can try different factor concentrate, maybe a recombinant to plasma derived and like that, and more frequent administration of factor. And also we can consider some immunosuppressive agent like rituximab along with the ITI protocol. So these are the standard method for ITI, but as we saw that 70% patient response, so for the rest 30% and more response in pediatric age group. So we need to find out further ways to have a more effective immune tolerance induction. So many works are going on. Most important is hepatic gene transfer that causes a decrease in the inhibitor level as well as development of tolerance. There may be co-administration of other drugs, rapamycin, which causes upregulation of Treg cell. And even we can ex vivo expand the Treg cell and again put it into the patient. Then we can modify the Treg cell. Treg cell is the most important cell in ITI. And there may be gene modified B cell which suppresses the development of the T cell. So the T cell will not be able to respond to an antigen and will not be able to stimulate the base cell for the production of antibody. And lastly, depletion of B cell by rituximab. This is already into the clinics, but other things are under trial. This has not come into the clinical practice. So these are the newer methods. So one is rapamycin, which upregulates the Treg cell, and this deletes the T effector cells. This is some oral tolerance. Intestine has a very good mechanism of develop tolerance against foreign antigen. So, but factor VIII, if we give orally, it will be degraded in the by the acid of the stomach. So they wrap this factor VIII in lettuce, and after that they give it. And it has been found that then it's very effective in the intestine. This upregulates again the Treg cells and downregulates the effector cell. And this is a vaccine, how it acts in cases of development of immune tolerance. So all these methods ultimately give rise to increase in the Treg cell and causes a decline of T effector cells, so that antibodies are not formed. Other emerging therapies, this is what I said, that gene modified B cells, so that it prevents development of antibodies. These are the Treg cell expanded ex vivo. What is more important and surprising is that CAR-Treg. We usually know that CAR is mostly for malignant hematological disorders, but this CAR has come into the treatment of ITI of Treg also. But of course, this is still now under clinical trial. So this gene therapy has shown very much promise. For a hemophilia patient, gene therapy, when we plan for gene therapy, the patients with inhibitors are not considered. They are not included. So this is one exclusion criteria. If inhibitors is there, they are not taken. But now it has been found that if we do a liver-directed gene therapy, then it can cause a decline in the pre-existing antibody of factor VIII, and this induces immune tolerance and provide a long-term therapeutic expression and prevent bleeding. So this is one of the method which is very important, but this is in preclinical studies only. So you can see like this is once the expression of the factor is increasing, the inhibitor titer is coming down with the liver-directed gene therapies, and this is given usually with adeno-associated virus. So this may be in future the most important approach for removing or eradicating the inhibitors from a hemophilia patient, and at the same time restoring a normal production of factor VIII in hemophilia. So the take is that patients with inhibitors should undergo a trial of ITI for eradication. Inhibitor eradication by ITI is at present is successful only in 70 to 80% cases. This may be started immediately. We don't need to wait for the titer to come down to a low level. There was no difference with low dose and high dose. As I told, low dose will take much longer and there may be more bleeding, and various novel approaches are under trial, and hepatic gene transfer is one of the most promising approach that maybe in future that will be one of the most important. retrospect. Thank you all for your kind attention.
Thank you, Maitri. A very comprehensive take on ITI and what the future holds for us. A lot of lessons for me there. Please be with us so that we can take the questions at the last, because many of those probably will be answered in the panels. Our next speaker is Dr. Siddhartha Shankar Rai, Professor of Hematology in Institute of Hematology and Transfusion Medicine, Kolkata. And he has been looking at hemophilia for quite a long, and he has the topic of role of inhibitors in surgery, a very important topic. Inhibitors in surgery. Siddhartha, please.
Yeah, good evening, everybody. Actually, I think lecture is also recorded. I think they will.
Sure.
Yes,
Please,
okay,
please stay with us. Please
Yeah.
stay with us, Siddhartha.
First of all, I would like to thank the organizer for giving me this opportunity to speak about surgery in people with hemophilia with inhibitor. So why this topic was chosen? Because before the invent of the factor replacement therapy, surgery was contraindicated in patients with hemophilia, and it was tried only as the last hope, almost when patient is about to die. But with the discovery of the factor replacement therapy, surgery is not much of issue in persons with hemophilia. But scenario is quite different in persons with hemophilia who has already developed inhibitor, means who has already antibody to the factor 8. So there we cannot decrease the bleeding by giving factor 8 or factor 9. So even in those patients, even spontaneous bleeding, like bleeding in the joint, muscles, or mouth, nose, that is difficult to control with factor. So in those cases, surgery even more difficult to control. So that's why this topic. Now, World Federation of Hemophilia has given some guidelines that there should be some prerequisites which should be fulfilled before going for surgery in persons with hemophilia. Persons with hemophilia, they should have a ready access to a center where elective and acute surgical procedure can be safely done, so that their well-being or quality of life should be maintained. And surgery should be managed in consultation with comprehensive hemophilia treatment center, so that there should not be any adverse event. And there should be adequate amount of clotting factor concentrate, or in these cases, maybe you can say that bypassing agent. There should be adequate amount which should cover not only during the intraoperative period, but it should cover the postoperative period also. And that center where the surgery is being done, there should have a good laboratory support which is available round the clock, so that the coagulation study and also the clotting factor level can be done whenever it is needed. When there is any emergency occurs, their laboratory should be there, and one experienced hematology team should be there to manage any adverse event. There are other prerequisites which was mentioned by the World Federation of Hemophilia, that all the patients with hemophilia A and B, pre and post-operative inhibitor screening should be done. And regarding the neurasthenic anesthesia, the World Federation of Hemophilia are against it. But if we have to give neuraxial anesthesia, then it should be given only after adequate amount of clotting factor concentrate is being given, so that there should not be any bleed around the CNS. Patients with mild hemophilia, and especially the other patients who are receiving huge amount of factor replacement, there we should rescreen for inhibitor presence 4 to 12 weeks postoperatively. And for patients with hemophilia and A and B who are undergoing major surgery, WFH recommend against the routine use of pharmacological thromboprophylaxis. That is, in other patients where we are going for major surgery, many times we provide thromboprophylaxis to prevent the occurrence of the DVT during the postoperative period. And regarding the duration of the factor replacement therapy, we have to give for at least 3 days in case of minor surgery, or 7 to 10 days for the major surgical procedures. and antifibrinolytics and the topical hemostatic like fibrin glue should be liberally used when and required. World Federation of Hemophilia guidelines, they have published and they have defined the adequacy of the hemostasis during the surgical procedure, and they categorized into 4 categories like excellent hemostasis, good, fair, and none. Excellent hemostasis when the intraoperative and the postoperative pure blood loss is similar, maybe within 10% of that which is predictable in a non-hemophiliac patients, and no extra amount of the factor or bypassing agent is required, and no extra amount of the blood component transfusion is required. That is called excellent. When the blood loss is more than 10% but up to 25%, and but still, because patient's condition judged by the surgeon and the anesthetist, they said there is no extra factor or bypassing agent is required, no extra blood component is required, then it is called good amount of hemostasis. Fair means the blood loss is 25 to 50% of that expected, and there is extra doses of the factor replacement or bypassing agent was needed, and there is blood component, either you say whatever PAC or maybe plasma or cryo is required, which is extra in compared to the normal persons, but it is within the twofold. In poor means, if we see the blood bleeding is more than 50% of the expected, and their patient has developed unexpected hypotension or transfer to ICU due to bleeding and substantially increased blood component more than twice, which is anticipated. So by this time, you might have already known that that these inhibitors are nothing but the antibody which is developed against factor 8 or factor 9. And when we diagnose a patient with inhibitor, we usually see how much what is the level of the factor, what is the titer of the that inhibitor. So according to that, and it is expressed in the Bethesda unit. So and we can divide them as a low responding inhibitor, where the inhibitor level is less than 5 Bethesda unit, and if it is more than 5 Bethesda unit, they are called high responding. Means actually, if it is seen that if the Bethesda unit is less than 5 for a hemophilia A or B, whatever is it, if they are exposed to the factor, again, the development or increase in the titer of the inhibitor is not very quickly and not too much. But those who are having more than 5 unit of the Bethesda unit of the inhibitor, they are exposed to the factor, then their increase in the factor level is too much and too quick. So according to that, they are divided into low responding and high responding. And WFH has recommended that the hemophilia A who are low responding factor 8 inhibitor, they can be managed by giving higher dose of the factor 8, maybe 3 to 5 times than the doses, because their half-life of the factor 8 is short because of the antibody. And in these cases, WFH also recognizes the adjusted growth factor 8 continuous infusion as an option, because few trials have already shown if we can give factor 8 in case of hemophilia A with low titer inhibitor, we can manage surgical procedure, and in those cases the total requirement factor 8 is little less, but it is not universally accepted. For patients with hemophilia B and hemophilia A and high responding factor 8 inhibitor who undergo surgery as an or an invasive procedure, WFH recommend any of the bypass agent. You can give either recombinant factor 7A, that Novo7, or you can give APCC, activated prothrombin complex concentrate, which is known as the FIBA, that is factor 8 inhibitor bypassing agent. And the dosage as mentioned is, in the case of recombinant factor 7A, you have to give, there are 2 doses, low dose called 35 microgram per kg stat, and then give every 2 hourly, and high dose is 90 microgram per kg, the stat, that is the before the OT, and then give every 2 hourly until there is hemostasis is achieved, and thereafter you can give 4 hourly or 6 hourly according to the clinical scenario, and this has to be given for total of maybe 7 to 10 days. And if you are giving APCC, that is FIBA, you have to give around 50 to 100 units, but not more than 200 units per kg per day, and that to continue or increase or decrease the dose according to the clinical scenario and the presence of the bleeding. And it has been seen that if a single bypass agent fails, we can give the other one. That is, suppose a patient with not responding to recombinant factor 7A, we can switch to APCC. They might respond. And even it is called sequential bypassing agent, where you give recombinant factor 7A, then after 3 hours you give APCC, then after 3 hours you give recombinant factor 7A. That is also a possible alternative, which is approved by WFH. the WFH also recommend the close monitoring for thrombosis, because in both the agents are associated with increased chances of thrombosis, especially APCC. Now, for patients with hemophilia A and who are receiving emicizumab is a bispecific antibody, now very recently developed, and it is being used in patients of hemophilia A for prophylaxis. Suppose they develop this bleeding. If they develop this bleeding, then we have to give factor 8 concentrated product if their inhibitor titer is low. But if their inhibitor titer is high, then again we have to manage like there is a recommended factor 7A for APCC. Okay. But again, if you are giving APCC, chances of thrombotic angiopathy is high. Now, if we consider the hemophilia B patients, their WFH says any factor 9 can be given if they are low responding inhibitor, that is less than 5 beta unit, you can give any of the factor 9, nothing specific. And if they have got inhibitor, better not to use APCC. Better, if you are using bypassing agent, you use factor 7A, because APCC has got little amount of the factor 9A. And this factor 9, along with the inhibitor, they can cause anaphylaxis reaction. So better to avoid APCC if it is a hemophilia B with inhibitor. And in case both the cases, the close monitoring for the thrombosis and conjunctive coagulopathy, it is strongly recommended. So to conclude my talk, surgery in people with hemophilia with inhibitor is very risky. It should be done in a hemophilia treatment center with collaboration between an experienced hematologist, a surgeon, an anesthetist, and a trained team of nurses. A good lab facility should be available round the clock to check coagulation profile and the factor assay whenever it is needed. Adequate factor or bypassing agent should be there in stock to manage any adverse event like excessive bleeding, and also blood product, like whether it is recorded that packed cell or whole blood or maybe plasma or cryo should be freely available at that center, so that we can manage any adverse event related to the bleeding. Thank you.
Thank you, Siddhartha. You have taken bull by the horn. You have discussed a very important topic, which is surgery in hemophilia. It's not an easy thing in practice, but yes, very well said. Now, please stay with us till the end, because we'll be having a panel discussion on case-based challenges in inhibitor management in hemophilia. And I would request all my speakers to intervene if there are questions from your topic. And I also do request the moderator, Dr. Prakash Kumar Mondal, and invite him to start the session. But before that, I have the opportunity to introduce the panelists there. Dr. Samir Kumar Behra, he's an associate professor of pathology at MKCG Medical College, Behrampur. And there is Dr. Shandip Saha, consultant and associate professor at IHTM Hospital in Kolkata. Then we have Dr. Damodar Das from Guwahati Medical College, a consultant hematologist. Welcome, Dr. Das. And we have Dr. Hemlata Das, the faculty in the Department of Medical Oncology and Hematology at IMS and Some Hospital, Bhubaneswar. We have their, I'm sorry, Dr. Datta is not here possibly. I was just told that he may not be able to join. And Dr. Dibyendu De, he's a very well-known name in hemophilia management. He's a consultant hematologist. Welcome, Dr. Dibyendu. Now, Dr. Prakash, may I request you to take over the session and start it?
Thank you, Dr. Basu, for a nice introduction. And he has done much of my job. That is, he has introduced all the eminent panelists in this session. And hopefully, most of the things today are discussed by the previous speakers. So I am just a minute. I am sharing my screen. Yes, Dr. Damodar Das is there.
Doctor, should I share it or you are going to share it?
Yes, just 10 seconds.
Okay, doctor.
If it is not, then I have shared my slides, so you can start from there also.
Noted.
Just a minute.
Dr. Behra, will you please unmute your microphone?
Yes, I will request all the panelists to please start your video if possible and unmute yourself. So I think this is my presentation. So I am sharing my slides. Is it visible?
Yes, it is.
So it is in slideshow mode?
Yes, it is.
Okay, thank you. So as I already have mentioned that every aspect of inhibitor management, inhibitor issues are discussed. Now I am giving the topic of case-based challenges in inhibitor management in hemophilia. So I promise we are already late by 1 hour. We will not go into the any details of any theoretical discussion. I will just take you with a case, very small child with a long history or long journey. So actually the history started in 2016 and now it is 2020. So what happened to that unfortunate child, and fortunately we could manage that particular child with a high titer inhibitor. So I am straightway going to the case. The case started with a 3 months old baby who developed large muscle hematoma following vaccination. That was managed locally in a local hospital with a supportive care and FFP therapy, not evaluated further. That is what I can say about that time. So I am straight away coming to Dr. Dibyendu. I think Dibyendu is there. Would you like to investigate further at this stage, or you are satisfied with this sort of management and patient was okay that time?
Yeah, obviously at 3 months old, developed a muscle hematoma, which is not a normal condition. So we need to investigate to find out the particular diagnosis. And the basic screening of coagulopathy should be done. That is fibrinogen assay. And along with that, if the APDT is prolonged, which is most commonly occurs in patients of hemophilia, then we need to do the mixing study and we need to do the corresponding factor level to find out whether it is a hemophilia A or hemophilia B.
Okay. So actually they attended our center at 9 months of age, referred to us. He presented with recurrent episodes of spontaneous ecchymosis earlier. So this time he was worked up, as Dr. Dibyendu has rightly pointed out, he was worked up with all those battery of investigations, and he was finally diagnosed as a case of severe hemophilia A. There was no history, family history of hemophilia. Now coming to Dr. Hemlata, do you suggest prophylaxis at this stage? He is a severe hemophilic and having recurrent episodes of spontaneous ecchymosis. So do you suggest prophylaxis at this stage? He is now 1 year age. Dr. Hemlata is there? So if Dr. Hemlata is there, I can go to Dr. Somir.
Yeah. We can start
No, I'm there.
Yeah.
Oh,
Hello.
Yeah.
So I am there.
Yes, please.
Hello.
Yes, we can hear
Myself,
you.
Dr. Himlata speaking.
Yeah,
So
we
we
can
can
hear
say,
you.
yeah. So now this patient is diagnosed as a case of hemophilia A.
Yes.
So early initiation of prophylaxis is the standard onset of joint disease, or ideally it can be started before the age of 3. So as per the WFH guideline, we can go for prophylaxis at this case because it is now already diagnosed as hemophilia A.
Yes.
And having recurrent.
Okay, so that time we had the luxury of having Eloctate, long-acting recombinant factor 8, supported by WFH humanitarian aid.
but that time we were also practicing low dose prophylaxis. In fact, low dose prophylaxis is being practiced in our center for last 4-5 years. So we started with a very low dose prophylaxis of Eloctate, 10 units per kg per dose, twice weekly, and that continued. And as a routine practice, as already mentioned by the previous speaker, patients should be screened for inhibitors. So we also had screened for inhibitors. After 5 EDs and 10 EDs, the Bethesda level was 0.5 Bethesda units. Okay. So now I am coming to Dr. Damodar Das. How do you monitor the inhibitor status in a patient in a PWH who is started with prophylaxis especially? Or
Yes.
what are the recommendations?
So
How frequently do you
yeah,
monitor for inhibitors?
yeah. Those patients started on profile initially. For first 20 weeks, we'll monitor every 5 explore days. It will increase every 10 explore days, and gradually, if there is no inhibitor, we can prolong it yearly, and after one exposure, it is annually.
Okay. So we followed that protocol, and after, as I already mentioned, after 5 and 10 EDs, there was no inhibitor, so we continued prophylaxis. So 2 months later, he presented with swelling, as is shown in the right upper panel, with swelling at the root of nose and especially forehead after fall. So treated with CFC for 5 days and other supportive care, I mean tranexamic acid, all these things. Then again put on regular prophylaxis. And what happened? The forehead swelling gradually resolved, but nasal swelling continued to persist and gradually started increasing in size, as shown in the right lower panel figure. Now, 35 days after the previous trauma, he had sudden episode of uncontrolled epistaxis, for which he was hospitalized, treated with tranexamic acid, both intravenous and local application. CFC, I mean factor therapy continued in therapeutic doses according to WFH guidelines, but intermittent epistaxis continued. Now coming to Dr. Saha, we supported this patient with sufficient amount of factors as per guidelines, but patient continued epistaxis. So what may be the possible reason in this case that patient is not responding to CFC replacement? Dr. Sandeep, please.
Unmute yourself.
Dr. Sandeep, please unmute yourself.
No,
Yes, Dr. Sandeep is there. Please.
Hello.
Yes, Sandeep, we can
Yes,
hear
yes,
you.
we can hear
Please
you.
come up.
So, Dr. Sandeep, we can hear you.
He's talking, but we can't really hear him now.
So, as because we are running short of time, we'll come back to Dr. Sandeep again. So we are proceeding further. So just to summarize the at this stage, the patient severe hemophilia
It's
started
okay
with
now. It's okay now.
Yes, yes.
Am I audible?
Yes, perfectly. So bleeding not responding
Okay.
to CFC replacement, what are the possible causes, or what do you suspect in
Yes,
this
I have
case?
already said that. First of all, we have to consider the inhibitor development is there or not, and apart from the inhibitor, we have to look at the other possibilities like local causes, any infection is persisting there or not, and any other congenital defect is there or not, any acquired any hemangioma formation is there or not. We have to consider this. Especially the local infections may cause recurrent bleeding. And as because the patient is also lower age, we have to consider the other things of other possibilities of epistaxis, like bleeding from the area for epistaxis.
So thank you, Dr.
Little
Sandeep.
area especially.
So you have rightly pointed out that in this scenario, we first think about the development of inhibitors. Of course, we have to rule out some local pathology or local lesion in the nasal cavity, of course, keeping in mind some other rare possibilities also. So we continued our inhibitor screening, and in this case, right at this point, we found a high titer of inhibitor that was 50 Bethesda unit. So now again coming to Dr. Sandeep. So what are the risk factors? Already theoretical past we have discussed. You just summarize the issues of risk factor development. What are the risk factors for development of inhibitors in this type of cases, small child?
Especially, we can actually divide this inhibitor formation into two: this genetic and the treatment related factors. We have already discussed in our previous session by Dr. Tulika Seth. So for the genetic factors are concerned, we should consider that the severity of the disease, whether severe disease or moderate or mild. In severe, obviously the risk of development is high. Family history should be screened, and the races and ethnicities considered, because we have seen that the patients belong to Africa or America, more developed, actually develop inhibitor more frequently. And the treatment related factors are also there are also genetic factors are there. That is, large deletion is also very important factor. In intron 1 and 22, deletion is also a factor. And nonsense mutation is also a factor for development of factor 8. And so far the treatment related part is concerned, that is the factor 8 exposure intensivity of the treatment and the doses of the factor 8 treatment. And not only that, the important factor is surgical procedures or any trauma or inflammation is running in the body or not. That is one of the very major factor for development of inhibitor in factor 8.
So thank you, Dr. Sandeep. Now coming to Dr. Damodar Das, your patient has developed a high titer inhibitor. So what is your immediate advice now regarding further management of this case?
Already inhibitor is developed, so there is no point to give continuing factor concentrate. Here we have to go for bypassing agent. It may be fever or recombinant factor 7. Depending upon what will be our next, if we go for immunotolerance, then if we have to go for recombinant factor 7. Otherwise, continue with fever to stop bleeding, and subsequently go for prophylaxis with fever.
So as Dr. Das has rightly pointed out, we discontinued CFC immediately. We started with fever because that time Novoseven was not available in our hospital, though it is now available at our center also. So repeat test after 4 weeks revealed a inhibitor level of 250. Earlier it was 50, now it is 250. So it's a very high titer and it's increasing gradually. Now coming to Dr. Somir, how do you plan to treat bleeding in inhibitors? Your patient is bleeding, you have given fever. So what are the things or agents you can try with in a case of inhibitor with active bleeding?
The inhibitor with active bleeding, you should start with the either you can start with the fever or the APCC. Okay, factor 7 Nova 7 or factor 7 or this one. The dose has to be calculated, and the dose is around 50 units per kg body weight for the APCC, or maybe you start with the recommended. You can start with 50, you can go up to 200, then you can decrease gradually depending upon the bleeding. Along with this, you should look at the inflammation is there or not. You should control the inflammation also, which is one of the factor for the increase in inhibitors.
Okay. So coming to Dr. Dotto, I think Dr. Dotto is there.
No, he's not there.
No.
Please.
So
go to the
if not, again coming to Dr. Somir. So your patient has developed inhibitor. Now the question is, whether you will put this patient on prophylaxis by fever novoseven or you will try to eradicate, because these things are already discussed by Dr. Tulika and Professor Maitri Bhattacharya, that in the long term, if you calculate, the cost effectiveness is better with eradication than continuing lifelong prophylaxis. So what is your take on this issue, whether you will go for eradication or prophylaxis?
What I think you should go for eradication. ITI treatment should start immediately.
Okay. Okay. So we planned for ITI therapy, but not feasible due to logistic issues, as you all will understand, and hence put on fever prophylaxis to prevent recurrent epistaxis. Now coming to Dr. Dibyendu, ITI is a dream, but it's not a reality in majority of the patients in India, especially in centers like us. So if you don't have the luxury of going for ITI therapy, is there any other possibility or other option that you can try for eradication of inhibitors in your case?
Yes. Yes, ITI, that is immune tolerance induction, is the most important methodology for inhibitor patients, and we should try for it. But sometimes it is not possible to go for ITI because of the logistic issue, because of the cost. And in those cases, we can try for some immune inhibitors or immunosuppressants. Like we can use rituximab, we can use mycophenolate mofetil, we can use cyclosporin. These are some of the medicines which have been used in many of the patients for the hemophilia with inhibitors with some success. And there are some studies also which have shown their response with the rituximab therapy also. And rituximab in the dosage for a immunological disease, that is 375 milligram per square meter every week for 4 weeks, can have some response. So we can try for it. But recently, this is at this juncture, we can actually use emicizumab for the continued prophylaxis without going for ITI if it is feasible and if
We
it
will
is
come to
cost
emicizumab
is not
later.
an issue.
That is a very
Yeah.
new agent in the field. So if we, as you have rightly pointed out about rituximab, we had also tried with rituximab in few cases, like 4 cases, we got very good response in 3 cases. Now there is a very good review article published, and that was updated in 2020 August only, on rituximab in inhibitors. Anybody can read it and get the message what is there. So our patient, we only hope was that we could start with rituximab because that was available in hospital supply. So rituximab in a standard dose weekly for 4 doses. Repeat inhibitor assay after 4 weeks from first dose, and last dose was 20 Bethesda unit and 2.5. So if you consider the Bethesda unit after the last dose of rituximab, it was 2.5. So remarkable decrease in Bethesda level. But nasal swelling persisted. The issue still persists. Nasal swelling persisted and intermittent bleeding. So, coming to Dr. Das, what may be the possible reason behind persistent swelling in this case? Or do
Sir,
you
it may be
suggest any
soft
other test
or
to?
maybe yes, sir. It may be soft mass or maybe vascular traction. So best thing will be imaging of the part. We can go for CT scan of that part. That way we can know maybe the traction underlying.
So, as rightly pointed out, the Bethesda unit now low, but the swelling persisted. So we have to search for a local pathology there. What is happening there? So we did a CT scan, and as you can see, there is a soft tissue mass in the nasal cavity, and radiological diagnosis of query angioma was made. So in view of increasing swelling and recurrent epistaxis, opinion of ENT friends were taken, and they advised to go for surgical excision of the mass. Now coming to Dr. Hemlata, what are the general principles for surgery in PWH before you put your patient for any surgery who has inhibitors? What are the general principles for surgery?
Actually, for what is happening, once we have known that it is an inhibitor patient, we have to look into that the type of like investigations, even from the laboratory aspect, the chromogenic assay and one stage factor VIII assay are done so that we are rightly getting into the inhibitor level, and simultaneously the factor coverage, bypass agents and follow up should be planned in a very systematic way. And in especially we have to look into that if it is a hemophilia A with, whether it is low responding or it is high responder, whether it is on emicizumab, whether it is means with minor surgery or what kind of surgery, whether it is a major surgery or minor surgery, all those things has to be taken care of, because this has been well described in the previous session, all the criteria, what are the general principles, but at the same time close monitoring for the clinical response with the bypass agents along with the safety to be taken care, that if there is any thrombosis by looking into the thrombin generation test at the simultaneously. Now whether we will, what kind of bypassing agents we are going to take care of, whether if it is a hemophilia A with low responding factor VIII, then we can have a choice to go even with more frequent dosing of factor VIII. Along with, if it is a cannot opt for factor VIII concentrate, we have to choose either any of the bypassing agent with FIBA or factor 7A recombinant, or we can even look into the things whether this patient is responding to single kind of bypassing agent, or it can go for a continuous infusion, or he can opt for a combination or sequential bypass agents. If it is on emicizumab, hemophilia A with a inhibitor along with emicizumab, minor surgery, there also maybe that factor may not be required, or low dose factor VIII can also substantiate the bleeding
Okay,
management.
that's true.
But
In
if
case
it
of
is,
low
yeah,
responder, low titer inhibitors, we can try with low dose factor VIII. But in 2016,
yeah,
emicizumab was not available, so we had the only options to prevent
yeah,
bleeding was either
yeah,
FIBA or 7A. So I am
yeah.
going to Dr. Samir. Is there any difference in planning your patient between elective and emergency surgery in a patient with hemophilia, with or without inhibitors?
No, when we are planning for a surgery, whether in a hemophilia patient, whether it is a with inhibitor or without inhibitor, some basic thing will be that should be robust lab support should be there. That will be very good hematologist should be there who knows about the factor assay, who knows about the thromboelastogram. That should be 24 hours lab support, as Tulika madam said. There should be 24-hour lab support must be there, whether it's a elective or a inhibitor emergency surgery or patient with a inhibitors. There should be robust lab support and the surgeon who is doing the surgery who knows about this. That should be, all these things should be there in that hospital before going attending any surgery.
Okay.
Otherwise, the patient will land up in the trouble.
Okay. So if you think about the logistic issues, if that is okay with you, perhaps there is no difference in planning a emergency versus elective surgery in hemophilia patients, even with high titer inhibitor, if you have all the logistic supports, as Dr. Samir has rightly pointed out. Now, Dr. Sandeep, how do you plan a case of hemophilia with inhibitors undergoing surgery, or what are the minimum prerequisites you should keep in hand? Already Dr. Samir has highlighted few of the points, and what are the minimum basic thing you should keep in hand before putting your patient under surgery?
Especially when we are dealing with the inhibitor patients, we have to assess the inhibitor titer, especially the Bethesda assay, we have to put it on. And apart from the assay, and we have to plan it with a effective agent. So the agents we have in our hand, that is recombinant factor 7A and or FIBA. Porcine factor 8 is there, and other effectives nowadays, that is the emicizumab. So, and for local agent, we can use the fibrin glue or tranexamic acid if a surgical problem is there to control the local hemostasis.
Okay, so as I have learned from my surgeon colleagues, they regularly use this fibrin glue, this type of things. I will come to this part, tranexamic acid issue later. So the coming back to our case, the soft tissue mass was excised. Grossly, there was only, as I learned from my ENT colleagues, some old blood clots inside. The operation was uneventful with minimum intraoperative bleed. He was given fever 50 units per kg twice weekly, twice daily for 7 days peri-operatively. Now Dr. Anupam is not there, so I am coming to Dr. Dibyendu. Post-operatively, so 7 days peri-operative we have given fever, patient is okay now. Now post-operative management, you have to plan discharge. What is your plan? Whether you will put this patient again on on-demand therapy or you will put this patient on prophylaxis?
Yes, obviously this patient had a history of inhibitors, and now the inhibitor titer is low and undergone a surgery, which is a major surgery because of bleeding complications. So this patient must be on a prophylaxis, and since the inhibitor titer is low, we can try for a factor 8 prophylaxis, but we must do the inhibitor screening regularly. And if there is inhibitor is positive,
No, sorry, Dr. Dibendu. Our patient still having a low titer to last level was 2.5 Bethesda iodide.
Oh, okay.
So we are talking about the fever prophylaxis at this point. Whether
yes,
we
if in this case
ask for on-demand therapy or put on a regular prophylaxis by fever.
Since there was a serious hemorrhagic complication, so patient should have a prophylaxis, and if it is logistically and financially possible, then we should go for a prophylaxis with fever or Novo 7.
So at what dose or what schedule do you suggest?
Fever can be given at 50 unit per kg daily dosing, or we can use Novo 7 also.
Okay. So he did not have any further bleeding episodes. Discharged after 10 days with fever prophylaxis, advice of fever prophylaxis. HP examination report came and it was consistent with a pseudo tumor. Okay. So what agents would you prefer for inhibitor management? Right now, at least these three agents are there in our hand. So 7 versus fever versus the new entry in it was approved by FDA, US FDA in 2017 only. So these three agents, would you prefer anything over other for
Yes,
this type of
since
cases?
APCC since APCC also contains some amount of activated factor 8 and factor 9, so sometimes APCC can cause activations of inhibitors. So it will be better if we go for either recombinant factor 7A or a emicizumab. It is better to go for emicizumab for few of the importance, because it can be given subcutaneous, it can be given once a month, and it does not require much of the follow up and much of the investigation. So emicizumab can be a preferable choice in coming future.
Okay, so the key message from you that as because MSO has the advantage that you can go for every 2 weeks, 3 weeks, and even every 4 weeks. So that is one advantage, and it can be given subcutaneously. So you will prefer over others in that issue. Otherwise, efficacy wise, you think or we think it's all are efficacy wise same, having some unique complications related to the particular factor. So these are the issues I am bypassing. Emicizumab, it is proven by having 1 to 4 trials that it is effective with or without inhibitors in children and adults. I am not going into details of this. Now, after 2 months, 3 months, and 4 months from last dose of rituximab, in between operation was done. So repeat inhibitor level was, after 2 months it was 0.75, but after 3 months and 4 months it was, in both cases it was less than 0.5. So we can say that rituximab worked well in our patient and we got a satisfactory VU in our case. So in view of severe disease, previous recurrent spontaneous bleeds, what prompted us to start prophylaxis therapy at a very early or young age, and persistent negative inhibitor status post-operatively, we restarted with low-dose prophylaxis again with Eloctate, with close monitoring of inhibitor status, and on repeat testing that continued to be 0.5 Bethesda unit. Now coming to any of the panelists can take this. Dr. Sandeep, antifibrinolytic agents in hemophilia, like especially what the agent we use regularly, what is your take on that issue, tranexamic acid?
Actually, this is a very effective one. So far, the severe mild disease is concerned and the mucosal bleed is concerned. And antifibrinolytic agent is also used by the surgeons before procedures and after procedures to arrest the bleeding. And other agents, fibrin glue is also they are using along with.
So do you have any problem in using tranexamic acid along with this Fiva, Novo7, Omicibzem, all these things?
No, actually, certainly, I never faced this kind of problem.
Okay.
It is very effective so far the mild bleeding is concerned.
Okay. So
and mucosal bleeding is concerned.
Any other panelist on this issue? So if no,
only subjected to certain part of the contraindication. Contraindication, we have to be just looking into. We know that for hematuria, and mostly we have to be taking care of this part.
Taken care of. Yes. Obviously.
Yeah, and I was telling that since it is excreted through kidney, that is why the renal impairment cases we need to take care of the dose adjustment. And in thoracic surgeries, if it is there, in order to prevent the development of insoluble hematomas, we have to be a little bit careful about it. And with hemophilia B also, since it rises with the expectation with the thromboembolism, we need to be means especially with prothrombin complex concentrates, we need to be careful about it.
Okay. Anything to add, Dr. Somir, please?
No.
Okay. So the story ends here. I don't know how far we have to go, but I am ending my story here. The child is now on regular follow-up for last 4 years with continued prophylaxis as before. So to conclude the whole session, we have to address all the issues related to inhibitor management, like treatment of acute bleeding, prevention of further bleeding, that is prophylaxis, and of course, if we just consider the cost issues, we have to try eradication of inhibitor activity in all cases, and safe surgical procedure. That is a very challenging issue in hemophilia earlier, now in inhibitors also, and that can be, our case has proven that that can be safely done and definitely done for PWH even with high titer inhibitors. Lot of efforts and teamwork needed for surgical management in PWH with inhibitors. But with that, I conclude my whole team. Thank you all. Good night. I
Thank you,
hand over
Prakash.
mic to Dr. Santanu, please.
Thank you very much.
Thank you, Prakash. Thank you very much. It is wonderful presentation. Whatever we learned theoretically was practically demonstrated by your case. Now the session is open for discussions or any questions. It's quite late, but I can't see any questions in the chat box. Are there any questions from anybody? Well, if there are none, and it is quite late, I thank our lecturers, especially Dr. Seth has left. Thank you, Dr. Seth, Dr. Bhattacharya, Dr. Ray, and a big thank you to Dr. Prakash Kumar Mandal for practically demonstrating what we have been theoretically saying. And thanks to the panelists, Dr. Bera, Dr. Saha, Dr. Damodar Das, Dr. Hemlata Das, and Dr. Dibyendu De. Thank you very much for the lively discussions. Over to the organizers.
Thank you very much.
Thanks a lot, session coordinators, speakers, moderators, and panelists for this informative session on hemophilia. I hope everybody enjoyed the sessions. Now I request Dr. R.K. Jina sir to address the audience and address the vote of thanks.
Okay, thank you and good evening again. We come to an end of this extensive annual conference virtual, the fifth one of the Eastern Hematoid Group. On the day one, we have a 4 session. In every day, we have a 4 session, well crafted and well educated. On first day, we have a session on aplastic anemia, then lymphoma, then sickle cell disease, and chronic lymphatic leukemia. On the second day, we had again 4 sessions. The first was ITP, the second was multiple myeloma, then third was on acute leukemia, and fourth was on hemophilia. And on behalf of Eastern Hematoid Group, I extend our sincere thanks to all the international faculty, national faculties, and panelists, particularly making their topics so lively and so informative. It's really a high-class academic which was executed, all practical problems, importance, and keeping even our real world into consideration. That was really amazing and well executed by all the speakers and all the panelists. We weigh on extensive, sincere thanks to all of them. I also thanks all the members of the Eastern Hematoid Group to log in and making it present and making very interactive sessions. And without their support, it would have been very, very impossible, difficult to make it very, very successful. I also thank on behalf of Eastern Hematoid Group, our sponsors, particularly Novartis Oncology, supporting in a very big way to this 5th annual Congress of ESG virtual. The other supporters, we extend our sincere thanks like AstraZeneca, Intas, both oncology and plasma division, Johnson & Johnson, Takeda, Celestial, Bharat Serum and Vaccine, and Plasmagen for the support to which was very, very essential to make this event very possible. I also, on behalf of Eastern Hematoid Group, thanks our event team, like me conference and Mr. Rahul Singh and their entire team, who has really worked very effortless, very with a lot of effort and sincerity, recording at the last minute of international faculties, national faculties, and making these technical facilities was super, without any hiccup, without any problem, making a very smooth selling of all the events throughout the 2 days. And if you remember, it was very extensive, 6 hours in the day 1 and 6 hours in the day 2. If you compare in every day, in every conference, the AG annual was a 1.5 day or 2 days, but it is a full-page discussion, 6 hours in day, very extensive and well educated. Lastly, I must extend our sincere thanks to the office bearers and the Dr. Tofan Dolai and his entire team, our Sharmila Didi president. Without their effort and without the effort of Dr. Tofan and the team, this would have never possible. Really, it has been made possible because of the tireless effort and very conceptualizing this, having this virtual congress and making all effort to make it possible. I extend on behalf of Eastern Hematoid Group thanks to all of you who have really contributed to making this a virtual congress really successful. With this, I again thanks all of you. It's over to organizer.
Yes, thank you, Dr. Jena, and all the faculties. And for the last 2 days, average there is a 300 to 350 people have been watching us. And during our international speaker, it rose up to 450 audience. So I think that is very successful. And
Really?
with this, in the month of the February, there will be our BaseCon 2021. In the 3rd week of the February, the 18th and the 19th February, I am welcoming you all in the BaseCon 2021, and our organizing secretary, Dr. Prakash Mandal, and organizing chairperson, Dr. Shantanu Basu. With this, thanks to everybody, and we end here, and thank you very much again.
Good night.
Thank you. Good night.
Thank you very much, sir. Good night.
Good night, everybody.
All the best. Very good.
Night, sir.
Very good week. It's really very, very interesting that it's very hugely attended, well successful, well educated, well done.
Good night, sir.
Good night.